Good morning, everyone. It's a lovely Sunday morning today in India, and we present FEMAS 2.0 Fertility Enhancement and Minimal Access Surgery one-day workshop dated 11th October 2020. I'm your host and the course coordinator, Dr. Niranjan Chavan from Mumbai, professor at Sion Hospital. And my theme and our theme of today is endoscopy for all, endoscopy for every gynecologist. This program is brought to you by an educational initiative by first time in India, Jectocos, Lipo, Suspension, Oaknet Healthcare, and on the platform of TOG, that is Times of Gynecology, Science Integra. It's an honor and privilege today that we start with this FEMAS 2.0 workshop, and we have with us none other than our chief guest, Professor Chitranjan Narhari Purandare sir. He is the president of FIGO, president of FOXY 2009, dean of Indian College of Obstetricians, editor emeritus of the Journal of FOXY. He is the professor emeritus of National Research OBGYN Institute, Moscow, and he has got many memberships of various societies spread all over India. FOXY bestowed with him the Lifetime Achievement Award in 2017 and is attached to hospitals in the Mumbai district. He has his own technique, that is the Purandare's modified radical hysterectomy operation, and I have been a witness to it at the FIGO conference in 2000 at Washington, D.C. He has an extensive experience in the field of gynae-oncology, vaginal surgery, and he's represented India on the FIGO Executive Board. I present to you Dr. Chitranjan Narhari Purandare sir. Sir, I request you to please inspire today's FEMAS workshop with your 2 lines.
Thank you, Niranjan, for the generous introduction. It's indeed a great pleasure to be here at this FEMAS conference, and it's nice to see contribution from all over the world for this whole day Congress. And it's a galaxy of people from the top people from all over the world contributing to this conference. Niranjan, I compliment you for getting everybody in on a platform like this. It's not easy at different times, and especially on a Sunday, to get anybody especially from outside India, to come for webinars and so on. We are used to in India talking on Sundays, but it's not easy to get people from abroad to speak on Sundays, and I compliment you for that. We have really the top people in endoscopic surgery as well as minimal access surgery, and I can see from the program various people who are there, right from seniors like Dr. Saraugi and the endoscopy people as well. So I'm sure you will have a great time a whole day watching all the videos. Just talks is one thing, but actually seeing surgeries on video is a different ball game, where people can learn much better than the slide presentations, where you can't really understand and go and really duplicate the work that somebody else shows you in trying that out. So congratulations again, and I wish you all the very best for this conference. And I see Shanta joining in there as the president-elect of FOXY, and the 1 year ahead also President-elect Rishikesh Pai being there. And the guest of honor, Adi, my very close friend, and we have worked together in the FOXY and the journal for many years, joining in, and he himself has been a great endoscopic surgeon, so you will have a good input from him as the guest of honor. So again, congratulations and all the very best to you for the conference.
Thank you, sir. It is an honor that you have being there present today. And thank you so much, sir. It's a privilege and honor that you have been here with us as a chief guest. Now I welcome our guest of honor, Dr. Adi Dastoor. Adi Dastoor, sir, who doesn't know, but it is my duty to introduce him. Sir is a professor emeritus and unit head of Nauroji Wadia Maternity Hospital at St. GS Medical College, where I was a student 35 years back when I joined MBBS. He is also attached and other hospitals like the Parsi General Hospital, the Bhatia Hospital, and he was also the dean of Wadia Maternity Hospital. Presently, he is at the Bridge Candy Hospital in Mumbai, a founder fellow, former governing council member of ICOG, past president of MOGS. He is the past president of IAGE, the dean of Indian College of Medical Ultrasound, and he was also the senior vice president of the FOXI in 1994-95. He was also the chairman of the FOXI of the Medical Nomenclature Norms Research Records Committee, and he was also the governing council and the permanent examination committee member of CPS, past president of ultrasound in medicine and biology, past president of CPS. Sir, apart from these honors which you have, sir, I know you personally. You're a great teacher, a very good singer, and an endoscopist par excellence, where I recollect when you used to be there working with Dr. Nargesh Motashaw, and as a secretary of IAG, I have seen that you have also performed the laparoscopic tubal ligations during the government of Maharashtra times in 1970s. I hand over the mic to Adi Dastoor, sir, our guest of honor, to please share his views and inspire us. Thank you, sir.
Thank you, Niranjan, for those kind words as usual. It's good to have a fan in the president's chair so we can talk good things about you. It's my singular pleasure and a proud privilege today to be here amongst you all as the guest of honor for the FEMAS workshop number 2, and to share this space with my esteemed friends, Dr. C.N. Purandare, the FIGO president, who we go back many, many, many years, and Shanta Kumari, who's again a close friend of mine, FOXI president, who's incoming. With an international faculty, which is brilliant, absolutely. That's good choice, Niranjan. And the national faculty also is equally brilliant. So you have a huge faculty, which is excellent for them to demonstrate the FEMA. The august audience that is engaging digitally today on a lovely Sunday morning. For once, it's not raining. The sun is shining today morning. Specially ordered for Niranjan. Now, this series of workshops for FEMA have been conceptualized by Professor Niranjan Chauhan to upgrade the knowledge of the common gynecologist who in his normal curriculum doesn't have the endoscopy option to study and to take further. So these are very important sessions for them to practice on the workshops and to imbibe from them. The theme of the workshop and the theme of Niranjan is endoscopy for all gynecologists, which I think is a brilliant idea because I don't see it as a super specialty now. Vaginal surgery, abdominal surgery has shrunk, and endoscopic surgery has become the lead. And therefore, but you have to know vaginal surgery, you have to know abdominal surgery to do endoscopic surgery, laser surgery, because you're not palpating, you're not feeling tissues. If you felt them before, you have a better idea and sense of how to go about your duties in a safe manner. Now, amidst the COVID pandemic, Niranjan has brought us together to learn, imbibe, and disseminate the knowledge worldwide. And we have speakers today from India, from UK, from Singapore, from Indonesia to participate in this workshop. Now, the workshop is scheduled on the 11th of October today, which also happens to be coinciding with the commemorating of the occasion of the World International Day of the Girl Child for the betterment of women and for the girl child. So we welcome that also today with us. We wish you all a very happy learning experience. And I'm sure at the end of the workshop, you will all be able to be in a much better position to do endoscopy and to go ahead in your future. Now, before I end, I've just, as usual, thought of a special song for Niranjan because Niranjan is a very good surgeon and he's got this little female robot. And this female robot is extremely close to him and fond of him, and they never operate without each other. So I chose a song of Elvis Presley called Pledging My Love. And I'm going to sing a couple of verses of this song for you from Niranjan to the robot, saying how they work together. So you also, all of you, please work together like Niranjan with your robots so to get the maximum out of your fertility enhancement, minimally invasive surgery. Here goes. Forever, my robot, your love will be true. Always and forever, I'll operate with you. Just promise me, robot, your love in return. May this laser in my scope, dear, forever burn. Forever we'll operate for the rest of our days. I'll never part from you or your operating way. Just promise me, robot, your love in return. May this laser in my scope, dear, forever burn. Take it, Niranjan. All the best for your workshop. Thank you.
So that was amazing. Wonderful song from Elvis Presley. So your words are always inspiring. And I think IAG is benefited by seeing all of you here today. Thank you for that wonderful, inspiring word, sir. Thank you so much. Now I call upon Dr. Shanta Kumari. Dr. Shanta Kumari is the Iron Lady of India, I can say, President-elect of Foxy. She is presently practicing at Yashoda Hospital, Hyderabad. And we all know for her hospitality at HICC, Novotel Hyderabad, where she has done for last 15 years, innumerable conferences, hosted them, ranging from FIGO, Foxy, IAG, ISPAT, ISAR, and various wonderful programs she has done. She also has many awards to her credit, namely the FRCOG from UK, FRCPI from Ireland, and presently she is representing India at the FIGO Executive Board for the campaign to eliminate violence against women. She was a vice president of Foxy in 2013, secretary TCOGS 2015-19, IAGE managing committee member 2015 to 19, and she has also been awarded various Foxy awards, namely the CL Javeri Award at the 42nd AICOG, long back at 1998. It's my honor and privilege to invite and call upon Dr. S. Shanta Kumari Madam to be the guest of honor today and inspire with her two lines. Welcome, madam.
Thank you very much. Good morning, everyone. It's indeed been a beautiful Sunday. Dr. Adi Dastur sir, we loved your song. It was a beautiful beginning for a beautiful day today. It's indeed a pleasure to be here today on the platform where I have some of my favorites, CN Purandare sir as chief guest and Adi Dastur sir as a guest of honor. Sir, I am really privileged to be with you all, and I think what more can I ask? And of course, and I really like the concept, yes, endoscopy for all. Endoscopy is nothing it's not a rocket science. It has now become the most important skill which every gynecologist needs to have. You need not be worried or scared that it is something only the blue-eyed endoscopic surgeons of India are going to do. We have some fantastic endoscopy surgeons. We have some fantastic infertility specialists in our country. But the rest of us can be happy when we are simple endoscopic surgeons to take care of the millions of women in the country. So I think this is a wonderful opportunity, Niranjan. Congratulations to you and the team for doing this lovely workshop. And as sir has told, you have got some excellent faculty in place. And I'm sure by watching all these programs, every gynecologist will decide that they are going to do all their simple endoscopy, the day-to-day endoscopic surgery. We need not do something out of the world. Simple things we can do. We need not take any general surgeon or anyone to do our cases, and that is the way forward. But that doesn't mean just because you have a scope, all the uteruses are going to be out. I'm sure that all of us are going to do, I think, as CN sir has shown, radical hysterectomy. So radical thought before doing an hysterectomy is needed with an endoscope. So that should be the teaching. So learn your scopy, but don't use it unless needed. So all the best, Niranjan and the whole team. And I'm sure Rishikesh is going to talk about infertility and endoscopy, and you've got fantastic other people today. All the best to all the delegates for a lovely Sunday learning.
Thank you, Shanta.
Thank you. Thank you, Dr. Shanta. Thank you, Dr. Chitranjan sir. Thank you, Adi Dastur, to inspire all of us with your inspiring and encouraging words. Now, we have been planning this FEMAS program since a long time, and today's programs fall on the special day, that is 11th October. It is celebrated by WHO and all of us as the International Day of the Girl Child. The theme for this year is My Voice, Our Equal Future, which amplifies voices and the rights of girls everywhere, reimagines a better world inspired and led by adolescent girls as part of the global generation equality movement. Girls worldwide are demanding a life free from gender-based violence, access to health, skills, recognition, and investment as leaders of social change. So let's see a 2-minute video made by Miss Nikita Borkar of Srimati Sulochana Devi Singhania School, Thane, who portrays the voice of countless girls. Let's see the video. That was Nitika Borkar's video. And I would like to say Nitika means the one who leads, the one who inspires. What a wonderful video she has made this. And it's really important that both the parents, especially fathers, have a major role in promoting a gender equality and education. So let's pledge today and take this pledge for our patients and promote equal rights to a girl child, the first being education. Now I hand over the mic to Dr. Rishikesh Pai to start his lecture. Thank you so much.
Dr. Pai, we have Archana
Yeah.
Verma.
Can you hear me? Can you hear me?
Yes,
sir. We have Dr. Archana Verma who will introduce you. If you could just give a minute.
Okay.
Very good morning, and I'm really privileged to be here on this.
So we have Dr. Archana Verma, who is the Vice President-elect FOXY for the year 21. She's an associate member of RCOG, past president Ghaziabad Obs and Gynae Society, among many other accolades. And she's very passionate about creating awareness on women's health. Dr. Archana Verma, I request you to kindly introduce the speaker, Dr. Rishikesh Pai.
Very good morning to everybody, and it's really a proud privilege to introduce the king of infertility and endoscopy as such, and my full respect to C.N. Purandare sir, who he is like our main, like is a very divine and godly figure for us, and Dr. Adi and Shanta ma'am, and Dr. Today girl child, and we are really Dr. Niranjan. It is a great honor that UN got the Nobel Prize, and this UN theme this year is gender equality, and we will be following your as said by you. We'll be following the pledge. Dr. Rishikesh Pai, we all know the most learned and most humble person of the FOXY. He is a MD, FRCOG, FCPS, and FICOG, and at present he is leading Bloom IVF group, and innumerable all over the India, and he's an administrator of the very special FOXY Manyata initiative, and he has been he's the president-elect of the FOXY, and we will be looking more of all the powerful work for girl child also, and endoscopy and infertility, and he is a almost international and national university professor, and his main interest in infertility, endoscopy, IVF, ICSI, and major achievements are he's got this FRCOG. He received at London, UK, with the most esteemed fellowships, and he was past Secretary General, and we saw the FOXY growing leaf by leaps and bound, and no organization can work without Dr. Pai's support, and he has been a past president, ISAR, IAG, and MOX, and he has been awarded more than 30 awards, and he's mainly in the research, and also the prestigious Lifetime Achievement Award for Outstanding in Research by ISSRF, and awarded by FOXY also, Indian Medical Association, and he has written many books and numerous research publication. We are so much privileged to listen to Dr. Pai sir. Please, you are welcome.
Thank you. I would like to really be grateful to the organizers, especially Niranjan, Dr. Niranjan Chavan, who is a very dynamic person. So he is, and I would like to pay my respects to my senior, Dr. C.N. Purandare, our FIGO president. We still call him FIGO president for him. For us, he is president for life. Dr. Adi Dastur, who has been a great teacher of mine as well, has been the past FOXY I was vice president as well as the editor of the journal. Dr. Shanta Kumari, my younger sister, who is going to be the next president of FOXY. And Archana Verma also, I would call her my younger sister also. She'll be the next vice president. So I'm very happy to share my thought. I am very passionate about hysteroscopy. I've been doing it for many, many years. And, when I was thinking about IIG and General Foxy, it's like literature and knowledge. So literature represents knowledge and action represents practice. So endoscopic surgeons are action, and majority of us who are the general obstetric gynecologists have probably knowledge. And books and movies are like apples and oranges. They both are fruit but taste completely different. That's what Stephen King said. If you look at hysteroscopy, what is its role today? It's an association with uh, laparoscopy. Hysteroscopy can be used to confirm explain unexplained infertility. It can be used to treat pathologies that can lead to infertility, and it can be used prior to IVF to enhance outcomes. So if you look at the, of course, diagnosis is very important, and this is a very old paper in Minerva 2001, which they concluded that diagnostic hysteroscopy is a very important method for investigating the reasons for infertility in a couple. As much as 15% of couples have got uterine factor, and so they feel that it should combine it in association with uh, uh, laparoscopy. And this is another paper where they showed that in approximately 10% of cases, pathology can be found in patients with normal HSG or ultrasound of the uterus. So even if the ultrasound shows normality, you may still find abnormalities. You can see a small polyp here just blocking the the internal loss at the internal fallopian tube at the junction. So I had a long series, huge number of cases. I used to do hysteroscopy in almost all, since being a lecturer in Nair Hospital way back in 1989. I started doing hysteroscopy. Before that, I was exposed to hysteroscopy in KEM when I was Dr. N.D. Motasha's houseman and registrar for subsequently of Dr. Joglekar in 1984-85. That's what the time when first hysteroscopy workshop was done in our country in KEM Hospital. And since then, I have done more than 9,000 plus cases. And as you can see here, that our series showed 14.7% abnormality rate. We could pick up 14.7% abnormalities when we did routine hysteroscopy in infertile couples. You can do surgery for various indications, such as you can do it for diagnostic purpose as well as for operative purpose, and I will go through each indication separately. But it's very important. So what is the most important thing in hysteroscopic surgery? You must know how the uterus is made, and is so accurate ultrasound measurement of the uterus is the bedrock of hysteroscopic surgery. And I would like to thank Niranjan, because in the last few 15 days, say, I have been reading about hysteroscopy. So I have actually learned a lot about hysteroscopy in the last 15 days. After doing 9,000 plus cases in my career, now I am understanding what I have been actually doing. And the most important thing, if you want to be a successful hysteroscopic surgeon, is to understand the structure of the uterus. So transvaginal imaging is very important. And this lovely paper was there. So how do you actually measure the uterus, uterine length from the external cervix to the fundus in the sagittal plane? If the angle between the cervical canal and the uterine corpus was more than 30 degrees, the cervix and the corpus is measured separately and the sum is taken. So that's how you measure the length of the uterus in an ultrasound. The AP diameter is measured in the sagittal plane from the anterior serosa to the posterior serosa at the point at which the uterus appeared at its thickest and perpendicular to the endometrium. That's how you measure the thickness of the uterus. And the width is measured by from right to the left side of the uterine corpus in the transverse plane, where the width of the corpus appears at its thickest. So the mean uterine size is about 8.6 centimeters by 4.9 centimeters by 4 centimeters. And the overall size is 7 by 4 by 3 in nulliparous uteri and 9 by 5 by 4 in a multiparous. This is a very important parameters. And I would like to share some very exciting thought processes with you. This is a paper by Vargatz in 2013, and they measured the uterine length by width ratio. And you'll be surprised that this length, uterine by length by width ratio, is known as the golden ratio. This is the ratio of life. If you have a face where the length by width ratio is 1.618, you are the most beautiful person in the world. This is the Mona Lisa's face. And this ratio is seen in the heart, in the face, and even in the sunflower seed. This is based on the Fibonacci sequence. So what is Fibonacci sequence? You can see this digits 0, 1, 1, 2, 3, 5, 8, 13, 21. In this, each number is made up of the sum of the previous two numbers. So if you can see here, 1 plus 2 is 3, 2 plus 3 is 5. And if you divide the previous number by the next number, the ratio is the golden ratio of life. That is 1.618. And the uterine ratio of the length divided by width is the golden ratio. This is a golden ratio which is even in the uterus, and this beautiful paper has shown that the uterine ratio is also the golden ratio. So there was a confusion of the classification of the uterus, and the first time in 2013 the ESHRI, the European Society for Human Reproduction and Embryology, and the European Society for Gynecological Endoscopy, EHG, they came together and they formed a working group, and this group was called CONUTA, Congenital Uterine Anomaly Group, and they classified. So you remember that the size is very important in life, the uterine size, the uterine ratio, and based on that, this classification has no value if you don't know the size of the uterus. So remember, the size is important by 3D ultrasound, and the classification is based on U0, that is normal uterus. You can see here that it's a normal uterus. U1 is dimorphic uterus, that is a small uterus. It can be of two types. A T-shaped uterus, cavity is small, but the normal ratio of the fundus to the cervix is 2:1. While the infantile uterus is the same as the T-shaped, cavity is small, but the ratio of the fundus to the cervix is reversed. So cervix is 2 and the fundus is 1. So this is based on the third is a U2 uterus. So what is a U2 uterus? This is known as a septate uterus. So how do you make out the septum? The classification group decided that the only way to make out whether uterus is got a septum or not is, first of all, look at the thickness of the wall of the uterus. So the wall of the uterus thickness is used as a reference point. So if you do an ultrasound, you take the thickness, and if the thickness of the wall of the uterus is more than 50%, then we classify it as a septate uterus. Remember, if so, the U3 is a bicornate uterus. So the notch has to be there, fundal notch. So how big should be the fundal notch? If it is more than 50% of the thickness of the wall of the uterus, then you can call it a bicornate uterus based on that complete and bicornate. Then the U4 is a hemiuterus, where there is one horn is fully developed and another horn is there. And in this, or it can be only single hemi without rudimentary cavity on the other side. So hysteroscopy you can do on a normal uterus, you can do on a T-shaped infantile uterus, you can do on a septate uterus and cut the septum. You can do it on a bicornate uterus. There's sometimes bicornate uterus with an additional septum. So you can have a septum that you can cut with the hysteroscope. And then you can do a hemiuterus, or you can do a hysteroscope just to confirm the diagnosis. Here you need to also do a laparoscope to remove the horn, rudimentary cavity horn, and then of course is a aplastic uterus. So this is very important classification. You can see here the normal uterus. This is the 3D ultrasound picture. This is a dimorphic uterus. You can see here, and this is again the dysmorphic uterus. This is a septate uterus. You can see the complete septum and partial, and this is a bicornate uterus. So the notch is very important, and notch thickness is very important. And this is the lovely, again, another way in which to look at so you have this ASRM guideline classification where you have, in a normal uterus, the depth is less than 1 centimeter. So this is the depth from the fundus till the protrusion is, if it is less than 1 centimeter, and the angle, this is the angle, is more than 90 degrees, then it is either a normal uterus or maybe a slightly arcuate uterus. You don't touch this kind of uterus. In a septate uterus, the depth is more than 1 point. So the distance between the serosa and the protrusion is more than 1.5 to classified as a septate uterus, and the angle, this angle is less than 90 degrees. And in a bicornate uterus, the depth indentation should be more than 1 centimeter. So this is another way of diagnosing. So diagnosis is very important for classification. So once you diagnose, it is very easy. You can just cut it. We can normally, in this video, I was crazy about Versa point, but unfortunately Versa point, which is a superb, the best bipolar is the Versa point, but it is not available anymore. I have got 5 machines in all over our IVF centers. I used to do a lot of surgery myself. I used to cut it out, but later on I started cutting with the scissor and only coagulating with the Versa point, because I realized that by cutting directly with the Versa point, I was actually creating more amount of fibrosis. So hysteroscopic metroplasty can be done by Versa point or by resectoscope. You can have a bipolar or a unipolar resectoscope, and you can also have you can do lateral metroplasty if it's a T-shaped uterus. So based on your dimension and classification, now it's very easy. So very important. See, our people are just putting the hysteroscope and cutting the uterus. Not correct. You can get litigated and sued for it. You have to establish the T-shaped uterus based on the European Society classification by doing a 3D ultrasound, by showing that the thickness of the lateral wall is there, and you have to justify your surgery. Otherwise, if you have an embolism, patient dies on table, it goes to court, they'll say, why did you do? You'll say, I did it for a T-shaped uterus. They said, where is the proof? Show us why you classified it as a T-shaped uterus. That is why the European classification is very important. So for all your hysteroscopic surgeries from now on, you must do a proper 3D ultrasound, classify your uterus structurally, and then decide your treatment. Don't do an arbitrary treatment, because you will land up in litigation. Then you can, for a smaller uterus, like an infantile uterus, you can do multiple vertical furrows, 4 millimeter deep furrows. Using a resectoscope can be done. 7 furrows from fundus to the cervix are done to open out the uterine cavity. What is the ASRM practice guideline saying? Should we really cut the septum? So what they have said, that it is recommended that imaging or with hysteroscopy should be used to diagnose uterine septum rather than laparoscopy with hysteroscopy. So now it's understood. You can do a 3D ultrasound or you can do a MRI, and you can easily image the uterus and diagnose it. You don't need a laparoscope to diagnose a bicornuate uterus. In a patient with infertility, prior pregnancy loss or poor obstetrical outcome, it is reasonable to consider septum incision. In a patient without infertility or prior pregnancy loss, it may be reasonable to consider septum incision following counseling. You can say that, okay, afterwards you may have a pregnancy loss, you may cause. So if we have put in a hysteroscope and we really come across a septum, we might as well cut it. So this is the ASRM recommendation, and this is one of the new papers that has come on T-shaped uterus. So after the 2013 H3 classification, a lot of papers have started coming out on T-shaped uterus, etc. Because now, using the classification, we can properly classify the patient. You can't just do blind cutting of the lateral metroplasty, which I see being done right, left, and center. 100%. If I am a lawyer, I'll sue you and I'll get a lot of money out of you. So if you have to be very careful and not do the lateral metroplasty unless you prove that it is a T-shaped uterus on prior ultrasound. I'm repeating this again and again for all the hysteroscopic surgeons who blindly do lateral metroplasty. But this paper has shown definite improvement in outcomes of clinical pregnancy and live birth rate with lateral metroplasty in a properly selected case of T-shaped uterus. You can also do hysteroscopic surgery for fibroids. You can see here the classification. Again, the beautiful FIGO classification has been done with total pedunculated fibroid 0, submucous fibroid with 50% protrusion inside the cavity 1, 50% outside cavity 2, and there are certain fibroids which are 2 to 5, means they extend from the uterine cavity and go till the serosa. This is known as a 2 to 5 fibroid. So 0, 1 can be easily removed by hysteroscopy. 2 can also be removed. I've seen great doctors like Dr. Hamu. He can remove a 2 to 5 fibroid also by the hysteroscope route, but it is very dangerous for non-skilled people. So till 2 you can remove. 2 to 5, it is better to remove it by the laparoscopic route. But there are certain hysteroscopic surgeons which would remove a 2 to 5 also through the vaginal route. But they are great surgeons, and we should not be. We should be average surgeons. We should do average surgery. Average, safe surgery is very important to do in life, not to do anything dramatic. I always keep on telling my juniors, if there is a difficult case, send it to a senior person or send it to your competitor. You don't do it yourself. It is, the philosophy of life is not to touch difficult cases, because it can land you in major complications once in a blue moon. So remember, submucous cavity distorting, large intramural non-cavity distorting fibroids are removed in infertile cases. And this is a lovely paper by Elizabeth Pritz in 2009. She's actually standing for the election of the AAGL this year, and she had concluded that fertility outcomes are decreased in women with submucosal fibroids, and removal seems to confer benefit. So this is understood and accepted that submucous fibroids should be removed. with the development of hysteroscopic technique, resection of type 0, I told you type 0 and 1 myomas can be easily removed by the hysteroscopy route, but a type 2 myoma also can be removed. If you want to convert a type 2 myoma into a type 1, you can give them GnRH agonist for 1 to 2 months, reduce the size of the fibroid, and you can take out the fibroid by the hysteroscopic route also. There are certain principles that are to be followed, so you can easily remove adenomatous and myomatous polyps. You may or may not give pre-op, post-op GnRH analogs. Mechanical removal, I like to do a small fibroids, I like to remove with scissors and myoma screw. There's a beautiful hysteroscopic myoma screw that is also available. So if there's a submucosal fibroid, you can just knock it out from the base, from the pedicle, and putting a myoma screw, you can actually pull out the fibroid through the cervix. You can use a resectoscope. It can be bipolar, unipolar. If you have a Versa point, it is the best bipolar resectoscope I have come across in my life, but it is very costly machine and not easily available in India, unfortunately. You can use a morcellator also, and you can there is a new it's an old technique. It's called Mazone cold knife technique. When I went to Greece to see a lot of, they are crazy about hysteroscopy in the country of Greece. The maximum hysteroscopy in the world is done in Greece, and they do all these Mazone cold knife technique where they can dislodge the fibroid and they can actually take it out by the vaginal route. So this is a 7-year experience of Dr. Tuifekchiva from Sofia, and he has removed a lot of submucous fibroid by resectoscope without any problem. This another technique which has been beautifully described by Murakami. And what he says is the strategy for grade 2 myoma is first scrape and vaporize the intrauterine dome of the myoma until top of the myoma is even with the wall of the cavity. Next, the remnant intramural node is squeezed by uterine contractions induced by PGF2 alpha. You can use an injection of PGF2 alpha. As I told you, you can use a Mazone cold knife, and it's a very big, it's a tough hysteroscope with a protrusion, and you can actually dislodge the intramural part of the fibroid and actually core it out and then remove it by the submucous blade. This is a Cochrane review of 2015 by Bostiels, which he said that a large benefit with the hysteroscopic removal of submucous fibroids for improving the chance of clinical pregnancy in women with otherwise unexplained subfertility cannot be excluded. So he had said, but there's a second Bostiels review came in 2018 where he said that the available low quality evidence suggests that the hysteroscopic removal of endometrial polyps suspected on ultrasound in women prior to IVF may improve the clinical pregnancy rate compared to simple diagnostic hysteroscopy. Another aspect of hysteroscopy is so we have the three main players. One is the septum, second is the fibroid, and third is the intrauterine adhesions. And these are the four important messages I would like to share with you of the EAGL. So the EAGL committee in 2017 came out with guidelines on intrauterine adhesions. So what they said is that hysteroscopy is the most accurate method to diagnose adhesions. If available, HHG and sonohistographic are reasonable alternatives. MRI can be used. Intrauterine adhesion should be classified, and various classifications. There are 7 classification systems to classify adhesion, but this is a beautiful system devised by the AFS in 1988. So based on the extent of cavity involved, type of adhesion, and menstrual pattern, you can have mild, moderate, or severe based on you give grading and you do point system. 1 to 4 is mild, 5 to 8 is moderate. So you can see this is a mild, this is a cavity with a small, this thing is a mild one, this is a moderate one, the cavity is partially obliterated, and this is a very severe one, full cavity is obliterated by the adhesion. So what are the guidelines which have been proposed by AHL? The risk for de novo. So how do you prevent adhesion formation in the first place? So one of the problems is hysteroscopic surgery, and it is very important that you must do it carefully. Polypectomy, myomectomy. The method of pathology removal also may impact the adhesion. The risk appears to be greater with electrosurgery. So you must use more of surgery, more of scissors, more of forceps, more of cold knife technique rather than resectoscope, because you will technically remove it, but you will create adhesions afterwards. Application of adhesion barriers also may be used. So the hysteroscopic lysis of adhesion should be by direct vision. So adhesive lysis, once you come to treatment, adhesive lysis should be done directly. Adjunct interventions to aid adhesive lysis can be done. You can, in severe adhesion, you can use an ultrasound probe to guide your first guide of the hysteroscope, fluoroscopy, laparoscopy, and in the presence of extensive and dense adhesions, treatment should be performed by an expert hysteroscopist with at least one of the method described. So this is how you would do the intrauterine adhesion prevention, and this is a diagnosis how you can diagnose adhesion. This is a cavity severely. You can see this is a grade severe adhesion based on American Society classification. Totally obliteration. You can see one small cavity here through which if you go in and you can create the adhesion. So what are the instructions for guidelines? How do you so the AGL instructions are that post adhesiolisis you can do adhesiolisis with scissors, resectoscope, bipolar, unipolar resectoscope. Post adhesiolisis, you should put in an IUD, but not a copper IUD. You may use a stent or a catheter. Solid barrier reduces infections. Hence, antibiotics may reduce adhesions. Inert lipase loop is the best use. E plus P or P means estrogen progesterone should be given. Medication should be given to improve vascular flow. Stem cell treatment should be a good adjuvant. Early follow-up assessment. So you should do a second look hysteroscopy after 2 months. I normally do second look hysteroscopy, and that can be an office hysteroscopy. You don't have to. You should have a small hysteroscope you can actually do. And etiology is also very important. Intrauterine surgical trauma is better tackled than uterine artery embolization or uterine suture. So adhesions that are formed by uterine artery embolization, or if you do Bielan sutures and all that, then adhesions formed, they are more difficult to tackle than other adhesions. And
so we just have one more minute to go.
I've been given 25 minutes now in my say. How many minutes are over? I started what time?
So you started around 10:20, sir. We are right now at 10:47.
Okay. So you can use stem cells to do the various treatments. So you can do stem cell delivery by spiral arterial vessels or subendothelial. You have a technique which I'll not give you the advice of the techniques this some other time. So you can also tackle hydrosalping using what is known as Assure implant. So you can actually block. You can see here you can block the cavity of the. So instead of going laparoscopically, you can go hysteroscopically and block the cavity. So you can do that technique as well, or you can do tubal cannulation technique. I'll just show you a tubal cannulation video. So if there are so this is a tubal cannulation video I would like to show you. So that's why I think I'll end my talk with the video. So in the tubal cannulation video, you have the outer cannula, which you go through the operative scope and you lodge it into the cornua. Following that, you have the inner. So this is a coaxial cannula. So you have the inner cannula, which goes into the cornua. It's a guide cannula. You can't go through and through. If you try to cannulate the whole tube with the guide cannula, you will have a problem and you may perforate. And after that, the guide cannula goes a little bit into the cornua. You slide the third tube, and this is very important. So this set has got a third plastic tube. You can see now this is a third tube which you slide over the guide cannula, and you remove the cannula and then thread the tube with this third cannula, and then you can use your methylene blue to flush the cavity. So this is how you actually would tackle and overcome the cavity. And a lot of the advantages are there of the hysteroscopic FTR, which it can be done as a primary procedure. The tubocorneal junction can be directly visualized, can rule out tubal obstruction due to spasm. You can do concomitant intrauterine pathology can be tackled, can be combined with laparoscopic surgery for evaluating and treating distal tubal disease, has no radiation exposure risk, falls within the purview of gynecological surgeons. And this is the last, there's one new paper that has come by our own Dr. Kamath in Cochrane Review 2019. And in which he has concluded that in women undergoing IVF, there is low quality evidence, including all of the studies reporting these outcomes, suggest that performing a screening hysteroscopy before IVF may increase live births and clinical pregnancy rates. However, pooled results from the only 2 trials with a low risk of bias did not show a benefit of screening hysteroscopy before IVF. So there is still the jury is out as whether we should do routine hysteroscopy prior to IVF. There are certain meta-analysis that had come in the past saying that if you have a patient with 2 previous failed IVF and you do a hysteroscopy, it will give improvement in outcome. But now the new meta-analysis have shown that the outcome doesn't really make a difference. So we need to do more studies to find out what will be the outcome in the future, whether we should use hysteroscopy routinely prior to IVF. In our group, we use it before a frozen embryo transfer, especially in patients with repeated failures. Thank you very much for a patient hearing.
Dr. Pai, thank you. It was very nice and most elaborate, and we all were listening to a master's strokes almost, and hysteroscopy, operability, and 3D ultrasound correlation is really the best tip you gave for everybody. And thank you very much, sir.
Thank you, madam.
Thank you, Dr. Rishikesh. That was a wonderful presentation I heard. I think you have been busy in IVF, but really this Corona pandemic times have made us read through all these books, and it was amazing to see the 9,000 cases series and 0.14% of your study which you have given today, and taken a lot of pains to go through all the guidelines. Thank you, Dr. Rishikesh, for you to give us your valuable time. Thank you, Archana Verma. Right now there are no questions, but as soon as they come, we will take over because there is always a lag of 5 minutes. Now we go ahead with the next lecture. I call upon Dr. Rohan Krishna Kumar.
Very good morning,
Dr.
everybody.
Dr. Rohan is a consulting obstetrician and gynecologist, an endoscopic surgeon at JK Women's Hospital in Dombivli, Mumbai. He is an IAG committee member, a fellow in gynec oncology, and through USA. Dr. Rohan, may I request you to kindly go ahead and introduce Dr. Niranjan.
Yeah, very good morning. Just one clarification, there's no IAG committee member in that. I think that's a misprint. So it's great to have such a wonderful session organized by Niranjan Chavan sir, such an educative session on a Sunday with such great attendance and great speakers. So today I have been given one of the magnanimous tasks of introducing one of the most famous person nowadays. So it gives me great pleasure to introduce Dr. Niranjan Chavan sir. He is the professor and unit chief of in Stein Hospital and LTMGH Medical College. He's the joint treasurer elect of FOXI, national coordinator for FOXI medical disorders.
Yeah. Thank you, Rohan. Thank you for those two lines.
The introduction for sir can go on as big as a lecture. So without wasting further time and going towards sir's lecture, I would request him to talk on this beautiful topic that he has selected today.
Yes, I think today all the talks are very different, and I appreciate Dr. Rishikesh Pai who has talked on hysteroscopy. So I thought I'll talk something related to sonography and laparoscopy, because sonography is one arm, laparoscopy, endoscopy is another arm. And when both of them join together, it's an amazing phenomena which we go through. So I want to share with you my slides now. I hope you can see. I'm going to skip few. This is my first. Sonologist and endoscopist are the two sides of a coin, and I'm going to talk something of ovarian cystectomy simplified. Already, I'm going to skip some 15 slides in the beginning, and then as due to paucity of time, I'm directly going to go on sonography. So when we deal with a patient of a cyst, usually it is a girl or it is in a reproductive age woman or a menopausal woman, we have to understand that most of us do sonography, and I wanted to take all of you through the journey of sonography and then the role of endoscopist. It's not that just because you are an endoscopist that you have to put a scope inside. It is not that way all the time. There are certain criteria which you have to consider. So when you have a adnexal mass which is there, you have to differentiate whether it is benign on one side or malignant on another side, and whether the size is less than 5 or more than 6 centimeters. Now, whether you would like to do a transabdominal or a transvaginal or a transrectal sonography. So that is what is the first aim which an endoscopist has to understand before he puts in a scope. So bimanual examination with per abdomen and PV examination and an ultrasound will equip and will enhance your imagination. It will take you in a new dimension, and it will help you to guide and anticipate what problems can come. Because even any sonography can come, you have to take it with a pinch of salt. So let us go through a simple cyst which is there. It is an anechoic area, a small thin walls. There is no internal flow on the Doppler, a posterior acoustic enhancement. That's what you can see with the green arrows. And this is a simple cyst which you don't have to touch at all. It will resolve on its own. Sometimes you get a corpus luteal cyst, and there you can find that there is a ring of fire around it, and it is blue and green are the Doppler studies which you can find. There is a peripheral blood flow, and the size of which is 3 to 4 centimeters. There is plus or minus crenulated appearance with internal echoes which can be there. So this is less common cyst which you can see. But unfortunately, if you have a rupture of a corpus luteal cyst, that's where you put in your laparoscope and it requires a surgical management emergency so that you can take care of that bleeder on the ruptured cyst may cause pain because of the bleeding in the enclosed ovarian cyst cavity. This is how is the picture on the macroscopic level and how you see on an ultrasound. So this will help you to put in a scope when and not. Theca lutein cysts are very less common and they are usually bilateral. This is occurring in those IVF patients where there is an overstimulation of the ovary. It doesn't occur commonly in normal pregnancies, but it is often associated with herediform moles, choriocarcinoma. So all these things you have to keep in the mind, and it can go as large as 30 centimeters. So this is how it looks. The picture on the right hand side will tell you the ultrasound picture of a theca lutein cyst. Well, we have certain cases of PID and we have pain, we have got pus, we have got tubo-ovarian abscesses, genital tuberculosis is very common in our country, and we have 14 to 38% of patients which are hospitalized for PID. So do you put in a scope? Well, in emergency situation, you might have to drain out that abscess rather than just poking it inside. And it is usually done in some of the gynecological care. Now, this is a very big chunk of patients which you get and PCOS, okay? So you don't try to put a scope in a PCOS, but obviously when you have a homogeneous appearance on an ultrasound and you have a chocolate cyst on a cut section, this is what you deal with and put in a scope. Then we have come now to tumors, cystadenomas, mucinous cystadenomas, serous cystadenomas. 10% of them are borderline, 20 to 25% of them are malignant, and they are usually multilocular with papillary components. On microscope, you will find low columnar epithelial with cilia, and that's what we found the Samoma bodies. They are basically the products of degeneration of papillary implants, and it is sometimes associated with fibrosis and may lead to cystadenofibroma. Now I want you to show these pictures. These are wonderful book pictures, and that's how you can see on ultrasound small septae which are there and the cyst which is filled with fluid. And sometimes you can have this solid cut section also there. So on ultrasound you find that serous cystadenoma, a small samoma bodies which is the orange there, and also if you see an MRI, it shows a picture like this. So this is going to equip you when you put in a scope and try to figure out whether it is one side or both the sides. And obviously when you have a mucinous cystadenoma, they are huge. They have a mucin thin material. So you have to be very careful when you are going to take out them, preferably in an endo bag, because if it plasters on, if it spills out, it will plaster the omentum, the lower pelvis, and it will cause problems. They are usually basal nuclei with goblet cells, a thick viscid fluid, and you can find this typically on microscope and the enlarged cyst with multiple septae inside, and that gives you an idea. Obviously, you will have to do an MRI if you want to, and if the patient is affording, you can go. Tumor markers play into a big role. I will come to that also point. Dermoid cyst also is very commonly seen, and you can find that the green arrow, which is hyperechoic component with distal acoustic shadowing, and they are focal or diffuse. And then you have the dermoid mesh, which is seen in an orange arrow, and it represents different tissues within a teratoma. For example, a hair. There are no internal flows on Doppler, and this is the floating fat. You can see the fluid level, and there is also something like a tip of iceberg sign. So I want you to take a journey through sonography. It's not only just because you're an endoscopist, you just have to put in a scope. Try to have that imagination of a sonography, read that report, try to understand what you're dealing with so that the picture is much clearer. And this is an ovarian fibroma which you see. It's totally a fibroid thing which you see, and on gross and microscopic appearance where you can come. And this is an MRI ovarian fibroma which you come across. So basically, when you are trying to do laparoscopy, the aim is to do a minimal blood loss, do an efficient surgery, try to do an endobag as far as possible. Do not burn the ovarian surface. Try to see that the AMH is maintained as far as possible. In cases of infertility, try to peel off the cyst in a total intact manner so that you don't have to keep some remnant, because in a complete surgery can cause recurrences in endometriosis. That is what you have to understand. Try to avoid removal of the ovary unless and until you feel it is a malignant condition like a dysgerminoma, or where the alpha fetoprotein or LDH level is high. You have to be very careful. Sometime it has happened that you have done a laparoscopy for an ovarian cyst and the histopathology comes out that it is malignant. So you are in a very big soup. So you have to understand and all this that there is a recurrence of an ovarian cyst. So proper consent has to be taken. Now I request session to play the videos, but it is very important that before we go for the videos, it's certain deviation which occurs. Pregnancy, where in that case you will have to determine and operate these cases in second trimester. However, unfortunately, you find them in the first trimester, especially with an ovarian torsion. There is no other way but to put a scope in the first trimester, but take proper consent. Try to do a clean laparoscopic surgery, and you have to sometimes use the Hassan's point or even a Palmer's point, a very large ovarian cyst, rather than going from the umbilicus. Sometimes you'll have to go supraumbilical. So, well, when you perform these cystectomies, you have a great reduction of ovarian reserve, serum AMH. So, you have to avoid excessive use of diathermy. And before I go for the take home message, I would like to stop sharing and show a few videos. Session, can you please show those videos? I hope. Thank you. Thank you so much. Well, you can play this video kindly. So this is an ovarian cyst you see. You have to please see that you grasp it properly. You can burn the cyst wall. Be sure that all the other structures are kept away. Once you do that, you have to use a scissor, go in the proper plane, and then cut it so that you can peel it off. Now you have this tadgoda. In Marathi, we call it tadgoda. It's like a water-filled fruit. So you have to avoid it. Try to avoid spilling it. But if it has already been confirmed and proper hemostasis has been achieved, you can take that rest if it is a fluid filled with serous material. But do not do that in a mucinous cyst, because it will cause a lot of peritoneal irritation and also cause adhesions. Following this surgery, you have to use an adhesion prevention barrier method. And then once you have taken out the cyst, you can just take it out properly without any spillage. Now here there are some bleeders which are there, and I'm cauterizing it. And I will just take 2 minutes more so that we can hand over the mic to the another moderator. Well, this is nicely cut now, and then we can take. Session, can we go to the next video now? Yeah, this is an, please go ahead, ovarian endometrioma. You can see here. Now I have actually used petricin here, and once we have done that, it will basically achieve proper hemostasis. Then you take hold of the cyst wall and then peel it off from the surface. You'll have to do traction, counter traction, and that's how you pull it out. Cut the cyst, and that's how you're going to pull it out. Remember, the whole tissue is now blanched, and I'm trying to pull it out with a traction and counter traction. Again, I give a cut to open it up. Session, you can just forward it. Support, please forward it. Yes, yes, yes. Now I got the proper plane. Yes. And now with traction, counter traction, I'm going to peel it off. So mind you, you need to park this away and then take it from the second port, a 5 or 10 millimeters port, so that you can just keep it parked that way. Can we have the next video now? This is the para-ovarian cyst which I found in a girl. A right para-ovarian cyst diagnosed on an ultrasound. Yes, please go ahead. So I use the simple bipolar. You do not require a harmonic or you do not require a laser for this. Remember, a simple bipolar can just open up. There are going to be bleeders. It is going to be magnified 10x. Not to worry. Just catch hold of those bleeders. Use, proper cautery. Just small bursts of those cautery. Coagulation mode is enough. You can use the foot pad or you can use basically small burst, and that's how you try to, with traction, counter traction, we just go ahead and do it. So we go and have patience. Try to avoid opening or rupturing it as far as possible, and with a slide and slight traction, counter traction, you separate it out totally. So this is what we are going to teach. Endoscopy for all, endoscopy for every gynecologist. Start with small cases, 3 centimeter, 5 centimeter above, 7, 8 centimeters. Go on doing it. And then once you are totally peeling, park it off. And then you just take it out from the second port. Okay, can we have the next video now? This is the laparoscopic cystectomy which I did in pregnancy. Well, I hope I'm just in time. Just forward it. This is also a cyst which is there. We try to cauterize the surface and then get a plane and then go ahead. Be careful. Yes, you can go ahead. Forward it, please. Yes, I'm just holding it. Traction, counter traction. I have removed out the cyst wall now. Some pieces is still attached, and then I park it and then I take it out. You can just fast forward it. Support. Yes. So thank you so much. Session. Yeah, thank you so much. I would like to share my screen with the last slide of take-home message. Just 1 minute. So laparoscopic ovarian cystectomy has now evolved and it has gone leaps and bounds, especially in ovarian masses. But in perimenopausal and menopausal, you need to do proper screening, proper tumor markers, have a good laparoscopic camera system, use dissecting the cyst from the ovary. Base of the ovary should be included while you use cauterize or suture it, and that's what you need to do. Thank you so much for a patient hearing, and I stop sharing now.
Thank you, sir, for the brilliant lecture. It has cleared many concepts. Without wasting further time, we'll hand over to the next moderator.
Thank
you. Let me introduce Dr. Mrugesh Patel, who is an MBDGO. He's a director, Mother Care Hospital, Mehsana, Gujarat, Scientific Secretary, MOMSO, Joint Organizing Secretary, SOGOG in 2011. May I request Dr. Mrugesh Patel to kindly introduce the next speaker.
Good morning, everyone. Thank you, Dr. Niranjan Chavan, sir, for giving this opportunity. And I am going to introduce a very dynamic personality of our in Foxy, Dr. Malvika Sabrawal. She is a Padma Shri awardee, Chief of the Department of Gynec and Obstetric, Department of Jeevanmala Hospital, Apollo Spectra Hospital, founder chairperson of Delhi State IAG, President Delhi Gynecologist Forum Central, past president Delhi Gynec Endoscopic Society, ex-member of the Association of Obstetric Gynec Society, AOGD, past managing committee of IAG, Dr. APJ Abdul Kalam's Excellent Award winner. I think many more feather on her head. So I cut down her introduction, and I invite Dr. Malvika Sabrawal to present her talk.
Thank you so much, Dr. Patel. Thank you for the very kind introduction. A very good morning to all of you. Dr. Purandare, our president, like Rishikesh said, yes, he is president. He continues to be FIGO president for us. So Dr. Adi Dastur, Dr. Shanta Kumari, all very, very good friends, and all of you who are there. Thank you so much, Niranjan, for having organized this wonderful session on Sunday, which makes it very fruitful. And all the very best to you, Niranjan.
Thank you, madam.
You know, my very important, no, that's a very big, you've worked very hard. We can all see that. So you've given me this very nice talk on demystifying fibroids or endoscopic myomectomy. And I hope you can all, you are able to, you can see my screen. Am I okay?
Yes, madam, we can see your screen.
So we all realize that almost by the age of 50 years, 70% of women might be having fibroids, and treatment has to be individualized depending upon what the desire is, whether she's infertile, whether she's bleeding, etc., etc. And the various options that are available to us are expectant, medical, surgical, or we can do interventional. So handling fibroids surgically can be challenging in certain situations, like if the location is such, it could be difficult. The size may be also one impeding factor. There could be number of fibroids. We do have patients who come with number of fibroids. You remove them, and a year later they again come up with de novo fibroids, or we have to, in primary surgery, explain it to them that you may still be having certain nests for which we, because want to retaining the uterus, we have not cut you every single place. The fibroid could be degenerated, then to extract may become a problem. Diagnostic dilemmas, we all know, situationally, it could be a difficult thing. So coming to a very important broad ligament fibroids, we will start that this is one of the most common extrauterine site myomas with low incidence rate. And as you can see in the picture, I hope it is clear that this is a fibroid, which is, you can see right adjacent to the uterus. And what I'm doing now is opening up the broad ligament. And of course, the ureters have been delineated first. As a rule, we always do the upper abdomen total visualization. We've worked up the patient in every which way to know whether there could be something else which we could expect, like endometriosis. We've taken a good history, worked it up appropriately. Now you can see the broad ligament, which the two folds are being opened, and you can see the fibroid and the adjoining uterus on one side. Once you're in the plane, the right plane, it's only the connective tissue which is there, and you can, one can just hold it with nice forceps, which are traumatic, which will give you a good grasp. And with the other side, you are nicely dissecting out the connective tissue, working on the right plane. And as you move on to further, you have to make sure that you don't come across any blood vessels, because they need to be tackled, as you can see now, appropriately at the right time. It's very important to be giving a gentle traction and counter traction, which is extremely important. These fibroids originate from the hormone-sensitive smooth muscle in the broad ligament. They may be just asymptomatic, but they can grow to very large size, and they can get impacted into the pelvis, thereby leading on to ureteric obstruction. Because this is the area where the ureter is crossing. It can cause urinary retention. We have seen cases. It can go into bowel obstruction or giving pressure symptoms. So this broad ligament, which has been opened, has to be closed, which is done. And let me tell you, let me share with you, endosuturing is not difficult. It's a question of just commanding the skill, which is really not difficult. So going on to the next, this is a cervical fibroid, very, very interesting fibroid. Now, whenever we have a cervical fibroid, let me tell you, when I started to do them, I used to be very, very apprehensive and worried about how I'm going to deal with it. One very important point here is that one should see the ultrasound one's own self. Incidence is 5% of fibroids could be like this. Once you have decided as to where the fibroid is, into the, like especially the relation to the cervical canal, you know, if it is an anterior fibroid, you're going to be opening the UV fold like what you saw me do and cut the right. As you move on with your dissection, you will be in the right plane wherein you will reach the fibroid. And once your fibroid is reached, you can just use a myoma spiral, fix it up and start lifting it. And slowly and steadily, whether using a scissor or a bipolar, or nowadays I land up using a lot of harmonic in such cases, wherein you slowly and steadily move on and you are giving constant traction with your myoma spiral on the other side. So this is a counter traction, which is very important, and gentle traction, counter traction, I cannot repeatedly say, but it's very important. And once in the right plane, you will not have much bleeding. Of course, you have used, prior to starting, you have used your vasopressin and you have warned your anesthetist that you're using your vasopressin. Remember, this fibroid, the cervical, they are, you know, they posteriorly, they will be very close to the rectum. Anteriorly, the bladder will be there. So once you once you've pushed away the bladder, the UV fold has been nicely pushed away, you can definitely go ahead. Ureteric course has already been seen. In case this fibroid was posterior, I would much prefer a vertical incision to avoid any injury to the laterally placed blood vessels. As you can see, harmonic being used in a comfortable manner, because this, the fibroid at the level of the cervix can be very, very difficult. So one has to be carefully doing it and reconstructing. Now, this is a very old video, but I have to just share it with you because this is a retroperitoneal leiomyomatous fibroid, which we could not do it. Pre-op, we were not sure. This is very, very old. This is the time when actually the gynae care came into picture. And there was this guy called Babu who was working in Johnson & Johnson. He told me in Delhi, I was the first one to be using the gynae care. And this was one of my initial cases. I was not sure. Here I'm just seeing where the ureter is, trying to make sure that it's not going to be coming in way. We didn't know whether it's going to be a fibroid or what. It's a retroperitoneal mass. You can see all the workup, MRI, etc. was still not clear. I will not name the place where we got from a reputed place the MRI done, etc., etc. But then any which ways, laparoscopy eventually, and reaching just like the taste of the pudding lies in tasting. This is where I'm still tapping it and seeing, and I'm making sure that the rectosigmoid is away, the uterus is anteriorly placed, and I'm now trying to lift up so that I get into the plane wherein I still want to know what it's going to be turning out to be. I was still not clear as to what it will be, but I did have the gynae care which they had given to me for the use. And after having made sure that everything is clear anteriorly, posteriorly, and I make a nick, the rectosigmoid has been pushed away. And as we go and we realize that once we are in the right plane, like I suggested to you, even for the anteriorly, once you're in the right plane, remember there will be no bleeding. And once you feel that it's a fibroid, you put in your myoma spiral. And remember, these fibroids are not very difficult, mostly if you're in the right plane, to dissect. So this is what we have done and taken it out gently as shared earlier. Now, this is myomectomy before hysterectomy. So this is something which can be required. The planned procedure here is hysterectomy. You can see the uterus which is sitting on the fibroid. And this is rather large. And you want to be making sure that you deal with the uterine, etc. comfortably. So what I did was I started doing the adnexa, the round ligament, and proceed on one side and seeing and then I plan to remove the fibroid before I complete the job of hysterectomy. Now, in this case, as we proceed on to the left side, you can see I'm approaching the mass Once you've opened up the product, but your geography is in front of you, and you make up your mind and you proceed according to the case that eventually whatever you were expecting may be different. So one very important thing is that UV fold has been pushed away, so that when one is dealing with the fibroid, any unexpected bleeding can happen, and we are at least making sure that the rectosigmoid and the bladder has been nicely pushed away from the point of dissection now. 1 or 2 myoma spirals can help to pick out this large fibroid. As you can see, it is a large fibroid, and once we have removed, it's very important to decompress the mass, and very important to do the dissection of the ureter rightly. However much you may have used the ultrasound, the TVS, normally ultrasound is adequate. I mean, we have an excellent ultrasonologist in Dr. Glossy Sabarwal. I form a good team with my other otolaryngologist, which is Shivani Sabarwal. And as a team, I think it's a wonderful way to manage to do the fibroid and then carry on with the hysterectomy. Now, this is another case wherein, it becomes like even Rishikesh showed you the classification of the FIGO classification, and he mentioned that a type 2 to 5, you may do it laparoscopically. Of course, there are so many factors which come in. There are a lot of studies whether you should remove fibroids, and yet even at this point of time, I've got 3 patients with large fibroids who are pregnant, who are carrying on. I've got so many stories to tell you about fibroids and pregnancy and deliveries and the follow-up, etc., etc. So this is an infertile person wherein I'm planning to do a myomectomy, wherein the same thing, like I said, the first thing is to get into the right plane, which is extremely important and very important care, because in infertile patients, one has to be very sure that you are causing minimal thermal damage to the myometrium, because the future pregnancies are going to be coming. Already, Rishikesh Pai has made a nice mention about cavity distorting fibroids, which need to be removed. Obviously, when the patient is going for a natural conception or otherwise, it's very important to remove the fibroids which are blocking the cavity or at least impinging onto the cavity. And here you can see it's a large fibroid. It's amazing how after myomectomy, these girls come pregnant. They ask you how much of a gap they should give before they should even make an effort to get pregnant. And we normally say 3 months, depending upon how much time we have, So age and everything has to be kept in configuration, and also we give them a good, but normally 3 months is adequate. So there is insufficient evidence to determine a specific myoma size, number, or location, excluding the submucosal. Of course, that you have to remove, whether it is associated with decreased fertility. But personally, I've seen in a series of our cases that whenever we have done myomectomy, the outcome of natural pregnancy is extremely good. It's extremely high. And as you can see, we have to take utmost care for the endometrium, so that we do not cause any injury to the endometrium, because we have to give due respect that she has to get pregnant following the surgery. Next. So now this is something which I've included here because I'll share with you. Now this girl has had a myomectomy with us, and now she's come up with something which we could not, despite all the investigations, we were not able to detect as to what it was, and we've gone it with a scope. Now parasitic or wandering fibroids or leiomyomas are very rare extrauterine benign tumors. Pre-op diagnosis is a challenge, because these, we have read about leiomyomatosis following myoma resection, but when you go inside to do the job is a little difficult, So we have to remember that we are in for a lot of adhesions, and be having that time which should be there for the surgery, which has to be very patiently done. What I'm showing is actually I recorded this on my telephone, and I've included this just to show you that this is the kind of picture. And as even the MRI could not pick up, because it was this particular area was very near to the liver and close to the stomach. So we were not sure as to what it was, but the final diagnosis was it was a parasitic fibroid. Next slide, please. Yeah. So okay, so now this morcellation is still a topic of debate, is it? That's a big question. So I have just included this because this video was made when Bhaskar Pal had organized an IIG conference in Calcutta, and this fellow Chandra Bajaj had given me this nice in-bag MorSafe to use, and we did it successfully, and the next day I was traveling anyways to IIG. So I included this in the sense that I told Bhaskar, let me just showcase this beautiful. So at one go, this was done, recorded, and just to share with you, this is a MorSafe bag which has been introduced inside the abdominal cavity from the lateral port, the left lateral port, and which has been extended into from 5 to 10, 12 millimeters. I'm showing you this is what I feel is that, the in-bag morcellation, not only for preventing LMS, but also to prevent any spillage of the, when you're resecting fibroids, there can be small spillages all around, which is a task to, wash off, do the lavage, take out all bits and pieces, which can still be left something. So I feel that to prevent that also the bag can be used. And I'm showcasing this so that we all know that the bag is not so difficult. Now, this is a bag which has been introduced on the left side. The fibroids have been put inside, and now the bag is being taken out of the abdominal cavity, from the abdominal cavity into the left parietes outside. The mouth of the bag is lying outside the abdominal wall, and this is the tongue. Now, this tongue is going to be, taken out from the visual port, which is the 10 millimeter port, which is supraumbilical. And I've already transferred my telescope from 10 mm to 5 mm to the right port. So basically, I'm inside with the 5 mm port, and this is the tongue which is being pulled out from the 10 mm port. Now you see it outside. Now this is the tongue through which now the telescope of 10 mm has gone inside. There's a little hole. You go inside, you collect the pneumoperitoneum to the 10 mm port, and you create a pneumoperitoneum. So now you have a secondary abdominal cavity which is inside the abdomen, so that the omentum, the intestines are outside that. So now the morcellator is introduced from the left port, which is already the 12 mm port, through which the Versator, that is the MorSafe the bag has been introduced. And after finishing the morcellation, what we have done is that we have complete hemostasis. Normally, I do use a lot of intercede. Let me tell you, we all know the morcellation debate, which shook everybody globally. Gynecare was withdrawn. Stores people continued to upgrade their morcellators. Despite all the Amy Reed case in 2012, we all have landed up using the in-bag morcellation in well-selected cases for the reason which I've already discussed. So, but the patient, I would share that patient has to be taken into confidence and talked to about in-bag morcellation and myomectomy. It is something which is very important in these medical legal times, wherein the patient understands everything. And your best time to talk to them is when you're taking the history of the patient, you're working up the patient. It's very important to tell them exactly, candidly, as to what you are in for. Because once you've spoken to them completely, they are ready for this. One must talk of blood transfusions in case need be, any injuries, any of those, and also one very important thing I've realized is in my initial cases, I would take the history of dysmenorrhea, but never talked about endometriosis. So this is something which for so many years I'm doing, that I must take it myself, talk to the patient and tell them in case there is a concomitant endometriosis, I have to deal with it. And the patient should be prepared, especially when she's like, 44, 45, and here she has got some endometriosis, which is not ovarian, but otherwise, and she has history of dysmenorrhea, and she's very troubled with that. So she should be, totally told about it. What is the plan that you have in mind? So take home message is that I've already mentioned the history of the patient, the workup, etc. A simple ultrasound is the best. I always do a fibroid mapping done in our own place. Of course, you have to be on the same page with the radiologist, and also you should be totally involved yourself. And in case informed consent is something which is extremely important, and the clinical results and extremely low conversion rates suggest that laparoscopic myomectomy is definitely reliable even in the presence of tricky myomas. Each surgeon has to determine selection criteria based on personal proficiency, especially the intracorporeal suturing. However, we believe that with requisite skills and good support, the size and location of fibroids should not be the limiting factor for the procedure. Thank you so much. It's the persistence which is very important. There is no giant step that does it. It's a lot of small steps. Thank you so much for a very patient hearing. I hope I'm on time.
Thank you very much, madam. May I request Dr. Mrugesh to kindly ask the question that's been posted on the chat box? May I request someone else to take up the question, please?
I think there are no questions right now. Yeah, there is one question. Shalini Singh from Lucknow. If during laparoscopy the cyst appears a complex mass with few papillary projections and all tumor markers pre-op normal and color Doppler normal, what should be the approach? Further oophorectomy or cystectomy? Hello, sir. Madam Shalini Singh, I think this question is related to me. You have a frozen section option. So you can just see that the frozen section can be done and try to confirm whether you would like to go ahead to do an oophorectomy. Mind you, you have to take a proper consent. You can't just do an oophorectomy on a woman who is under anesthesia. You will have to do a proper consent, and in such cases, it is always better to send that cyst wall or whatever you have got of the ovarian tissue to a frozen section, wait for the report, and then go and again counsel the patient. And I think that should solve your problem.
Niranjan, I would like to just add one thing, that it is very important for all of us to work up a patient by a good ultrasonologist prior to taking up the patient, number one.
Yes.
Number two is that always do a full abdominal ultrasound, because long time back I started doing, combining procedures in a single surgery, wherein the gallbladder and the ovarian cyst or the uterus was removed in the same sitting. So these papillas, coming back to the question from Lucknow, the papilla will be easily picked up by a good ultrasonologist, and you should be would have talked to the patient earlier.
Yes. So that is the reason I thought I want to, go on an uncharted journey with you, and of course, to have sonologist or a good consultant with you. Either you are a better trained person, but it will give you a proper, insight before you go on this uncharted plane, because sometimes there are googlies which happen, and unfortunately then we don't want to come in any medical legal issues. I think we should move ahead with the next moderator. Thank you, Dr. Malvika, but please be there, because there is always a lag of 5-10 minutes by the time the questions will be coming for your session. So I request you.
I'm with you, not to worry.
Thank you, madam. Thank you so much. Yes,
Before
please go ahead.
Before we go ahead, a very short word from our sponsors. So the next moderator is Dr. Lovely Jetwani. She's an MS OBGY, DNB, DFP, and FMAS. She's done her fellowship in ultrasound, fellowship in endoscopic surgery from various stalwarts of Mumbai, Ahmedabad, and California, and fellowship in ART. She is currently consultant obstetric and gynecologist, endoscopic surgeon, and IVF consultant at Sona Hospital. Dr. Lovely, thank you for joining us. I request you to kindly introduce the next speaker.
Thank you, Sushant, for the kind introduction. A very good morning to the esteemed faculty of FEMAS, my respected seniors, dear friends and colleagues. At the outset, I would like to thank FEMA's team and especially Dr. Niranjan Chauhan sir for inviting me and giving me this privileged opportunity to invite and introduce on screen one of my favorite endoscopic surgeon, Dr. Sanjay Patel sir, who is not only the role model for for me, but for every endoscopic surgeon who dream of this being an endoscopic surgeon in endometriosis, especially, which is a surprise disease. Sometimes people don't have any symptom, and when we open the when we see enter the endoscopy enter the endoscope inside the abdomen, we find there's a different kind of disease, as the person is saying it is not like that. So it is very difficult task for every new aspiring gynecologic surgeon, endoscopic surgeon, to deal with endometriosis. I would like to invite Dr. Sanjay Patel sir on screen, who is India's pioneer person in gynec endoscopic surgery. He is the director of Mayflower Women's Hospital. He was the first gynecologist in Asia to perform laparoscopic Verdheim's hysterectomy in 1997-98. He has been ex-course director of Asia Pacific Association of Gynec Endoscopy. He was invited as faculty in AAGL, and he has also been honored as Best Gynecologist of Gujarat in 2003 and 2019 by IMA. He has also been awarded with Senior Korean Award in Foxy annual event in 2019 and received Foxy Korean Award in 2007 for research work in salpingoscopy. He has performed more than 200 live workshops and delivered more than 400 lectures at national and international level. His best quality is his humble and the simple behavior. He has always been grounded, even on being the legendary surgeon in endoscopy, especially in the advanced radical cases and the endometriosis. Sir, we have always been following you as a father figure in endoscopy. Welcome on board, Dr. Sanjay Patel, sir.
Thank you for the kind words, Dr. Lovely. It's a pleasure for me today. I am with you.
It's my pleasure to introduce
First,
you,
I would like to thanks to the Dr. Niranjan Chauhan to invited me here for this webinar, and wish you all the best, Dr. Niranjan, for the election related to treasurer post for the IAG. Today, my talk is related to simplified the advanced endometriosis of the bladder, bowel, and ureter. Endometriosis surgery, if you try to make the understand, it looks like the mathematics. 1 + 1 make 2. My dear friend Malvika also, I since long back, after endometriosis still is the enigma, as we all are not ever the real reason of the disease. But we know the certain facts based on the which the present treatment is designed. The basic principle related to endometriosis surgery, understand the alter anatomy. This is very important because this is not the perfect anatomy. You create the anatomy and then you proceed for the surgery. Find out the correct plane of cleavage. Debulking surgery, because it's very difficult to enter in the pelvis due to this is bilateral tumors with the progen pelvis with the adhesions. So debulking surgery is definitely a key role in the endometriosis surgery. Understand the texture of the tissue. Sometimes texture of the tissue give the guideline related to create the pathway for the further more dissections. And understand the epicenter of the disease. If the epicenter is related to left uterosacral, then whole the fascia is moved toward the left uterosacral. So understand the epicenter of the disease. Now we deal with the bowel. First we talk related to bowel endometriosis. In this case, I think 6 principle is very important related to DI for the bowel. Mobilization of the sigmoid column from the pelvic brim, particularly on the left side. Identification of the ureter at the pelvic brim and do the ureterolysis. In institute, this is the first victim to identify the ureter and do the ureterolysis. Debulking surgery with the removal of the TO mass if needed. If conservative surgery, then you lift up the TO mass and you hitch with the anti-abdominal wall. Middle pararectal space dissection is very important whenever you deal with the colon. Lateral pararectal space dissections with the identifications of the uterine artery at origin in complicated cases because it reduces the blood loss, and meticulous dissections with the hypogastric nerve sparing surgery. Now the most important part in the particularly with the DI is the endometriosis to preserve the hypogastric nerve. There is two type of infiltrations we find out that it's extensive. In those cases, particular over this bowel, you do the saving technique. But when it's intrinsic, if more than 7 mm depth is involved or more than 3 mm depth is involved, and associated with the muscularis portion of the colon is involved, in those cases, the intrinsic involvement, the approach is absolutely different one. And I think this is, I created diagram. If the particular, the serosal surface is involved, and this is the rectovaginal plate associated with the posterior cervical pathology, in those cases, only the saving technique is required. If the involvement of the serosal and the muscular layer associated with the muscularis involvement, but it couldn't involve the mucosa of the colon, in those cases also you go for the saving technique. And this not the typically is the discoid dissection, but you go for the saving, remove the muscularis portion and you suture it. If the single lesion is 3 cm, less than 3 cm with the mucosal involvement, in those cases you require to go for the discoid rather than just you go for the saving technique, because you have to have the remove the involvement of the mucosa of the colon. And particularly in those cases with the multiple nodules associated with the more than 3 cm size of the lesions with the hourglass structure, in those cases circular ring of the fibrosis surrounding to the colon, in those cases we require to the resections. This is another case. Both the side circular ring, it's the hourglass structure, particularly in the colon, where the parametrium and cardinal involvement associated with the uteroscal, in those cases, I think we require to go for the colon resections. This is the very important case. Small bowel obstructions and involvement of the bowel is very rare. But in this case, multiple hospitalizations for the subacute bowel obstructions with the iliac and rectal endometriosis. I show you in this video clipping because it's the rare rarity. This patient, it looks the tip of the iceberg, small implant over this ileum. First we dissected with the harmonic scalpel, and then we realized that the 70 to 80% of the small bowels, it's involved with these nodules, and due to the hard tissue, that's why repeated the obstruction is happened. The torsion of the particularly this ileum is happened, and that's why it's developed subacute bowel obstructions. This is the really we get the mobility of the colon, small bowel, and I think just try to make the stretch or extended the middle part and we bring outside. This is the simple way rather than you use the multiple stapler over it. It's the simple way bring outside, took the stay stitches, and I prefer to use the 3-0 Bicrid with the 2-layer suturing is important. But it's a very simple, I think whenever the small bowel is required, better try to make the extended 2.5 to 3 cm middle part, bring outside and suture it. And look here, this is more than 70% lumen is involved with these nodules. So this is the intrinsic environment, particularly in this such kind of the cases, you have to have go for the resections. But this is the case. It looks the very complicated case. It's the frozen pelvis, uterus is adenomyosis, and the previous multiple surgery. But in spite of that, we try to make the mobilize the colon. We flush to the surface of the uterus. And here, this is the part of the whole nodule. Particularly in such kind of the cases, the middle displacement of the ureter is happened. So first try to make the identify the ureter at the pelvic brim and mobilize the ureter laterally. This is the key part. Second important part, if needed, then you go for the middle pararectal dissections. The very important in such kind of cases to split the nodules. Never try to make the flush to the colon, otherwise you end up with the injury of the colon. You split the nodules, and half of the nodules you bring with the colon and half of the with the uterus. So this is the simple way to, I think, dissect the such kind of the nodules. And look here, the whole nodule, whole majority chunk of the nodules is, I think, bring with the colon first. In this cases, first we perform the hysterectomy, because this is the case for the hysterectomy. This is not for the conservative line of the treatment. So we first perform the hysterectomy, we remove the uterus, and we prefer to use the tilaculum and try to make the flush to the colon. Sometimes we put the rectal probe, and Caesar is really wonderful tool. Otherwise, nowadays I prefer to use the HD 1000 probe. It's a fine tip. It's dissected properly in this for the such kind of the nodules. And very important. Look, this is the lacunical access. Try to make the, I think, remove the whole lacunae wall. If you leave the small portion of this lacunaceous wall, there is ample of chances of the recurrence. So Caesar is give the tactile sensations, flush to the colon, and remove these nodules. But this is the only the serosal surface of the involvement of the colon. So only the saving technique is very important in such kind of cases. No need of any discoid. And at the end, very important, you check the colorectal integrity test. The middle pararectal space dissection is very important whenever you go for the discoid. Here, I think, try to make the flush to the colon, parallel to the and medial to the uterosacral. Majority you find out the very good plane of cleavage. But the most important part, just you go below to the this one. This is the hypogastric nerve, and try to make the preserve this hypogastric nerve. Look here, this is the hypogastric nerve. So medial to the hypogastric nerve, if you dissect the colon, majority time you avoid the injury of the hypogastric nerve. And this is the two layer of the denominator spacia, just we split it. And further we more dissected because it's a multiple peritoneal implant. This is the case for the conservative surgery for the endometriosis. And this is the whole rectovaginal plate is also involved. So left side also we, I think, do the middle pararectal dissections, and we develop in Mayflower is the butterfly technique. We try to make the remove the both the leaf of the butterfly above the level of uterosacral and below the level of the uterosacral. We remove both the peritoneal tag with this one, and in between this is the rectovaginal plate. Might be you understand whatever I am telling. It's a between this one is the rectovaginal plate. We remove it, and it's the small chunk is here, but it's invasive in the muscularis portion. It's up to the 7 mm. Because sonography, sometimes you try to make the find out the invasion of the muscularis portion, and the depth of the invasion we realize with the MRI and with the sonography. And also we try to make the, in this case, is preserve because mucosa is not involved. So we dissected flush to the mucosa, and we try to make the preserve the mucosa. If you preserve the mucosa, the post-operative morbidity is comparatively very less, and hospital stay is also very less. So this is the whole nodules, we remove it, and we do the single layer suturing. If we open the mucosa, in those cases we prefer to take the transverse level suturing, but in those cases we try to make the preserve the mucosa. In those cases even the vertical suturing is also enough, and we couldn't encounter any cases with the ureteric any cases with the colonic stricture in such kind of the cases. So it's very important to, I think, suture properly, took the thick muscularis portion of the bowel and approximate properly. But in those cases, this is the another case. Also, there is a muscularis portion is involved, serosa is involved, but mucosa is not involved. So this is the different approach. How can we do it? I show it. In these cases, first we mobilize the lateral fat with the harmonic scalpel. This is very important. Whenever you go for try to make the mobilize this lateral fat. This is very important. Clear it. Then we find out the rectal tube on the lateral side. Again, further we dissected on the left side. Then we pick up with the tenaculum and flush to the nodules. Look here, this is invasive more than 7 mm. In those cases, if the nodules is slightly big, it's invasive, but the muscularis portions is involved and mucosa is not involved. Once we dissected the mucosa is pop out. This is another small nodule we left behind. Again, we use the scissor, flush to the nodules and remove it. The small bleeder, it's happened. We take care with the under the continuation of irrigations. Then we put the rectal probe. And now we prefer to use the VLOC because VLOC 30 is such kind of the cases is wonderful because we leave the halfway. So we took the depth of this muscularis portion of the colon. Look here. Because we leave halfway through and then we tight it, again we lift up it and then we suture it. So we go in the depth of the muscularis portions. So we proper suturing of the colon is possible with this VLOC. And I think we extremely happy with this is one of the technique we develop at Mayflower Hospital. The most important part, the colon integrity test. But if the muscularis portion associated with the mucosa involvement, in those cases, the discoid is very important. I took this case specifically because majority patient is go for the hysterectomy and people is doing the intrafacial hysterectomy and leave the pathology left behind. This patient is presented with the bloating abdomen, dysphagia and difficulty passing the flatus and stool. So in these cases, if you look here, this is the small collections. First, we try to correct the kinking of the colon. Then we dissect the whole middle parietal place and try to preserve the hypogastric nerve. Also, we take care related to middle rectal artery here. Whenever you go for the discoid, the mobility of the colon is one of the most important part, and we dissected between the two layers of the denonvillous fascia here. Once we get the mobility, this is the more than 3 centimeter of the colonic involvement. So first we prefer to take the straight stitches on both the sides. So I think one of the dictum and principle related to colon suturing, always prefer to take the straight stitches on both the sides. And then you excise the whole nodules. In this cases, the mucosa is involved, so you have to have open the colon. And look here. But try to make the flush. This is the lacunic collections. The chalky material is coming out from these nodules. And this whole colon, we open it first. This is the more than 3 centimeter size associated with the discoid. So we prefer to take the transverse suturing rather than the vertical to avoid the stricture, avoid the stricture of the particularly colon. And I think inner side I prefer to take with the 30 Vicryl. With the transverse suturing is very important. This is the key part of success. Otherwise, sometimes if the nodules is bigger size, there may be ample of chances of the stricture of the colon. And even in these cases, outer layer we prefer with the VLOC. But the most important part to you bury the mucosa remain inside. This is the key of success. And outer layer we suture with the VLOC 30. We go in the depth of the muscularis and we bury the whole first layer. If you take the one layer or single layer, doesn't difference. But anytime the pop out of the mucosa, in those cases you require the second layer. So I think the 30 VLOC is also wonderful suture, and we take the lateral tag of this colon and fix up with this angle. And at the end also we fill up pelvis with the saline and we push the air from the below and we check the colorectal integrity. And look, this is the nodules with the multiple lacunic collections remaining inside. It's more than 4.5 centimeter. And in spite of that, we go for the discoid. Now we done the series of cases and we realize that I think if you do the meticulous surgery, and even though it's a more than 3 centimeter size of the nodules, if you go for the discoid, it gives the wonderful outcome. But in those cases with the multiple nodules, associated with the hourglass stricture in parametrium cardinal involvement. You have to go for the use of the circular stapler and colonic resections. Even though in some cases I think colonoscopy is not possible, it's just so narrow. This is very interesting case. I think this is from the Calcutta, and somebody is try to perform the surgery with the help of the GI surgeon and urologist, and I think it's considered to be inoperable case. And these people is do the diversion of the colon, and this patient is referred to me. Here, look here, because this is the extreme complicated cases because the colon is absolutely loaded. So first we go for the middle parietal. First we go for the such kind of the cases when the whole multiple nodules is involved. I prefer to compromise the inferior mesenteric artery and vein because we get the enough length, and associated with sometimes it's the tensor-free anastomosis is created with this technique. So I think whenever I go for the big segment, I remove it. In those cases, I compromise the inferior mesenteric artery and vein. And now if you cut it, then you get the good mobility of the colon. But the most important part in the such kind of with the loaded sigmoid, I think sometimes the dissection is maybe difficult. We enter in the middle parietal space. First we dissect it. Furthermore, we enter inside. And this is the area of the holy plane, just behind to the colon and sacrum. This is the two layer of the fascia, and this is we call the holy plane. We also enter and we dissect it furthermore as far as possible. This is the lateral wall involvement with the endometriosis. And here we find out the pyriform muscles with the associated with the levator ani muscles. So we dissect parallel, and this is the whole circular ring is involved because lateral rectal wall is also affiliated with this one. Also, this is the posterior upper vagina, 1/3 of vagina involved with the endometriosis. So we dissect it furthermore, and we try to make the mobilize. We split the tissue from the vagina. And this is the whole circular ring. First, we clear it because such kind of the cases is we open the vagina, we try to make the furthermore dissected. And this is the lateral rectal pillar also involved with the endometriosis. Here you take care related to this middle rectal artery. It directly arises from the internal iliac artery. And then I prefer to use the stapler. I prefer sometimes 45, sometimes the 60. It depends upon the size of the colon. And also I prefer to use the 29 mm stapler, circular stapler. Then we bring the outside. We open the natural vaginal orifice because we already performed the hysterectomy, and this is the multiple nodules over this involvement in this colon. So we excise. Also very important part, you take the stasis with the prolene, circular. And then we put the anvil remain inside and we fix it. Further we push back and we fire the stapler from the below. Before that we do the alignment of the colon, correct the axis rotation of the colon, and then we fire the stapler over it. We correct the axis rotations and then we fire it. It's very important. And because we compromise the inferior mesenteric artery, we get the good mobility of the colon. The true circular ring is very important. It's related to proper anastomosis. Sometimes I prefer to take, if any tear of the muscularis portions, in those cases I prefer to take the 1 or 2 stitches, depend upon the tear of the muscularis portion of the colon. It's reduced the leaking late in the post-operative time. And this is we done the proper anastomosis in this case. And this here, if you look at the multiple nodules involved, because it's previously underwent go for the 4 or 5 times surgery for the endometriosis. And this is the approximately 50 to 60% colon is involved with this occupied the colon with these nodules. And this is lacunar collections remain inside. So the next my topic, ureter is the first victim. I think it's because near to the uterosacral and peritoneum, and it's with the small lumen. So I showed some couple of cases related to ureteric involvement in the endometriosis. Particularly, one of the basic principle dissects from the virgin to the affected area. Never try to jump directly over this affected area. Start dissection from the virgin to the non-virgin area. Ureterolysis is the key part. Try to make the understand the pseudocyst. We always find out the pseudocysts in cases of the advanced endometriosis when the ureteric involvement. In some cases, the intrinsic involvement, in those cases, we require the ureteric implantation. The most important part is to maintain the vascularity of ureter. This is very interesting case, left ureteric stricture with the hydronephrosis, hydroureter with the left cardinal involvement. And this is the conservative surgery, but it's the extensive ureteric involvement in these cases. Look here, the pelvic is virgin. And once we mobilize the colon, we realize that this is the approximately more than 1 centimeter dilated ureter. We try to make the dissect parallel to the ureter on the anterior surface because the mesentery was on the both the sides. So anterior is the same area to dissect parallel to the ureter. And look here, this is the whole dilated ureter. This is the small implant. So this is the typically endometriosis behavior pattern is absolutely different. It's the typically it's the DI, deep endometriosis with the cardinal involvement in these cases. Further, we more dissected. We try to make the dissect the whole ureteric tunnel in these cases, and very important whenever the hydronephrosis with the hydroureter with the cardinal involvement, in those cases de-roofing of the ureter is very important. Then we go for the lateral parameter space. We try to make the identify the uterine artery. Also we dissected further ball, and this is the whole disease involved. We also try to make the flush to the uterine artery. This is the anterior division of umbilical ligament, and it's the whole middle displacement of the uterine artery. Look here, this is the internal iliac artery associated with the anterior division of umbilical ligament, superior vesical artery, and this one is always the water is below the breech. Salis is telling. And this is again we try to make the further more dissected parallel to the. We also compromise the round ligament because we dissect totally ureteric tunnel in these cases. And look here, this is what you look the white lesion. This is typically white lesion of endometriotic nodules. It's involved the cardinal ligament.
Sir,
further we mobilize.
2-minute warning, sir, for the lecture.
Okay, sir. Whenever you tell, immediately I stop it, sir. Further we more dissected parallel to the ureter. And this is the pseudocyst. You try to make the identified the pseudocyst. You enter in the pseudocyst, and then you try to make the excise the whole fibrotic portion over this ureter. But in this case is the hourglass stricture, but this is no involvement of the muscularis portion of the ureter. And look here, this is the kinking of the typical ureter. So further we fiber by fiber dissection is key part in such kind of the cases, and never try to make the remove the big chunk. Try to make the small chunk. Further we mobilize the uterine artery, and here if you look that because it's the cardinal involvement, even the uterine artery involved with this particular with this disease. I show you in a couple of minutes. Look here, what I remove it. This is the whole chunk of the nodules, and this is the uterine artery over this ureter. Because disease is also involved in the uterine artery, and that's why the stricture of the uterine artery. We mobilize the uterine. It looks like the thread. Look here, because due to the involvement of the disease, the uterine arteries looks like the thread. Further, we dissected parallel. Majority time, sometimes you on the particular right or left side, we find out the good plane of cleavage. And always, if find out the good plane, better try to dissect it in the particular this zone. Here, this is the whole stricture of the ureter. And scissor is really wonderful tool. And further, we excise the more affected portion of the cardinal ligament with the endometriosis. And now the ureter is absolutely clear one. We furthermore say over this ureter, but this one is the extrinsic involvement. So in this cases, I think no need of ureteric implantations. This is the whole disease of the uterocecal and part of the cardinal involvement. We mobilize properly ureter, because this is the key part to remove all the implant over this ureter.
Sorry to interrupt, sir. Our time is already being completed.
Thank you very much. Thank you again, Dr. Niranjan Chauhan and Dr. Malvika. Thank you very much. After a long time, I see you. Thank you, ma'am.
Sanjay, it's a great pleasure to see you operate, and all your videos are very good. All of us have a learning experience with you.
Really mind-blowing.
Thank you, Malvika.
So I have a question for you. Can I ask?
Yes, ma'am. Yes, lovely. Tell me.
Sir, last year I went for observership with Dr. Kamran Nazad for advanced endoscopic training. I observed that many patients were complaining so many complaints about endometriosis, but while entering for diagnostic laparoscopy, there was no lesion at all. But Dr. Nazad used to do hydrodissection, and then he used to take peritoneal biopsy from all over the peritoneum, from anterior pouch, from POD, and from broad ligament. And then very rarely, these peritoneal biopsies came out to be endometriosis, fibrotic lesions. So I wanted to ask you that how this scenario works, in like if we take so many biopsies, 10, 12 in different vials, and this is very costly for in our scenario. So how should we proceed in such cases, like if patient is complaining so much and there is nothing inside in the diagnostic laparoscopy?
I think the key dictum, particular for the endometriosis lesion, associated with the neurovasculature. And if you feel and try to make the pickup, you try to find out the hardness of this tissue. So I think if you randomly took the biopsy, you couldn't find out that. But whenever the hard nodules, sometimes it's the tip of iceberg, it's smallly 1 mm nodules above the level of peritoneum. And if you go below, this is the 5 or 6 mm size of the nodules just below to the peritoneum. So you try to make the pick up the nodules. You find out the vasculature, you feel this one, and then you dissect and send for the biopsy. Majority time you find out the endometriosis. But if you took the random biopsy of the peritoneum, you never find out the
I guess that comes with the experience. We feel a tactile sensation about this fibrosis, right?
It's very easy. Even though you just try to make the pickup, you feel that this is the hardness.
So I could not understand the principle of hydrodissection. Like it must be for the safety of the underlying structure. But we are not. I saw you are not doing any hydrodissection. You are directly.
I think hydrodissection is create the tissue edema, and sometimes we leave the lesion left behind. So I think rather than doing the hydrodissection, better you try to make the understand, and accordingly that you try to make save the whole the nodules, because zero dissects, zero particular surgery is not possible in the end. But optimizing surgery is very important, particular for the endometriosis. So I think if you go for any hydrodissection, that tissue is implant, and you leave so many tissue left behind. So rather than, I think, infiltrate and doing the hydrodissection, better you do the peritoneectomy if the multiple implant over this peritoneum, whole peritoneum of the particular posterior broad ligament, you remove it and try to make you go depth in the retroperitoneal structure. If the ureter kinking or everything, just you mobilize and then you excise the whole nodules.
Can I just say one thing, Sanjay? So
yes, ma'am.
You had an experience wherein Kamran Nazad was doing a laparoscopy for every patient, like whatever number of patients who had basically presented with pain.
Sir, ma'am, he used to give a formatted 7 pages of history. Like a patient has to fill a form of 7 pages where he had an elaborate history of patient, including the emotional history of emotional abuse or sexual assault. He used to correlate with this. He was doing the research on the correlation between the endometriosis and the past history of emotional abuse, sexual assault, including all the symptoms of endometriosis: pain, dysuria, mild, moderate, severe. There was elaborate history. Then according to the history, he used to put the patient for the diagnostic laparoscopy, and then he used to say that see, I have found this, see lovely, in the last 2 months I have found one coincidental endometriosis patient while there was no lesion seen at all in the peritoneal cavity.
So lovely.
But I think it's very important to narrate the Dr. Lovely. I think if you take the depth history in our center, I think this is the 8th protocol. Among that, one is related to depressions, psychological problem, abnormal behavior pattern, you took the any psychiatric treatment related to pain, any suicidal tendency you also think related to this part. And I think out of 10 in the deep infiltrating endometriosis, 2% have the some psychological problem. So
So
it's
it was
very important.
very
So I
interesting.
think very important to take proper history, and you depend upon the severity. We, I think, a score of 0 to the 10, we put accordingly that we sign it, and accordingly that we our design our treatment. In which cases, I think once every time I'm telling optimatic surgery is important, but those who have the pain threshold is very less, with the severe pain, with the some suicidal tendency, in those cases I am very aggressively and try to make the do the zero disease in those cases, because this is very important. So accordingly, the symptoms of the dysphagia, bloating pain, dyspareunia, and difficulty passing the urine, so many things I think we consider step by step in our institute, and we do the scoring from the 0 to the 10. According to that, we design our whole surgery. So I think that this is the mapping and planning of the endometriosis surgery is very important. It's the key part. What I am telling related to adenoma might be majority people heard my lecture related to adenoma resections. So always I am telling for the adenoma resections, the mapping is very important. Mapping, and mapping. Particular for the endometriosis surgery, the mapping and planning is very important before you enter in the abdomen. And accordingly that you design the whole surgery.
Thank you so much, sir, for mind-blowing videos, and it was very motivating for us to become. I wish we could also become fearless endoscopic surgeons like you in future, sir.
Once you do the 1 or 2 mistake, if you cut the 2 ureter, automatically you get the enough boldness related to ureter. If you open the 2-time column, if one face the fistula related to peritonitis, I think you get the enough boldness related to column. I learned from my mistake. I tell you, I committed. I opened the so many time column, and gradually I get enough boldness to how to suture, how to handle with the column.
And so
I think the complication is this is the failure is the part of the pillar for the success in our life. The same way, complications, I think you learn from the complication, and the complication is the pillar related to next step. We go ahead. What the Malvika is telling, step by step, you go for this journey related to endoscopy. This is the same way. If you do the complication, you understand and you learn from your complication and go step by step. My journey is affiliated with so many complications, and then I think I reach near to some finishing stage. So this is very important.
One more important thing, we should be ensured ourselves before doing such complicated surgeries. Otherwise, we can be
complication is bound to be happen. You I think identify the complication and you rectify the complication. This is the main key part. If you deal with the endometriosis, such kind of the complications may be happen. Recently, I show the video clipping in the particularly aortic injury, the success story related to survival of the aortic injury. Because this is only the one documented things. Even though I try to do the suturing and everything over this aorta, I try to at the only the 40 blood pressure of this patient, and even though I documented, because this is very important for the society to how to deal with such kind of the cases. So documentation is also very important each and every cases.
We can almost sense the passion that comes from each of you experts towards this topic, but we have to move ahead. So I request Dr. Sanjay, thank you very much, Dr. Lovely, and Dr. Malvika.
Thank you, Malvika. Thank you, Lovely.
Thank you. Thank you so much.
Sarogi sir.
Sanjay sir, Mukesh here.
Mukesh, how are you? Fine.
I'm fine, sir. Jordar.
Thank you, Mukesh.
Yes, sir.
May I request my colleague Sana to please introduce Dr. Aditi?
I would like to introduce our next moderator who will be moderating the next session, that is Dr. Aditi Tandon. She is the consultant gynecologist, fertility consultant, and endoscopic surgeon at Dr. Sudha Tandon Fertility, IVF, Endoscopy and Maternity Center at Chembur and Navi Mumbai. She is the ex-assistant professor at DY Hospital and has done fellowship in ART and advanced minimally invasive laparoscopic surgery. She is the recipient of many awards like Foxy Young Turk Award, Best Youth Council Member MOX, then Yuva ISA Researchers. And she has also received the award for Ashok Mehra Prize for Best Endoscopy Paper in the National Conference of MOX, and she is the Youth Council member of MOX since last 4 years. Over to you, Dr. Aditi. Thank you.
Thank you. So from one great stalwart of gynec endoscopy, we move to another stalwart of gynecology, Dr. Rajendra Sarogi. He needs absolutely no introduction. He's a teacher of teachers. He is ex-honorary professor at KM Hospital, Mumbai, ex-honorary and HOD at Cooper Hospital. He's senior consultant at Nanavati Hospital. He's director of Sarogi Group of Hospitals. He is past president Malad Medical Association and past president and founder of AFG. He is also managing trustee of AFG. He he has written various chapters in various books and also has been given the Best Book Award by Foxy. He has also received the most prestigious Foxy Corion Award in 2006, 2007 for devising a surgery mesh plasty for SUI. He has presented various papers and has over 50 publications in reputed journals. He's a master of vaginal surgeries, as we all know. He's president of Society of Vaginal Surgeries of India, Maharashtra chapter. Over to you, Dr. Sarogi.
Thank you, Aditi. Thanks for those kind words. First of all, I would like to thank Dr. Niranjan Chauhan, course coordinator, for inviting me to be a part of FEMAS 2. I would also like to thank all the viewers of this program who are watching this program with such keen interest. My talk is on meshplasty and SUI repair for fertile women. This is a PowerPoint presentation followed by video. PPT will tell you all how I developed this novel method of meshplasty for SUI, and video will make you feel how much it is to correct SUI. I got inspiration from this article way back in 2003 by Dr. Ravindranath Tongaonkar. I don't know how many of you are aware of him. He's from Dhule and we lost him just few days back. He came with the idea of using mosquito net for hernia repair. Next slide, please. In those days, Johnson had come out with tension-free support for incontinence TVT tape. Mind you, the word is tension-free support. That was another thing which made me think, why can't I use my method for correction of SUI? Next. At Cooper, we performed quite a few SUIs. So I thought of devising a performer, and this is the performer which we made. And mind you, 2 of my residents did a thesis also on meshplasty for SUI. Next. This is another part of performer. Next. Initially, in some cases, we tried to do urodynamic study. Here you can see I had sent this patient to Dr. Anita Patel, a renowned urosurgeon. And she reported that patient had severe type of stress incontinence. This was on 1st February 2006. Next, please. 2 months later, that means 6th of March 2006, after the surgery was done, you can see history of surgery 2 months back for SUI. Some meshplasty was done. Presently has minimal leak on a loud cough only. Night frequency 0 to 1 time. Subjectively happy with the outcome of a surgery. So this gave me some inspiration ki fine, my meshplasty will definitely work. Next, please. Then I published this paper in our Jogi in 2010, which was an original article as meshplasty treatment for stress urinary incontinence, a preliminary report. Next. We did further study and we published this in 2017, meshplasty treatment for stress incontinence, a prospective clinical trial. This was published in International Journal of Reproduction, Contraceptive Obstetrics and Gynec. Next. I was given Foxy Corion Award for this during the year 2006 for best scientific research work in obstetric and gynec amongst the senior members on the occasion of 50th Golden Jubilee All India Congress of Obstetric and Gynec Society held at Kolkata. Next, please. Let's come to what is the principle of meshplasty. Recent advances in knowledge about pathophysiology of SUS shows that support at mid-urethral level is weak, resulting into sagging at mid-urethra. See, all these years we were under the impression that probably the problem is at the internal urethral meatus. But now it is proved beyond doubt that the problem is at the mid-urethra and not the internal urethral sphincter. In such cases, whenever intra-abdominal pressure rises, the intravesical and proximal urethral pressure also becomes more than that in mid-urethra, resulting into dribbling of the urine. I'm not talking about the cases of true incontinence due to sphincter deficiency. Next, please. To understand SUI in a better way, let's try and understand one thing. If we stand on a watering rubber tube, which is analogous to urethra in a lawn, and the floor is rigid enough, that means mid-urethral pelvic support is rigid enough, the pressure of your foot will stop the water flow. That means the pressure on urethra will stop the urinary leak. But if the floor is soft like sand, water will continue to flow till the floor is made rigid. That means the tube will sink down further and the flow of urine will continue. Next, please. This is how you can see here on a rigid floor, when I'm pressing with the legs, the flow will stop. But when there is a sand and I press, the tube goes down. And that is the basic principle of my meshplasty, TVT or TVTO. That means basically for cases of hypermobility of urethra due to mid-urethral support weakness, this surgery will help. And we all know that 95% of the cases SUI is due to hypermobility of the urethra. Next, please. It will be irrational. In olden days, we used to use Cayley's plication suture, and over a period of 5 years, we realized that efficiency was only 50%. Because it is irrational to use this already weak and torn fascial support for supporting the urethra. It may give temporary relief, but it will not be permanent. Hence, these supports should be enhanced by using synthetic material like polypropylene mesh, which will provide permanent solution. Next, please. In the technique of meshplasty for SUI correction, the lost fascial support, as I mentioned earlier, is to give mid-urethra a support, which is by using a flexible, non-absorbable, non-reactive polypropylene mesh, that is hernia mesh at the mid-urethral level, thus providing immediate mechanical support. Mind you, it has to be a mechanical support. You have to use a foreign material. Lesser the material you use, better it is, because we all know after using these meshes, it has come out through the urethra, it has gone into the bladder, it has gone into the rectum also. So lesser the foreign material used, better it is. Since the defect is at the mid-urethra, support is only required at mid-urethra. Next, please. Subsequently, what happens to this mesh? This gets interpenetrated by fibroblasts, thus creating a tough support and preventing permanent descent of mid-urethra as seen in SUI, which I had shown earlier in my picture. Next, please. To study the effectiveness of mesh, since it was an original study, we took into consideration following factors: improvement in patient symptoms, duration of surgery, type of anesthesia, assistance from other surgical faculties, intra and post-operative complications, post-operative hospital stay, special surgical instruments, and the cost effectiveness of the meshplasty. Next, please. This clinical trial was conducted at Cooper Hospital from 2005 January till December 2016, and it consisted of 518 cases of meshplasty which was being performed for SUI correction at Cooper. Some of these cases were done by me, others were done by my residents. However, overall, throughout India, more than 2,000 cases have been done, more than 1,000 cases by me alone at different places. Next, please. What were the inclusion criteria? any age group. There was no restriction as far as age is concerned, pedity is concerned. What was more important was clinically demonstrable SUI with or without associated pelvic floor defect and positive Marshall and Bonis test and Q-tip test. These were the clinical evaluation which we used to do. We excluded all the cases of urge incontinence and urinary tract infection. After treating UTI, we tried to evaluate again and took the patient for SUI surgery. Next, please. Urodynamic studies were done in some cases wherever it is possible. The anesthesia of choice, if it was only meshplasty, it was done under local. However, general anesthesia or spinal anesthesia were used whenever they were associated with pelvic floor repairs. Next, please. Post-operative patients were ambulated by evening. Vaginal pack was kept if I have done ancillary surgery. Antibiotics, catheter removed on the same day. Residual urine volume was noted. Any leak on Valsalva's manure was noted on the same day. And I believe in giving vaginal douche, so I used to call them frequently to study the effect of this surgery. Next, please. Follow-up was done at weekly for 1 month, followed by a month till 6 months, and 6 monthly for 2 years, and yearly till date. Next, please. Pre-operative urodynamic study was possible only in 34 cases amongst all these, while post-operative was done in 20 cases. Out of 518 cases, 382 patients are lost to follow-up over a period of 11 years. In the remaining 136 cases, follow-up time varied from 1 month to 11 years. Next, please. This you can see we did a study at 11 months, 15 months, 1 year, 11 months, 6 years, 7 years, 7 months, 11 years. At the end of 11 years, you will find the success rate was 81.89% amongst all the patients. Next, please. We had very minimal complications. Hence, to summarize, it's a very simple and quick procedure which you will realize when you go through the video. It requires hardly about 10 to 15 minutes. It can be performed under local. No serious complications were noticed. Next. Post-operative febrile morbidity, local and systemic infection was not seen in any of the patients. Can be performed along with A repair and P repair, or with hysterectomy. Can be performed in medically unfit patients, and cost-effective procedure as compared to other procedures used in treatment of SUI. Next. Hospital stay was for 1 day, maximum 3 days if ancillary procedures are there. Does not require any special skill or special surgical instruments. Can be performed in remote places, short learning curve. Even a first poster can easily perform this surgery. Next, please. We'll show you the video, which is unedited video lasting for about 8 to 10 minutes only. I want you all to see, please, the video. I'll require voice also, please. Audio and video both. Can we have the video?
She is a case of genuine stress incontinence due to urethral hypermobility, which you could see. The first step is to pass a Foley's catheter. The principle is there is sagging of the mid urethra. Principle remains same as in TVT and TVTO. Basically, you have to support the mid urethra, and to support the mid urethra, you have to identify mid urethra. We pass a Foley's catheter, inflate the balloon with 5 ml of saline, and here you will see that I am trying to locate the internal urethral meatus. We know the external urethral meatus. So the middle portion becomes mid-urethra. If we are doing it under local anesthesia, one can use xylocaine with adrenaline or plain xylocaine, which is diluted with saline. While injecting xylocaine or saline adrenaline, you have to be careful to push the catheter still inside, otherwise one can puncture even the catheter balloon while passing the needle. You can inject almost about 20 ml of diluted xylocaine or saline adrenaline. After that, apply 2 Alice's forceps to identify the mid-urethral segment. Here you can see the mid-urethral segment. Now we inject in the para-urethral space almost 10 to 15 ml on each side. With this, the dissection becomes much easier and the bleeding doesn't occur. Make a vertical cut in the mid-urethral area with the help of 15 number blade. Catch hold of both the cut edges with Alice's forceps. Pass in an artery forceps or a mosquito forceps. Go all along the urethra on right side as well as the left side and create a space. Once you have created the space, you will be able to put your fingers inside. And when you put your fingers inside, you can feel literally the pubic arches and the rami. In case there is little bleeding from the paraurethral plexus, you can put a gauze piece. You can see the urethra in the center. A mesh is being prepared using polypropylene mesh, which is macroporous. It's the same as hernia mesh, which is almost 3 to 4 centimeter long and about 1 to 1.5 centimeter wide. It's a quartering rectangular piece. The edges are cut on the side so that it gets little shorter. Just place it in that area. Both the ends go next to the urethral on the lateral side. Since it's a tension-free tape which has to be used, so at the end you can keep an artery forceps between this. As the space created is very small, the displacement of the mesh doesn't occur. What we do is we use hernia mesh, and we can make almost 20 pieces of that hernia mesh, and mind you, it is autoclavable. So you can autoclave the pieces. Here I am putting an artery forceps between the mesh and the urethra. And once you have done that, and if there is good hemostasis, there is no bleeding, we can approximate the vagina with the help of 20 or 30 Vicryl. and close the vagina
Sorry to interrupt, but the time is already.
by a vertical mattress sutures. If you are scared to include the mesh in your stitches, you may take a continuous suture or interrupted direct suture. You may have to put 3 or 4 stitches.
Yeah, you can close the video, please. It's over now. The beauty of this surgery is if you realize it's about 8 minutes unedited video. And overall cost to the
These
patient turns
sutures
out to
have
be
been
rupees
taken.
50.
You can see the entire thing. The catheter is being kept for 4 hours, and after 4 hours, the catheter can be removed. We give 1 shot of antibiotic. She doesn't require any painkiller.
What's more important, if you look at TVT and TVTO, I want you to pay attention to this. When we take TVTO, they bring out the tape above, but they don't pull the tape. Neither they fix the tape. In TVTO, again, it goes to the obturator membrane, but nothing is being fixed. So you don't have to fix the tape. That TVT and TVTO, they pull out the tape so that it doesn't get displaced. While here my dissection is only that much. So there is no question of displacement. I'll request all the participants to please try it out. If any difficulty, I'm always there to help you out. Thank you. Thanks a lot.
Fantastic video presentation, sir. That was a very novel way of treating SUI, and basically the path is what the path of TVT is, right? Not transobturator.
Correct.
And sir, if I could ask, there are patients after doing these tension-free tapes who complain of retention. So how often have you seen?
In my case, there is not even a single patient with retention of urine.
Okay, because it is tension-free.
TVT, what happens when they pull it up?
Yes.
The basic idea why it is tension-free, let's try and understand. Whether we do hernia repair or we do mesh plasty or TVT, it has to be tension-free because polypropylene mesh will contract over a period by 30%.
Right.
So when it contracts over a period by 30%, it becomes shorter in size. And when it becomes shorter in size, it can compress over the urethra.
Okay.
That same principle is applicable even in hernia. In hernia also, they take a bigger mesh and keep it over there. They don't make it tight.
Right. Yes, sir. Okay. And any particular, dimension as to where the mid-urethral level is?
That is the reason I put in a Foley's catheter, inflated the balloon. That gave me an idea of internal urethral meatus. Yes. I knew where is the external urethral meatus. The middle portion becomes mid-urethra. Right. And that is where I infiltrated and did the things.
Okay.
Looking at it, I request even a first poster who can just cut it and do it. It's very simple surgery, very effective. Till 2016, I did follow up the patient. After that, I gave up because I realized that it has a good success rate.
Okay. Thank you, sir. Thank you for that.
Thanks a lot. Thank you. Thank you,
Dr. Niranjan Chavan, for giving me the opportunity to moderate this session. We'll move on to the next session.
Thank you, Dr. Sarogi sir.
Thank you,
Ala Sanjay Patel and Rishikesh sir for that wonderful talks which you have given and the question answer session being there. Sir, you are always a teacher of teachers and we all get inspired by your studies and your talks. And we will get back to you soon, sir. I request you to please wait online because there is a lag of 5 minutes. So always there will be few questions, after this next session. So please request you to be there for some time.
Thank you.
Thank you. Yes, Dr. Aki Singh, please come over.
Let me introduce the next moderator of the session, Dr. Rakhi Singh. She is the director of Albon Clinic and IVF Center, Noida, senior consultant and fertility expert. She is the chairperson of Endocrinology Committee of FOXY for the year 20 to 22. She's been the secretary of, she is currently the secretary of UP State ISAR 2019 to 21, organizing chairperson of North Zone UA FOXY 2019, and many other accolades. Dr. Rakhi Singh, may I request you to kindly introduce the next speaker? Thank you very much.
At the outset, I would like to thank and congratulate Dr. Niranjan Chauhan and the IAG, and best wishes for him for his elections, and wonderfully organizing this whole program. And we have got our stalwart of laparoscopy, Dr. Nutan Jain, who is well known internationally and nationally for her work. And to introduce Dr. Nutan Jain, it is a proud privilege for me. She is a director of Vardhaman Infertility and Endoscopy Center at Muzaffarnagar, India, elected board of International Society of Gynecological Endoscopy from 2006, member of governing council of ICMR, which is a research body of India, live telesurgery relay of laparoscopic surgery to AAGL in 46th Annual Global Congress in Washington, D.C., USA, nominated for AAGL Board of Directors in 2019 to represent Asia Pacific region, author of 8 textbooks of laparoscopic surgery, which has been translated in Spanish, Chinese, and very popular worldwide. And all her surgeries have been popular, and we've been growing, seeing her surgeries. Dr. Nutan Jain, we are going to hear, it's an honor to hear from her. She will be talking on sling surgery in nulliparous prolapse.
Thank you so much, Rakhi. And I know we've known each other for years together, and it's always been a pleasure going to Noida Society for the annual meetings. And at the outset, I will first thank Dr. Niranjan Chauhan for consistently arranging all these scientific extravaganzas, almost surety on every Sunday, and to meet nice friends like Rishikesh Pai, Sanjay Patel, and a nice talk by Dr. Rajendra. So today I shall be talking about the laparoscopic management of pelvic floor defects. Is my screen seen over there? Do you see my slides?
We can see your slides.
Okay. So since we are just beginning, so greetings from our center. That's my new endoscopy complex with nice striker theater complex. And we always have our trainings and fellowship programs. There's the outgoing fellows. And this is my daughter-in-law, Dr. Vandana, who's busy doing very advanced surgeries now along with me. It's a pleasure seeing her do surgeries and grow up alongside. So these are new hospital because I just took the liberty of putting few slides since it's a new setup, and in the corona times, such big outdoors, they're good work, we can have the social distancing very well. So now coming to the topic, we shall be talking about laparoscopic management of pelvic floor defects, and this has been my, very close to my heart since we went to Australia and all those places to see value for in the very initial years in the early 90s. And I still remember the Agra FOXY that had spoken about paravaginal defect repair. So at that time, it was sort of a new concept talking about laparoscopic management of prolapse repairs. So all of us know that prolapse is almost a type of a hernia where these attachments of the uterosacral and the cardinal ligaments, they break away from the pericervical fascia, and anteriorly the support is the pericervical fascia and posteriorly is the rectovaginal septum. So the prolapse repair, I would like to divide it broadly into 3 categories. One, entirely with the use of mesh. Secondly, entirely without the use of mesh. And thirdly, a combination techniques using the site-specific repair and augmenting those platforms with mesh. So an expert endoscopist who is drilling into these pelvic floor defects day in and day out, they have one plan ready, and if it doesn't work out on the table, they have another plan B ready. So we should have a handful of options so that we can mix and match depending upon the patient's anterior compartment, posterior compartment, and the other factors. So what are these factors which they have a large bearing upon what type of surgery we are actually about to do. So first is the age and the patient's own inherent tissue. What is her desire for fertility? Has she completed family? What is the overall muscle tone? A very important factor, because along with the muscle, her support system could also be legs or can still be utilized. Is she having an associated SUI which needs to be corrected at the same time? And the assessment of the anterior and the posterior compartments. So we believe in giving a global repair, strengthening the anterior compartment as well as the posterior compartment, so that when the patient becomes ambulatory, she gets a total repair. And we should try that we should correct all these things in single setting. And then what is the need of hysterectomy at the same setting? So there is no one surgery which fits all. So it needs to be tailor-made for according to each and every patient, her needs, her body tone, etc. So the vaginal wall prolapse is one of the commonest entities. And first I will talk about the time-tested old as gold procedure, the sacrocolpopexy. So first of all, we reduce the prolapse over laparoscopically inside, and then this is over the symphysis pubis. We open up the peritoneum right up to the levator ani muscle, and then we open up at the apex of the vaginal wall. And usually they will have a surgery. So it's very important to go into a correct plane of cleavage so that we can push the bladder down and expose the supporting structures anteriorly, the pubocervical fascia, and posteriorly the rectovaginal septum. So here you see that I am doing the site-specific repair utilizing a non-absorbable proline suture and obliterating the utrovesical fold of peritoneum from where the bladder prolapses, causing a clinical cystocele. So we apply, depending upon the patient's need, 2 or 3 tiers of sutures. And now we have taken a long strip of mesh, 15 or 10 centimeters in length, and we are anchoring it over to the apex of the vagina. And since proline has a lot of memory, so we need to take at least 6 or 7 throws and then tie a good knot. And here you see that I'm utilizing 2 separate strips of mesh, because the convention is to use a Y-shaped mesh, a Y-shape like this, anterior and posteriorly, but that usually needs proper evaluation, and at times it doesn't work out well. And so you are more independent and free to place these 2 mesh strips. So I take separate 2 mesh strips and anchor them together over to the sacral promontory. And it is better to be good in suturing and take sutures rather than using tackers. As all of us know, tackers have been associated with more paravertebral lapses and backaches and some complications which are quite inherent to the use of metal, though they are titanium, but still they can lead to separate problems. So this was sacrocolpopexy. Now comes another group of young patients when the uterus is to be conserved. So as we see here, a very young patient, good muscle tone. So in these patients also, there could be 2 groups of cases with the use of mesh or without the use of mesh. So this is lateral suspension. So all of those who have been doing surgeries for pretty long and seeing us operating in workshops, so this lateral suspension was popularized by Dubisson, and it is a very simple technique. In the same way, we took 2 mesh strips, okay? They are both 10 to 15 centimeters each. And if you see, we used to go by the side of the lower left lateral port, and by the side of the round ligament, in the subperitoneal part, we used to bring a grasper and take this free end of the mesh over to the anterior abdominal wall, and it used to be fixed over to the aponeurosis of external oblique muscle. So that is a tough structure. So this was the rationale of using the lateral suspension, and then this peritoneal defect used to be closed. But there were some problems along with this because it used to be very close to the skin. So mesh erosion was more of a complication. So then what the second phase which we worked for few years was a young patient with good muscle tone to avoid the mesh related complications and no issue of mesh in the future C-sections. We did only site specific repair. So if you see here, this is a grade 4 prolapse. I made these two red dots because people would not believe that only with the site-specific suturing, this much of closure of correction of the defects can happen. So this is the anterior pubocervical fascia application in several layers. And then posteriorly, if you see, is the uterosacral ligaments. So the uterosacral ligaments, we start the application at the level of ischial spine and go down separately on one side and then on the other side. We never plicate in between the two uterosacral ligaments, and this is the final picture which we achieve. So it is also a very good solution when the patient has a good muscle tone. Now comes the group of procedures which have a laparoscopic repair along with suturing and mesh both. So in this, I shall first demonstrate. Recently, it has gained a lot of popularity, the laparoscopic pectopexy. So in this we utilize the iliopectineal ligaments. So if we look at, this is the pubic symphysis, then we have the Cooper's ligament, and then more posteriorly and cranially, we have this iliopectineal ligaments, which are the posterior prolongations of the Cooper's ligament. So I will just show you a video clip. Here this patient has a grade 3 prolapse, again a young patient. So what we do over here is we utilize the harmonic A's, and the same way as the lateral suspension, we open up the peritoneum widely right up to the insertion of the round ligament. And then after exposing this, this is the Rumi cup which has been applied to show clearly the margins of the bladder. And here now I am exposing the pubocervical, the iliopectineal ligament. So this shiny white is the iliopectineal ligament. Again on this side. So we just open it up with the help of a harmonic A's, and you can see very clearly all the fibrofatty tissue is removed. The margins are the external iliac vessels, the internal oblique muscle. So in the midline, the multiple bites are taken to fix this about 3 centimeter with mesh, and we take continuous sutures only in that little oblong area to fix the mesh snugly in the midline. And then what I like most about pectopexy is that it is a bilateral fixation. So as we saw the evolution of procedures, and the lateral mesh suspension we have done for hundreds of cases. So once we got exposed to the pectopexy, now here we take one bite and then we take another good bite. So 2 bites in the iliopectineal ligament, they are pretty good. Then we come out over the mesh and fix it. And if you see here, that usually it lies in the anterior compartment, and there are no other structures which could come in its path. So it becomes relatively easier procedure for average endoscopist also. And the first bite, and then we take the second bite, and then out of the mesh. So this gives a good, and the best is the bilateral repair. It does not hamper with any nerves like the hypogastric nerves in the sacrocolpopexy there are no immediate vascular structure, though I will tell you there is one, and we really need to be careful about that. So after the anterior mesh has been applied, we close the peritoneum, and if at all the patient has SUI, after we close the mesh, the defect of the mesh is the peritoneum, then we can go ahead with the Birch colpo suspension. So from one end to the other, we just close the opening from where the mesh was fixed. So this does not entail any adhesion formation, and if a C-section has to be done, can be very easily done just above the mesh. And there are other applications of pectopexy also, which I will show you shortly. So in most of our cases, we get good results, and we also augment it along with the uterosacral ligament plication. So it's very interesting to see that it was an Indian doctor, V.M. Joshi from Pune, who has at least 5 publications in the year 93 to 97 in very reputed international journals on open pectopexy, and then later on he progressed over to laparoscopic pectopexy. So we really need to give credit to our Indian colleagues who have been good in the very initial years. So I will just show you how we do a pectopexy for wall prolapse repair. And here the mesh is a little wider in the center to cover the entire width of the prolapse, this wall prolapse in the midline. And the lateral strips are the same. So most of the other procedure will remain the same, but here we try to cover the mesh anterior to posterior so that it gives a very good repair, and it is really a nice procedure. So pectopexy done for whatever indication, there could be a risk of injury to the accessory obturator vessel, corona mortis. Maybe if you scratch, you will remember your lessons of anatomy. Risk of trauma to the hypogastric nerve and the iliopectineal ligament. So these are the benefits. And it's away from the ureter, intestine, sigmoid, and presacral veins and nerves. So that is a better procedure. But this I would like to show you that this is the iliopectineal ligament. This is anteriorly the Cooper's and posteriorly is the iliopectineal. So these are the accessory obturator vessels or the corona mortis. So if they get injured, they can bleed, as you all remember. So what I do is that I specifically go and look for them and preemptively coagulate them so that there's any risk of passage of needle through them is not there. So only this is the concern which needs to be kept in mind. Another simple procedure is the use of a Marceline tape. So again, this is a patient like wanting conception, and many of the patient the procedures when we were just preparing a paper on pectopexy, we saw at least half of our patients are for secondary infertility. So here what we are doing is and this was done in a SR workshop in Indore, I think, when Dr. Singh was, it was Indore. So here we open up the anterior compartment, we pass concentric tiers of sutures so that we have a platform ready over which the Marceline tape will be applied, and then this Marceline tape is fixed over to the uterus, over to the, like here. So we just, we are showing you how to placate the uterosacral ligaments starting from the ischial spine, and we do not cross over to the other side, because I always feel that the pouch of Douglas is meant to fill up. So if we cross from one ligament to other from contralateral sides, the patient comes up with de novo defecation defects, like there's always a feeling of fullness and the patient is never too happy. So it's a very good procedure to do, not always to be done from one side and then on the other side. And then we have brought in this Marceline tape, which we use for, we have seen it more for cervical tightening, laparoscopic cerclage. So from the other side, also from anteriorly, we pass it bring it out posteriorly, avoiding the uterine arteries, and then we pass it over to the sacral promontory. And here, both the needles are utilized and one passage each from both the Marceline tapes. And then we just tie the knot. So that is the end of the procedure. And for young patients who are just contemplating pregnancy, so that we do not hamper with the cervical os or anything, so this procedure can be done. So we will just close the mesh. So I think Dr. Sarogi has, Dr. Raki, can I just show a 2-minute video of SUI, or you are hard pressed for time?
Yes, ma'am, 2 minutes is fine.
Okay. So actually, Dr. Sarogi showed us the mesh, the needle procedures, like something like a TVT or TOT. But here I will show only for a cystocele. We can do a lot of pubocervical fascia application, and it takes care beautifully of cystoceles, but only of a mild to moderate grade. And then we can do the Bird's corpus suspension. So it is just the anterior part which I was showing here. So I'll just show you. We first pre-fill the bladder with about 200 ml of normal saline. So it nicely delineates the margins of the bladder. So now we try to reach the space of Retzius. It is easily recognized by this cotton candy space, and we see beautifully the coming up of the space of Retzius and the Cooper's ligament. So now I'm using an ethibond, and this is the paravesical tissue. So as Dr. Sarogi said, the bladder, the bulb of the bladder is inflated and it comes at the bladder neck. So first suture is passed through the Cooper's ligament, and we make the throws, and this suture is never tight very tightly. We have to just make a sling. The purpose of making a sling is that whenever the patient coughs, there is an increase in the intra-abdominal pressure, but then this sling makes an acute angle and the patient becomes continent. So as I said, we've been doing these procedures since the late, in the past century, I would say, from the 90s only, and it's been almost like 25 years, and we've always got good results with birds, and we do it a lot along with TLH. And we specifically ask the patients leading questions, as all of us know that many of these females are suffering from SUI. So these are the 4 birth sutures applied on 2 on either side, and then we close the defect with a continuous suture. And this is usually, I said, rather than being an isolated procedure, it's always to complete the pelvic floor repair to strengthen the anterior compartment. And so just a word about paravaginal defect. I will not show the video. So whenever the arcus, we know that the pubocervical fascia gets attached to the arcus tendinous fascia white line. So when it breaks away, then we have this a big anterior cystocele. So these are specifically starting by interrupted sutures from the anterior suprailiac spine. We complete. So I'm just not going with the video. So all of us know these are all the comforts of the laparoscopic route. So to give these elderly females a good quality of life, we resort to lot of pelvic floor procedures, and we have compiled them in our book, which is almost now a long time back. Just to introduce, because this book is very close to my heart, a lot of work has gone into laparoscopic entry, and the moment this book was released in Lucknow, we had this corona. So maybe you people may find a little more time to get yourself acquainted with this new concept of the primary approach to be non-umbilical to avoid the vessel, viscera, adhesion, and wobble. So it's time that we switch over to the laparoscopic repair. Thank you so much. Any questions?
It is always a pleasure listening to you, Dr. Nutan ma'am. And you make the topic so simple that it looks as if it is very easy to do it. But when actually we are doing it, it is, we know the difficulties what we have. And the steps explained by you are always a pleasure to hear and go ahead. Thank you, Dr. Waiting for the questions for some more time, ma'am. There are any questions, kindly wait over so that we can address to the questions. Dr. Chauhan, sir, do you want to?
Thank you very much, Dr. Rakhi. Thank you very much, Dr. Nutan, for a very inspiring talk. May I request Dr. Sachin, please come. Dr. Sachin has done his MD, DNB, FCPS, and DGO. He's a consultant and gynecologist and IVF specialist at Madhu Hospital, Bhandup, and Embryon IVF Center, Vikhroli. Dr. Sachin,
hi.
I see you in the car. Will you be able to introduce Dr. Krishna Kumar, sir?
Yes, I would be. Hello, everybody. It's my pride and my privilege to introduce none other than Dr. S. Krishna Kumar, sir. He has been the go-to person for hysteroscopy training, hysteroscopy queries in the city of Mumbai and Thane. Sir is Chief Consultant at JK Women's Hospital and Fortis Hospital, Kalyan. Sir has been elected to the IAG for the year 2020-2021. He was the Secretary General of ISAR 2018 to 2020. His centers are recognized for ICOG Fellowship, 6 months ART endoscopic surgery. His is a FOXY recognized center for infertility and endoscopic surgery training. Over to you, Krishna Kumar, sir, on your talk pre-ART hysteroscopy.
Yeah, I have to be allowed to share the screen. Sheshan, can you allow me?
Sir, the permissions are already there. You can proceed.
Thank you. Thank you, Sachin. Nice to see you after a long time. And thanks for the nice introduction. And I am obliged for being invited in this FEMAS International One-Day Workshop. And thanks to the convener, Dr. Niranjan Chauhan. Of course, as Sachin already mentioned, that hysteroscopy is close to my heart. And especially when it comes to infertility treatment, we know that hysteroscopy has a big role to play. But there are a lot of controversies when we consider hysteroscopy in infertility and ART still, though hysteroscopy is the gold standard for evaluation. Now, you will agree that the implantation is the magic of 2 E's, the embryo and the endometrium. Even with a good blast, grade A, if we put it, if the endometrium is not receptive or has something, it is not going to implant. So endometrium is the primary focus for us in infertility and ART. Despite this endoscopic evaluation of the uterine environment in infertile couples still remains understudied in spite of so much development in the last 3 decades. And we rely on the indirect way of evaluation, either by HSG, now outdated, but now we mostly rely on excellent sonography. Not to deny that sonography is improving by leaps and bounds, and the machines which are coming up can pick up so many things. But still, hysteroscopy, both evaluation and treatment, remains the gold standard as per several studies, which includes Betoki and all. Now, how is hysteroscopy relevant to, of course, macroscopic pictures? Both microscopic, hysteroscopy is still the relevant, and macroscopic abnormalities, it can not only treat, but sonographically, yes, I agree, macroscopic features can be definitely determined and can be, then posted for surgery. But hysteroscopy remains the gold standard as far as both diagnosis and treatment. Now, as far as energy usage is concerned in the uterine cavity, especially when we are dealing with a infertile couple, the studies are not clear which is better. We have the option of non-energy sources, but sometimes such large polyps may require slicing. And today we have the advantage of operative smaller sheets which don't require any dilatation. These 2 millimeter needles can also give you energy, and that's what we as clinicians who offer infertility treatment, hysteroscopy especially in infertile couples, should know that not to use the receptoscope, either go for energy, without energy, or go for these smaller diameter needles which are very easy to do. But what about microscopic pictures, features? Endometritis can cause endometrial delayed maturation leading to asynchrony and implantation. We know that in a country like India where COX and other endometritis is so common, it has been shown that almost 30% of women with recurrent implantation failure do have some form of endometritis, and this, I'm sure, sonographically it is going to be difficult to evaluate. So especially the features which we get in this hysteroscopy could be varies. It can be classical tuberculosis, but it could be micro polyps which are otherwise missed by sonography, focal hyperemia, stromal edema, strawberry appearance, hemorrhagic endometrial spots. All these are very, very, this upper one can show that it's classical of chronic endometritis, more likely to be Cox, tuberculosis in a country with so many small polyps. And this lower one demonstrates to a local strawberry-like appearance, which if detected can be taken, a biopsy be taken, sent for histopathology and look for those plasma cells, and then an antibiotic cover will definitely give the endometrium a better chance. So this is where hysteroscopy is important for identifying those subtle lesions which otherwise cannot be picked up. But pre-RT hysteroscopy allows the diagnosis of so many anomalies in infertile in almost 50% of IVF patients. That has been proved by several studies. But pre-RT also, it allows you to know the tract and small polyps which are there in the canal. So your embryo catheter doesn't get obstructed, and you can really identify the course and morphology of the whole canal, and which will ease out in transfer and not give you surprises at the time of transfer when you're planning and when you get obstructed and your catheter doesn't bypass that and go into the internal os or beyond. So that is where pre-IVF hysteroscopy has also been proven that it has got a big benefit. Now, of course, this controversy of adjuvant effect of hysteroscopy is still not proven, though there are several studies which show that definitely that improves local gene coding factors which are important for implantation. The studies are still controversial, but definitely there is some adjuvant effect of any manipulation inside the uterus. But these two studies, every opponent of hysteroscopy pre-RT quote, the trophy trial, which proved that doing hysteroscopy prior to cycles in ART doesn't have any effect. As you can see very classically here, the implantation in the hysteroscopy group and the same when the control group are almost same. 42%, 44% was the the pregnancy rate. So they say that it is not required, and this trophy trial became popular. And of course, to add it up with that, the INSIGHT trial, which also included couples who were going for IVF, pre-IVF hysteroscopy and without hysteroscopy, you can see the clinical pregnancy rate in both the group was 27% and 26%, and the ongoing pregnancy rate was quite similar, 21%. So these two studies laid to rest whether hysteroscopy is really needed, rather it's a waste of time and increases the morbidity. But there are fallacies of this trial. This very nice article published in the Fertility Sterility in 2019 revealed that patients who were included in the trophy trial, 45% of the patients had already undergone hysteroscopy and they were recruited as a control group, not done. So this was a big fallacy. And if you look at the INSIGHT trial, the fecundity and the fertility rate is very low, hardly 21%. So did they miss a lot of endometritis? See, 21% today, we wouldn't say a pregnancy rate is allowed. We would expect it beyond 30% at least. So whether the endometritis and other features were missed by this INSIGHT trial is the big question. And so definitely we know that pre-IUI of hysteroscopy has a no role. That has been proven beyond doubt. And even before the first IVF ICSI cycle, there are level A evidences which says that definitely hysteroscopy may not be effective in improving the implantation or the pregnancy rate. So that is where these initial studies have shown that definitely we do not have much benefit of doing hysteroscopy, but definitely there is a good evidence, level A evidence, that operative hysteroscopy, whenever you find abnormality, especially macroscopic, the polyps, fibroid, definitely surgical intervention, pre-infertility treatment or pre-RT definitely has a role, and you should go ahead and remove those pathologies, and definitely patient will be benefited. It is proved beyond doubt. Now, this paper, which we all know that all uterine anomalies congenital, if you look at the association of adverse reproductive outcome, we know that all the uterine anomalies have poor obstetric outcome. the number of abortions, the premature deliveries are increased in all form of septate, unicornuate, bicornuate, everything. But definitely even conception rate is diminished in patients who have septum. So you are justified today in incising a septum, preferably if you're using no energy, means to a 2 millimeter scissors. And definitely we can prove that it is a better, not only future for the obstetric outcome as far as preventing abortions and premature labor, even implantation. And this very beautiful study, almost of 2,400 cycle, published by Pryor et al., proved that patients who have abnormal uterus, especially the septate and the subseptate uterus, you can see the pregnancy rates dropped drastically. Whereas normal or arcuate uterus, the pregnancy rates were close to 45% or 42, close to 37%. When it came to septate uterus, you can see the pregnancy rates and the implantation rates drops to almost 22%. Whereas with a unicornuate or a bicornuate uterus, the implantation doesn't diminish. So septate or partial septum or complete septum definitely has some role in the implantation process, and you are justified in removing the septum in every case of infertility prior to ART, definitely. So this again is the same. Now, of course, there is no doubt that amongst all the fibroid which can cause complication, fibroid submucous is implicated not only in menorrhagia, but definitely it can prevent implantation. And today, there is no doubt that we cannot use, or rather we cannot avoid energy in this. We need to use energy, and hysteroscopic submucous myomectomy is a little difficult procedure, but you have to be very careful when you're dealing with such fibroids which are, LASMAR 7 or 8, which are located more on the lateral wall, and the length of its penetration into the whole myometrium is much wider than a polyp which is, partially pedunculated or rather totally type O. This is a type 2 fibroid. So here you need a little more skill. All those precautions for preventing the fluid overload will have to be taken. I wouldn't go much detail, but definitely you need to take care that you do not damage adjacent endometrium if the patient is definitely for ART, because you don't want endometrium to be damaged because of the heat and energy. And it's a level A evidence, and that submucosal fibroid in patients who have unexplained infertility has to be removed and gives good results. Now, whether to use morcellator or resectoscope is the big question, but it has been proved that maybe for type O, the use of morcellator, it may be a little faster, but whether it is of benefit as far as pregnancy or implantation is not been proved. But though we believe that morcellator will cause less damage to the endometrium, but technically it becomes a little simpler because the debris which otherwise float when you do submucous resection floats around and impairs your vision. But when you're doing with the morcellator, since it is being sucked and removed, you get a very clear vision, and maybe it is faster. That's what the studies say. But still, it is not easy to do a type 2 myoma with this, so it has its own limitations apart from the cost, but definitely it has a role in some of these patients who have type O or some cases of type 1, where you believe that endometrium gets less damage because of the morcellator. Now, whether, of course, I've already discussed whether you use the energy or no energy, and it has been shown that, of course, nobody has proven that use of energy is good, but we know that definitely endometrium is the important factor, and you wouldn't want to damage the endometrium and also dilate with those, inserting those larger diameter resectoscope. So practice with these smaller diameter sheath, and also use non-energy sources like the scissors, because apart from the preserving the endometrium, even if complications do occur like perforation, the damage is very, very negligible. So that is where I would encourage every hysteroscopic surgeon today to do 80% of the hysteroscopic procedure with these scissors, and never ever use energy unless there is a submucous fibroid or there are large broad septum which are vascular, and you need to use energy to prevent the bleeding and also the speed. Fibroids can never be removed by scissors, there is no doubt, but polyps, septum, everywhere you should go ahead and remove it with the scissors, and it is possible, especially even in cases of Asherman's. That is where of course, the incidence of Asherman is increasing with the use of hysteroscopic surgery. Prior to this, only DNC was the culprit. But today we have studies which show that when you are removing a single myoma, also the incidence of intrauterine adhesion is 32%. And if it's a multiple myoma, the incidence is over 45%. So large septum, the incidence is close to 7%. But the idea of showing you that today we can use office hysteroscopy and pick up these adhesions faster, especially if the patient had a recurrent pregnancy loss or implantation failure. Your office hysteroscopy can pick up these adhesions quicker. So before the endometrium gets sclerosed and damaged, if you remove these adhesions at a very early stage, the regeneration is very fast and they have as good as a normal woman having potential to implantation. So this is where you can see they appreciate that if you pick up early Ashermans, it's very, very beneficial, not only for the surgeon as far as doing the procedure is concerned, but also for the patient. Definitely we are interested in the patient benefits. So such Asherman should be picked up early. So we know how to be, because it's an iatrogenic disease, our procedure is causing. So why are we delaying in picking up Ashermans like this? Because the moment it becomes severe, the pregnancy rates drop from almost 89% to 45% or 33%. So this patient where 2-time DNC was done in a patient who had vesicular mole, you can see that adhesions have started right from the internal os. So you are not able to identify even the internal os. So here imagine dilating with a cervix with a dilator and then going or imagining you are in a false passage. Follow the anatomical principles of hysteroscopy. Follow those mucosal folds, and in the center will always be the internal os. And this judicious use of scissors, occasionally opening it, occasionally dilating it, you will be able to enter the uterine cavity in the proper plane. But definitely you need to create the good cavity before you can even think of starting the ART procedure. But definitely when a patient has such severe Asherman, you have to counsel them for a relook. But our job is to create the triangle first with the apex at the internal os and the base at the two tubal ostia. But the ostia may not be seen all the time, but it is for us to leave it to nature to regenerate the endometrium. So our job is to create the cavity. So that is where severe Asherman is always a challenge. Now, after hysteroscopic procedure, what should be the interval prior to do an embryo transfer? Now, it has been proved beyond doubt that polyp heals the fastest. You can do the next cycle transfer if you have done a removal polypectomy with scissors, not with the resectoscope. Septum heals the slowest because it's a lot of raw area, fibrotic area. So you have to wait for 3 cycles for the endometrium to grow over the raw surface. Post myomectomy, 2 cycles, and Asherman's depends on the severity. In a severe Asherman, after 2 sittings, we would evaluate it by sonography and see the zone, the color flow, and also the thickness before advising her to conceive or go in for embryo transfer. Now, stem cell therapy is a big ray of hope, though it's still clinical, rather, I would say experimental. But today, patients who have poor endometrium on sonography have been benefited. There are few studies where we do it in patients who have thin endometrium, but maybe in future, patients who have no endometrium like Asherman, will it be of great benefit is the question. So this stem cell or even PRP can be now injected through the hysteroscope subendometrially, about 0.3 to 0.5 ml on each of the 4 walls of the uterine cavity on the 3rd day under hysteroscopic guidance, using the simple, the ovum pickup needle on all 4 corners and leave it. And there have been, studies have shown that they do good improve, but still long-term studies, and one has to wait maybe for the future. This would be good or will be used in patients with severe Ashermans. Now, time to pregnancy, which is such a big new fantastic article published in this March 2020. We know that so many women who do not become pregnant after our infertility treatment, especially after 1 cycle of ART, abandon the treatment because of either psychological stress or because of the monetary burden. But we have all moved from live birth rate to cumulative live birth rate. So it's a great idea. You do multiple attempts in my cycle, I'll give you a pregnancy. That's the definition. So to improve the same, but still the pregnancy rates have been quite less. So to improve the same, we know today we have concept of add-on. The list of adjuvants which are being used in infertility or ART is enormous, especially if you look at the adjuvants of the endometrium. You can see the list is just so huge. We are using all these just to improve that implantation, and we are not bothered to check the uterine cavity prior to embryo transfer. And it has been proven, or this study which is published in this Fertility Sterility says that all these add-ons have been just useless, and they've added to the expenditure. Only after the hysteroscopy has been given the amber color by the FA, the Human Embryo Fertility Academy, by the United Kingdom. So instead of being helpful, they have to be proven to be hopeless. So if you look at the FR rating, all are red or amber. None of them is green, which indicates that you can use all these adjuvants in clinical actually, but we all continue to use and not bother about the expenditure which is involved. So it is for us to really introspect and see that whether endometrial scratching is going to really play some more important role. So to conclude, to reduce the time to pregnancy, which is so important for the couples and definitely for the doctors, that there are studies which say that the role of hysteroscopy should be reevaluated, since its execution at specific steps may improve the reproductive outcome of the infertile couples. Even Cochrane definitely concludes that. And today, the debate on whether hysteroscopy should be done in every case is never ending. But if you consider that in optimizing fertility, embryo culture conditions for the first 5 or 6 days matter, but do not anatomic factors affecting the next 9 months? So that is the big question which we all have to really introspect and decide. And today hysteroscopy is evolving. We all have moved from, OT-based hysteroscopy to a lot of ambulatory or the office-based. So it is time to rekindle our thoughts that for the benefit of the patient, they deserve nothing less. So we should move on and maybe perform hysteroscopy. So this hysteroscopy today, with the availability of even smaller diameter resectoscope, like you see this Goubigny resectoscope, which is hardly 14 French and can be used without anesthesia as we are using in this patient. So today, are we underutilizing hysteroscopy is the big question. So we should rekindle a thought and maybe advise hysteroscopy to every woman who is wanting IVF or ART and infertility which is unexplained. So I would just end my talk here. You can see a polyp being removed without any anesthesia in a woman who is just, even in this COVID pandemic, who is conscious and who is awake. Though of course we are doing it inside the operation theater because of the availability of all the machine. Doesn't mean that you can compromise on your equipments if you're doing something called as office hysteroscopy. So to do everything has to be in the same safety precautions which need to be taken in the OR has to be done in office. So thank you, my dear friends. So that is my concluding talk on hysteroscopy pre-ART. Thank you.
Thank you, Krishna Kumar sir, for that extensive and elaborate talk on hysteroscopy pre-ART. There are a couple of questions that come to my mind. If you would be kind enough to answer. First is, would you yourself at your center do or advocate a pre-hysteroscopy, a pre-ART hysteroscopy prior to the first IVF cycle, or only for failures?
Yeah, we do not see the indication. In a patient who is for male factor, I wouldn't do hysteroscopy. In a patient who is unexplained infertility, I would definitely like to do hysteroscopy because to pick up the other things. So where tubal factor is proved or unexplained infertility, I would definitely want to rule out infection inside the uterine cavity. So there we do first IVF, first hysteroscopy prior to embryo transfer, but not in male factor. We don't.
Right, sir. So thank you so much. Second question is for a suspect T-shaped uterus or a T-shaped uterus for a patient going for IVF the first time. Would you like to do a lateral metroplasty or a correction before going for IVF?
Yes. Now, of course, I didn't include that particular beautiful presentation paper which had come in the same Fertility Sterility last year about dysmorphic uterus and pregnancy. Definitely, it has been proven beyond doubt that if you select right cases, the implantation and the pregnancy, even spontaneous, has improved in patients with typical T-shape, because when your sonography, if you see the endometrium is rather, the volume is smaller, I would definitely want to do a lateral metroplasty in a patient with T-shaped uterus.
Okay. So there are a lot of postgraduate residents in the audience. So for their benefit of doubt, you mentioned in your talk about a strawberry pattern of the endometrium on hysteroscopy. Would
Yeah.
you be kind enough to elaborate more about that?
Yeah, that particular strawberry pattern is seen more in patients with endometriosis. You know, that is the endometriosis, almost 40% have endometritis associated. And this typical appearance of strawberry pattern is seen in those patients. So that again can be picked up by hysteroscopy only. So all these biopsy which you can take that typically and send it will prove that there are plasma cells indicating endometritis. So this we have seen more in patients of endometriosis.
Okay, sir, you mentioned about septum resection. After septum resection, say if it is a mid cavity septum, would you be putting a IUD or a Foley bulb, or just a preparation of estrogen?
Right. No. In septum, we definitely not put any intrauterine barrier after septoplasty. Only case which we put is complete septum and a very broad septum. But for small subseptate uterus, there is no role of any intrauterine barrier. And one more message is never talk of intrauterine device today. If at all you want to put any barrier, it has to be a balloon intrauterine, or second choice is a pediatric Foley catheter. It has to occupy the cavity well enough to keep the surface apart. So IUD is not to be used at all.
So that was my purposefully reason for asking, because even till date, we see come across patients who have had post hysteroscopy septum resection IUDs inserted, which again causes. So coming from you, there is a big one.
No, definitely.
Right. For you mentioned fantastic about the PRP and stem cell for thin endometrium pre-ART.
Yeah.
So what is your personal experience with that, and how is the response with
For me to,
thickening?
Right. For me to conclusively say is not right, because my number of patients are still in single digit, almost just 9 or 8 we have done. And out of that, of course, I don't deny that the results have not been that encouraging. Out of the 8 or 9 which I did, one patient whose endometrium was never growing beyond 5, it grew up to 8 and she conceived, means she's pregnant after embryo transfer. So out of 9, I would say 1. So that is not for me to really give a good opinion, because the number is too less. So we are just in a very early learning stage. We don't know whether we are preparing that PRP properly. So I wouldn't say, but yes, one patient we did get benefit out of the 9 I have done till now.
Right.
Thank you, Dr. Sachin. Thank you, Dr. Krishna Kumar. Excellent presentation, excellent moderation by Dr. Sachin. And you can see the dedication of Dr. Sachin Dalal. Though he is in a car, he is right now with us. But mind you, when you are driving, please be careful, and you have to be properly seeing the audience and also at the same time conversing.
I'm not driving.
Then if you are not driving, it's a very good message you are giving. I want to correct and tell every one of you, please do not drive and talk. So
thank you so much,
Dr. Krishna Kumar, it was a wonderful presentation which you gave, and a lot of questions being answered by you, practical questions. I want to tell all of you, we have crossed 1800 users, not only from India, but from Indonesia, Kuwait, UAE, Nepal, Bangladesh, I can just go on, Bahrain, Hong Kong, Kenya, and few African countries. So apart from this, I would like to take this opportunity to inform you all that Dr. Krishna Kumar will be taking over as the new IAGE president on 31st of October, and we are planning a big annual conference. This is titled as Mask along with AAGL. So please register for that. Those who are from abroad, you can get that benefit in dollars, and it will be surely a wonderful program for 2 days. And Dr. Krishna Kumar, thank you for sparing your valuable time.
And it's free for IAG members, so that is where it is important. For others, it is 1,000 rupees only, but IAG it's free. So please convey to every friend of yours. Thank you.
Fantastic. Thank you, Krishna sir. Thank you, Niranjan sir.
Thank you so much. Now I request the next moderator, Dr. Supriya Jaiswal and Dr. Devang Kanuga, to please join us. Thank you.
Yes.
I would like to introduce our next moderator, that is Dr. Supriya Jaiswal. She is the Chief Consultant doctor at SM Hospital, Patna, and specialist in Government Hospital, Bihar. At present, she is the treasurer of POGS, chairperson, Adolescent Health Committee POGS, communicator ISOPARB, executive member ISOPARB, and she is member to the most of the committees, that is Adolescent Health Committee, FOXY, Young Talent Promotion, Genetic and Fetal Medicine Committee, then Public Awareness Committee. She is the treasurer IFS Patna chapter and life member of ESAR, IMS and IFS. She has received many awards such as MP John Gold Medal, GV Ellen Murthy Award for Best Paper in Obstetric, and Gold Medal for Best Short Paper in Gynecology. Recipient of numerous certificates and award, and her special field of interest are high risk pregnancy and preventive oncology. Welcome, madam. Over to you.
Thank you. Thank you for your kind introduction. So a very good afternoon to all the
Yes,
dear
but
faculty
madam, I
members.
will have to leave after some time as I already there is one program going on in Mumbai, and with due permission, I have been there for last 1.5 hours. Wonderful. I wish all the best to Dr. Anupama Rao, and surely Pathfinder will find its path in Bihar and Patna. Dr. Neelam, excellent. Dr. Pragya, and all the wonderful members of POGS to be there with all of you. Thank you. Yes, yes. Thank you, madam.
So, shall I proceed? So, a very good afternoon to all the dear faculty members, the moderators, the viewers, and dear friends. It is my privilege to be a part of this very prestigious and highly academic endoscopic workshop. Thanks to Dr. Niranjan for making me a part of it. So now over to Dr. Dr. Devang Kanuga. He is MD DGO from BJ Medical College, Ahmedabad. Has attended advanced training course for gynec endoscopy at CICE, France. He has been doing laparoscopic surgery since last 17 years, done more than 20,000 endoscopic procedures. His major area of interest are severe endometriosis, fertility promoting surgeries, vaginoplasty, tubal microsurgery, and surgeries of prolapse. He is doing private practice at Ashirwad Women's Hospital, Ahmedabad, and Bariatric Hospital, Ahmedabad. So besides running FOXY approved endoscopic training center, he is also running various fellowship programs. He has conducted several CME seminars and surgical workshops. He has been the operating faculty at various national and regional conferences. He'll be speaking on the endoscopic management of congenital anomaly of female genital tract. So, with these words, I hand over the virtual mic to Dr. Devang. Over to you, sir.
Thank you, ma'am. Can I share my screen now?
Yes, sir. Please.
Can you see? No.
No, sir.
Okay. Yes.
Yes,
So
sir,
good
we can
afternoon,
see.
everyone. At the outset, I would like to thank Dr. Niranjan sir for giving me this opportunity. Respected seniors and dear friends and colleagues, I will be speaking on endoscopic management of the congenital malformation of the female genital tract. An understanding of congenital anomalies as they are encountered in clinical practice is greatly enhanced by not only a knowledge of normal embryology and the mechanism of formation of normal infants, but also an insight into the process that result in the development of anomalies. The identification and interpretation of such abnormalities constitute a real challenge to the clinician.
deviation from normal anatomy, embryological maldevelopment of the Mullerian or paramesonephric duct will result. They are basically benign condition with a prevalence of 4 to 7%. Moreover, they are associated with renal, axial, skeletal, and rarely cardiac and auditory problems. Now, before going to the management of congenital anomalies of female genital tract, let's see what is actually the normal development of the female genital tract. Mullerian ducts are solid columns or cords of cells. They join up caudally and then open into the urogenital sinus as Mullerian tubercles, which later canalizes. Upper part, they form fallopian tubes, and the lower part form the uterus, cervix, and upper two-thirds of the vagina. Sinovaginal bulbs, they form the mesodermal thickening from the lower one-third of the vagina. The membrane separating the upper and the lower vagina will disappear during the course of development. Vulva will develop in the area between the coccyx and the umbilicus from two genital tubercles. The tubercle, they fuses to form a single tubercle, which is known as clitoris. Posteriorly, two genital swellings are present, which form the labia majora. Medial to these are two folds, which are called labia minora. Gonadal development is, this is very important, gonadal development is separate from that of the ducts. So normal ovary can be present with absent uterus and tubes. Mullerian and Wolffian ducts are closely related, and because of that, there is an association with malformation of the renal tract. Severe congenital anomalies may be associated with chromosomal anomalies. So this was a few sentences as far as the normal development of the female genital tract is concerned. Now, what are the causes of this malformation? It can be either environmental or genetic because of the developmental arrest, hyperplasia, agenesis, aberrant development, and so many other reasons. This is an AFS classification, American Fertility and Society classification. We will go into detail as the time progresses. Now, the first important anomaly is imperforate hymen. Of course, there is no endoscopic management in this imperforate hymen, but to mention it, it is the persistence of fusion between the sinovaginal bulb at vestibule associated with primary amenorrhea and hematocolpos. Now, the treatment is very simple. What you have to do is you have to put a cruciate incision over the blue bulging which can be seen at the vulva. If the bulging is not seen, you can push from the abdomen, the whatever mass is there, it will bulge from the vulva and will be seen as a bluish discoloration there, and you can just put a cruciate incision there, and then you will be able to drain whatever collection is there behind this imperforate hymen. Now what you have to do is that you have to marsupialization is to be done as far as this hymen is concerned with the along with the vulva with the help of Vicryl, so that it doesn't get fibrosed again. So just put a small nick, as you can see, and all the fluid which is collected inside the menstrual blood, the whole menstrual blood will come out, and that is the end of the surgery. Another important vaginal abnormality is a vaginal septum. The developmental abnormalities from the normal single vagina includes vaginal agenesis, complete vaginal agenesis, or vaginal atresia, double vagina, or a longitudinal vaginal septum. As you can see in this video, a beautiful vaginal septum is seen and two separate cervix are there. Now the treatment is that you can do, you can have a vaginoscopic approach of this kind of vaginal septum, and you can resect it with resectoscope. As you can see in this video, I am showing a monopolar resectoscope, which is used to separate this vertical vaginal septum, which is present with the by vaginoscopic approach. So you can see two different cervices, cervices remain in the center. The most important thing here is to remember is that you have to remain in the center, bladder or rectum posteriorly. So as far as possible, remain in the center and keep on cutting the septum till you reach the cervix. Because you are using a resectoscope, hemostasis will definitely be achieved. Gradual resection is done till you reach the cervix, as you can see in this video. Incomplete septum usually are interferent. They are interfering with the descent of the fetus, but complete vaginal septum usually are not interferent because there is a whole space on one side from by which the fetus can descend. The next important congenital anomaly is MRKH, that is Mayer-Rokitansky-Kuster-Hauser syndrome, which is a condition that includes maldevelopment or absence of vagina, fallopian tube, cervix, and or uterus. The incidence is estimated to be about 1 in 4,000 to 10,000 live-born girls. 47% are associated with urinary tract anomalies. 12% are associated with skeletal anomalies. Patient will present to you with primary amenorrhea, difficulty in sexual activity. Most of the patients have primordial uterus and no periodic abdominalgia. Diagnosis, of course, is very simple. On physical examination, everything is normal. Beam or ultrasound, there is absence of uterus or there is a presence of rudimentary uterus. Karyotype is normal and hormonal analysis is usually normal. Now, this is a video I am showing of laparoscopic vaginoplasty by Davidov's procedure. As you see, initial look, if you see inside the abdomen, only 2 uterine buds you can see on both the sides, which are underdeveloped or non-fused, and in the center there is absence of uterus, and the pouch of Douglas is also free in this case. The most important step here is the creation of the vaginal space. Now, I have this unique method of creating vaginal space with the help of Hager's dilator. Now, whenever you observe or when you examine or see this kind of patients, there will be definitely a small dimpling at the level of vulva you will be able to see. And if you keep on dilating that dimpling without causing injury to either bladder or rectum in the center, you will be definitely able to create a beautiful vaginal space. Sometimes there is a vertical septum there, so sometimes you may need to use 2 dilators along with that septum, and after dilating with the dilator, you can cut that septum boldly in the center. Now, once you dilate up to the maximum number of dilator, just insert your fingers and then you can stretch the vagina or the vaginal space transversely so that you avoid causing injury to the bladder and rectum. Then the next step, which is very important, is the mobilization of peritoneum. And if these uterine buds are too large, you can remove it, or sometimes if they are small, you can keep it inside only so that the vaginal apex can be created with them, which will give more stability and strength to the vaginal apex, which is created later on. Again, as I said, mobilization of peritoneum is done from one round ligament to another round ligament. A semicircular incision is put anteriorly as well as posteriorly, and mobilization of peritoneum is done. If you are removing these uterine buds, then you have to remember that keep the whatever thickening or bud which is present there in the center, you have to keep it for the proper dissection of bladder and proper dissection of rectum, so as you can mobilize the peritoneum. There will be definitely a uterine artery, as you can see beautifully. Uterine artery will be there supplying these buds. You have to tackle and remove, cut it with harmonic or whatever bipolar scissors or whatever instrument you are using. Similar procedure is repeated on the opposite side. And then you can pull the bud which is present in the center vertically and then dissect the bladder. Dissection of the bladder and mobilization of peritoneum is very important, as I said, because you are going to bring that bladder peritoneum below up to the level of vulva. So that, if the dissection of the bladder is done properly, then the bladder will not come along with that peritoneum below. Otherwise, there will be a post-operative urinary issues to that patient. Similarly, posteriorly also, you can dissect the peritoneum and mobilize the peritoneum. Even on the lateral side, mobilization of peritoneum is required. Now you can remove the central part of the bud. Still there is some bud is present, then still you can pull and you can dissect the bladder over it further so that peritoneum is properly mobilized, and then you can remove it. Now you can ask your assistant to push from below with the help of a gauze on saw boulder, and then put a transverse cut over that portion, and you can open the vaginal space which you have created from below. You can see the brownish gauze there. Further mobilization of peritoneum is done on both the side. And then that peritoneum is brought down with the help of Ellis forceps. You can catch the peritoneum, or you can take a vicryl stitch also with the help of number 1 or 10 vicryl here, and then pull that peritoneum below with the help of that vicryl thread. Now, after pulling that peritoneum down, you have to take stitches of that peritoneum over the vulva. So I usually take 3 stitches anteriorly and 3 stitches posteriorly so that the peritoneum is stabilized there. Another important thing you have to remember, that whatever peritoneum you bring down has to be slightly thick peritoneum and not the thinner peritoneum. Otherwise, if the peritoneum is very thin, it will not stay there for a longer period, particularly in the post-operative period when you ask the patient to dilate with the help of a heart dilator. So for that reason, peritoneum is, whatever peritoneum you bring should be slightly or comparatively thicker one. So after taking this stitch, we have created the whole tube. Now we need to create an apex. As I said, if you are keeping these uterine buds there, you can use it to make an apex so that it will give more stability to the vaginal apex. A circumferential purse string stitch is taken, barring ureter on the lateral side. We have to take the fat of the rectum or the anterior wall of the rectum in that stitch also. Similarly, on the left side also, the same thing is done. You have to take the peritoneum and then tie that stitch to create the vaginal apex. So this is how you tie the stitch and the vaginal apex is created. So this is the final picture from abdomen, and this is the final picture from below. You can see on the first day I usually use the soft mold, and then from the second day onwards a semi-soft or hard mold are used. Usually about 6 centimeter length is created, and post-operatively maybe 1 or 2 inches, centimeters are, they get fibrosed, but ultimately you will get at least 4 to 5 centimeter vaginal length with this procedure. Now let's go to cervical abnormalities. Cervical abnormalities can be complete cervical atresia. The entire cervix may fail to develop. This may be combined with incomplete development to the upper vagina or lower uterus. There can be double cervix, as you saw in the previous video. It can be a septate cervix. There can be a complete septum starting from vagina to cervix up to the level of fundus of the uterus. So that also can be possible. As far as atresia is concerned, unfortunately, I don't have any video of cervical atresia surgery, but you have to create the vaginal space as I showed in the video of vaginoplasty. You have to enter the endometrial cavity through the abdomen, through laparoscope, and then you have to join both the cavities together to make a continuation. Another important are the uterine malformations. The incidence varies from 0.13 to 4%. Defects that result from the development of only one Mullerian duct or from the lack of fusion of the Mullerian duct. This may result into miscarriage, ectopic pregnancy, rudimentary horn pregnancy, preterm delivery, uterine dysfunction, etc. The diagnosis again is very easy. Discovery in either routine pelvic examination or via laparoscopy or by HSG. MRI also sometimes may be necessary to delineate the Mullerian duct anomalies and their extent, and of course the accuracy is 100%. So this is a classification of uterine anomalies, starting from unicornuate uterus, which again can be with rudimentary horn, without rudimentary horn, and that rudimentary horn can again be functioning rudimentary horn or non-functioning rudimentary horn. That again can be communicating rudimentary horn or non-communicating rudimentary horn. And second is uterine diadelphys, where there is complete duplication. Everything is double, starting from vagina to cervix to uterus. Can be a bicornuate uterus. Either it can be complete or partial bicornuate uterus, or an arcuate uterus, or a septate uterus. So these are all different uterine anomalies. Now let's say start with the unicornuate uterus first. The there is increased incidence of infertility with unicornate uterus, endometriosis, dysmenorrhea, spontaneous abortion, preterm delivery. Women with non-obstructive defects such as uterine diadelphys and unicornate uterus usually do not require surgical intervention, but sometimes they do. So this is a simple video of a unicornate uterus, just a diagnostic video. You can see only one ostia is seen and a tube-like uterine cavity is there. And this is a video showing a lateral metroplasty in case of unicornate uterus when you need it. Particularly, the basic aim of this surgery is to convert a tubular cavity into a triangular cavity. If patient has a bad obstetric history, multiple abortions, and premature labor and all those things, so you can create an enlarged cavity by doing lateral metroplasty with the help of cold scissors. Initially, I used to do it with monopolar resectoscope, but you can do it with cold scissors, and it's always better to use scissors in hysteroscopic surgery in the endometrial cavity to avoid damage to the surrounding healthy endometrium. So this is how gradually fiber by fiber cutting of the lateral wall of the uterus is done, just to create an enlarged uterine cavity or to create a triangular uterine cavity, and the similar procedure is repeated on the opposite side also, on the opposite uterine wall, so that from tubular cavity it becomes a triangular cavity and patient obstetric outcome will be definitely benefited. So this is the end result of the surgery. Then the second will be uterine diadelphys. There is a failure of the fusion of the two mullerian duct, complete duplication. There will be complete duplication of the, as I'll show you in the next video also. Then the bicornuate and septate uterus, incomplete fusion of two mullerian duct. There is marked increase in miscarriages that is likely due to abundant muscle tissue in septum. Pregnancy losses in the first 20 weeks were reported from the case studies, 70% from bicornuate and 88% from the septate uterus. Now, this is a video of a bicornuate uterus where Strassman's operation was done. You can see there is a complete well-developed two uterine horn on both the sides, and there is a complete vertical septum joining the bladder and the rectum posteriorly. So the first step is to dissect the septum properly and then dissect the bladder from there. You have to put two Hagar's dilator in both the cavities separately so that you can manipulate both the cavities separately. Harmonic scalpel is the best tool in these kind of cases to separate the septum, I mean this band, which is the fibrous band which is present between the bladder and the rectum. After separating that band and after injecting vasopressin, you just have to mark the incision where you want to put the incision for the unification of uterus. After marking, you can reach up to the endometrial cavity with the help of either monopolar or scissor or with harmonic scalpel. So this is how you mark it. And then with the help of monopolar hook or spatula, you can enter into the cavity till you see your dilator. And then you can extend that incision with the help of harmonic scalpel through and through up to the level of cervix on both the sides. Similarly, it is done on the opposite side. Now you can see both the dilators in both the cavity. Even the central part is open. And then unification is done in two layers. Of course, V-lock is a very good suture material which will give strength as well as proper tightness and hemostasis. So start from posterior and then come to anterior side, which will be comparatively easy to suture. I just fast forward the suturing part. So this is the end result, as you can say, as you can see, complete unification of uterus is done in case of bicornuate uterus. Then let's see the septum. Of course, Dr. Krishna Kumar sir has shown beautiful videos. Two videos I am showing as far as hysteroscopic septum resection is concerned. Both cases thick septum incomplete. One on the right side I am showing with the scissors, and on the left side with bipolar resectoscope. Very thick septum and long septum. Then only sometimes we use resectoscope. Otherwise, only scissors are advised, cold scissors, because again, as I said, to prevent the damage to the surrounding healthy endometrium. There are a few points to remember as far as septum resection is concerned, that you have to remain in center only, with equidistance from anterior as well as posterior wall. One more important point is that you have to stop at about 0.5 centimeter. You have to keep about 0.5 centimeter distance from the ostia. So you keep on cutting the septum and you feel that you have reached up to the ostium or about 0.5 centimeter from ostium, then you have to stop at that point of time there. Third point, that you have to keep on looking at the myometrium. If you see few pinkish areas, or you start getting sputters from the septum or the myometrium, that means that you have already entered into the myometrium and you have to stop at that point. In my view, undercorrection of septum is always better than overcorrecting and causing problems, bleeding and perforation like complications. As far as diagnosis of septum by hysteroscopy is concerned, when you put a hysteroscope at the level of internal os, you won't be able to see both the ostia simultaneously. So once you cut the septum and the cavity is expanded, you will definitely be able to see both the ostia from the internal os if you put your hysteroscope at the level of internal os. Now this is a video of T-shaped cavity. Very rare congenital malformation caused by exposure to DES. A T-shaped uterus will cause increase in the risk of early miscarriage as well as the risk of preterm labor and delivery. So this is an old video which is, where I have done lateral metroplasty with resectoscope in similar fashion as we do with scissors. The tip here is that whenever you give a stroke with monopolar or bipolar resectoscope, after giving the stroke, you just keep the, bring the pressure of the saline or glycine slightly lower, so that the cavity slightly collapses and you can see the bleeding spots or whatever bleeder is there, you can see, and you can coagulate. You will be able to see in the video here. So
Dr. Devang, we have just 1 minute to go, sir.
Stroke, just get the pressure slightly lower and you will be able to see the bleeder or whatever bleeding point is there, and you can definitely coagulate that bleeding point. You have to be very careful because you are operating on the lateral. There you can see the bleeding point, so you can coagulate. This is a lateral wall surgery, so you have to be very careful because uterine artery is just lying there. So only fiber by fiber or gradual resection is done. The next is rudimentary horn. Can be non-communicating or communicating, as I said. Non-communicating horn is present in 90% of the patient. A patient may present with cyclic pelvic pain, mass, ectopic pregnancy, or endometriosis. Surgical excision is the treatment. So this is
Dr.
a case
Devang,
I'm showing of a rudimentary horn.
Dr. Devang,
on the left side, you can see the normal uterus. On the right side, that is a functioning rudimentary horn which is present in patient head, and see some hematosalpinx in the fallopian tube also. So after injecting, basically you have to treat these rudimentary horn like a fibroid or a broad ligament myoma. So just inject some amount of vasopressin in the rudimentary horn as well as some amount of vasopressin, diluted vasopressin in the uterus, because you are going to separate this rudimentary horn from the uterus, so there should not be much bleeding. Remove the fallopian tube always when you want to remove the rudimentary horn. Here I am using harmonic scalpel. Gradual resection is done by pulling the rudimentary horn on the medial side. Basically, the steps are similar to remove the rudimentary horn as of laparoscopic hysterectomy. And as I said, you have to treat it as a fibroid. So just pull it medially, and then you will get the space and planes very easily.
Thank you, Dr. Devang. I hope
there will be definitely a separate
wonderful presentation you have done, Dr. Devang. We have already crossed the time.
Uterine artery also.
I request you
to
please
dissected anteriorly.
Dr. Devang, can you hear me?
So this is the uterine artery I'm tackling with bipolar and harmonics.
I think he is not able to hear us.
The important point here will be to separate the uterus from the, to separate the rudimentary horn from the uterus. So at that point of time, you have to be very careful that you remain as away from uterus as possible towards the rudimentary horn, because you don't want to damage the normal musculature of the uterus, because you are going to keep that uterus there only.
Dr. Devang, can you hear me? Hi. There is some audio issue with
With the
Dr.
help of
Devang.
harmonics, you can gradually.
I think so.
Support, can you please contact Dr. Devang that we need to stop now? We are
Yes.
already other faculties being waiting, and then we have to stick to time.
Okay.
Thank you, sir.
Okay.
Thank you, sir. I know there is some difficulty. Thank you, sir, for your wonderful presentation.
The most
and
important
Dr.
thing here
Surya,
is to suture the myometry and whatever is damaged here with the help of Vicryl. 2 or 3 interrupted stitches are taken, and you can suture it. I'll just fast forward because I have overshoot the time. I got a call. So this is how you suture it, the defect, so that it will give strength to the patient in future pregnancy. So just to conclude, the impact of common congenital anomalies of female genital tract is highly variable. Some anomalies may be asymptomatic, requiring no intervention. Good knowledge of basic embryology is important to understand the pathogenesis and clinical features of these anomalies. All gynecologists should be aware of this condition and possible clinical presentation. While some conditions such as imperforate hymen require a simple surgical intervention, other complex anomalies need careful assessment and accurate pre-operative assessment. The contribution of uterine anomalies to subfertility is poorly understood, and the role of uterine surgery needs to be further evaluated. So thank you so much for your patient listening.
wonderful, wonderful. So I request Dr. Leela, madam, to please start the presentation. Well, Dr. Leela Vyas is a wonderful lady, a kind human being, and she is a vice president of FOXI. She was a former professor and unit head at the SMS FEMAS Medical College in Jaipur, and presently she is a consultant at Cocoon and aesthetic and cosmetic gynecology at the Vyas Clinic in Jaipur. She has immense knowledge, a thorough professor. She also holds, apart from being the vice president of FOXI, the chairperson of ISA Rajasthan 2020 and an active member of IAG. I welcome Dr. Leela Vyas to please introduce Dr. Anthony Suai.
Good afternoon, everyone. Can you hear me?
Yes, madam.
Yes.
Yeah. Good afternoon, everyone. And thank you very much for giving this opportunity and to be a part of this conference. Very nicely that fertility enhancing is the point which we all require, because this is important for everyone, not only for the, just to say, for only the infertility specialists, but for all of us, all the gynecologists should know the basics, and all the topics you have taken is of a very important and practical importance. This, and I welcome Dr. Anthony here, and he is from Singapore, and he is the first gynecologist to start with a single puncture, a single incision laparoscopy for hysterectomy and myomectomy. And definitely, as we all call it as a minimally invasive surgery, definitely the new and newer advances are going on, and we want to put minimum incision over the abdomen, and that is the very important things. And those who are trying this thing, definitely they are helping the females, those who require also the I'll not say only that of a cosmetic purpose, but also the post-operative inflammation and other parts are also that. So Dr. Anthony is a medical director of ASC Clinic for the women's, and he is from a renowned medical center from the Singapore. He is from the KK Hospital Outstanding Clinical Teacher Award for training the gynecologists in advanced laparoscopy, and Excellent Services Award for the letters to the commendation in the consecutive year 2002 to 2012. Very congratulations, Dr. Anthony, for doing this very nice work, and is having so many awards in his credit. So I invite Dr. Anthony here for your lecture, and this will help us, all our audience, to learn from this learned person.
Thank you very much. Okay, let me just share my screen. Can you all see the screen now?
Yes, sir,
Yes.
we can.
Okay. Right. A very good afternoon to everyone, and thank you all for spending Sunday at this webinar. The program has really been very, very fruitful, and I learned quite a lot of things as well, and I hope I can contribute a little bit more to it as well. I've always been fascinated with laparoscopy because I enjoy seeing my patients after surgery recover as though they never went for a surgery. And so when single incision laparoscopy came on, I embraced it wholeheartedly in 2009. It was difficult at the beginning because there was quite a steep learning curve, but I felt that I'd rather be suffering and make it difficult at surgery than my patients suffering and make it difficult for them at recovery. So please let me share my philosophy of single incision laparoscopy with you all today. And I chose the title, Single Incision Laparoscopy, is it more than just mere aesthetics? So we all like to see our pre-op patients having an active life, doing all the sporty event, but we also like for them to have the same activities of daily living after operation in a short span of time. And so really speaking, we have moved away from surgery with this kind of cuts to maybe this kind of cuts with robotic surgery or conventional laparoscopy like this. But there are still more than one cuts in this tummy and still areas of pain at recovery. And so can we do better with just one cut? So this is a sports lady who I picked and said she only just want one cut please for surgery. And really speaking, this is what can happen after surgery, just a small cut down here. And about 2 months later, the scar becomes like that. You could tell that this is the same patient because she's got the same mole, okay? Sometimes we put the cut in the vertical axis, depending on how the belly button is shaped. We tend to put it in the skin fold. The cut of 3 centimeters over a few months will retract by another 30%. And a lot of time, the next year, the patient will not be able to see the scar. So is it more than just mere aesthetics when we do single incision laparoscopy? At the onset, it looks like it is all about aesthetics, okay? But really speaking, studies have shown that if you show women what kind of cuts they're going to have at surgery, be it a mini laparotomy or laparotomy, be it a conventional laparoscopy or robotic surgery, surprisingly, the women actually choose the mini laparotomy cut, as one small cut, as opposed to all these multiple cuts, even though they are small as well. If you introduce single incision picture into this patient, then surprisingly, they all choose the single incision cut down here. And so this is actually quite telling in the fact that these are lay women who prefer to have this kind of cut rather than multiple cuts of conventional laparoscopy. So it tells us that they strongly prefer single incision or mini laparotomy incisions. So it is all about aesthetics. But there are the other side of the coin, where a review of randomized controlled trials show that it does not really offer any much more advantage over conventional laparoscopy. And so really speaking, many papers also found no significant differences between single port laparoscopy and conventional laparoscopy. And so why is it then that a single cut does not give you much more advantage over multiple cuts. And I like to think of it like so. We started with open surgery, moving on to laparoscopy surgery and single incision surgery. There was the learning curve that we had to embark on to go from open to laparoscopy. And in that migration, the patient's benefit has all been reaped. There's another learning curve to go to single incision laparoscopy, but the benefit has not been as much as before. So all the benefit has been reaped by conventional laparoscopy. And so if you compare conventional laparoscopy with single incision, you will not find much more difference. But if you compare single incision with open surgery, then you will find a lot of difference again. Again, it is not about cuts. To me, I find that this train is about surgery refined, you know. And so it is about aesthetics, yes, but it's also about surgery being more refined. And so when we say laparoscopy, it is a more refined surgery than open surgery. Then why do we need 3 cuts and not 1 cut if we can do laparoscopy? Because mind you, there are complications with the other cuts in the site, as well as even 5mm cuts causing hernia. This is not to say the single incision won't have hernia, but the single incision at the belly button will definitely not have bleeding issues. And so really speaking, are there cases that we can employ single incision laparoscopy? And I say yes, because there are small cases like ectopic pregnancy, small cysts or small fibroids that are indenting the endometrium causing bleeding, or cases like dysfunctional uterine bleeding, early cervical cancer. All these are relatively normal sized uterus, where in the past, we asked our doctors to move from open to laparoscopic surgery. But what about now? Can we ask them to move from laparoscopic surgery to single incision laparoscopy? And so studies have shown that if you compare single incision with multiple incision for simple procedures like BSO, then the time to get in is actually faster. The pain is also much less. And similarly, for scar image and body cosmetic satisfaction is always better for single incision. Similarly, in the myomectomy studies, where they compared fibroids in both arms of about 6 centimeters to 7 centimeters, the pain requirement may not be statistically significant, but they tend to use less. Then, of course, again, the objective and subjective assessment of the scar much better in the single incision. And so this paper says that although there's no difference in the operating outcome, there is better patient satisfaction. Even in oncology, there has been many papers comparing single incision and multiple laparoscopy, and they all say that provides a feasible, safe, and promising MIS modality for treating cancer patients. So we started single incision laparoscopy in 2009, published our first case of single incision laparoscopy hysterectomy for stage 1A1 cancer of the cervix, and move on to do myomectomies in 2010. These are the initial results, and I was trying to compare my time, whether it took much longer between open and between conventional and single incision, and I found that it's about just slightly more than conventional. And like I said in the beginning, I rather spend a little bit more time here and let the patient recover much faster than rush through surgery and the patient have to take longer to recover. So moving forward, when we try to encourage single incision, there are benefits, but there are also disadvantages in terms of the visibility, maneuverability, and countertraction, and triangulation, and ergonomics of single incision. And so really speaking, very few gynecologists use single incision approach because of this advantage, and they feel that it outweighs the potential advantage. So really speaking, it is these 3 issues that hold people back, and with it, maybe the depth perception of the visualization, the crowding of the instruments. Like if you put all your conventional instruments like this to do single incision, there will be lots of crowding. But technology has come about and give us flexible tip laparoscopic camera in terms of the Olympus EndoEye. And this has really helped me reduce crowding, because if you look at this setup, you can bend the camera tip and keep the camera head at the side. And so when you do surgery, there's no crowding whatsoever. The vision is here and the operation is here. And so this overcome the crowding issue. What about ergonomics and triangulation? How do we do surgery inside through just one small cut? So I always like to look at the orientation in terms of altitude. So this is where the camera goes in, operating ports goes in. So I put like a plane between these two, and above this plane is the optics plane, and below this plane is where I do my operation. And so instruments should not clash. And this is what it might look like inside where we do surgery or cystectomy. This is my initial cases where you can see rupture of the dermoid. At some time you realize that you can move. At some time you realize that you can move the instruments in only one axis, meaning you can move it in the North Pole very freely, but somehow you just can't get the instrument to move it freely in the South Pole. And then at other times, you can actually see the instrument moving very freely in the South Pole, but you can't move it freely in the North Pole. So what's happening down here? So if you pull, so this is very free movement in the South Pole, but very limited movement in the North Pole. So what's happening down here? If you move the camera back, then you'll realize that it is the instruments that are fighting down here that's preventing your operation. So this fighting your instrument prevents the North Pole movement and only allows the South Pole movement. To overcome it, we circumscribe. We go over, and now you are free to move in the North Pole, and you can come back and freely move in the South Pole. So this is what I mean by circumscribing over the instrument. And so you could see that the instrument goes in to the belly button hole, and you can circumscribe. And so if you think of it like so, this setup will not be good because you can't circumscribe that well. This might even be better. So if cost is an issue, the glove port with the Alexis retractor can give you a wide distance to circumscribe, but not this. So this is how I overcome cystectomy, myomectomy, and the such. What about triangulation? What is triangulation? It is actually the triangle formed by the ports at the point of surgery. So it is actually on the outside, you can see the triangulation, but the active triangulation is actually at the point of surgery. And in single incision, there is triangulation in the vertical plane. If you look at it from the sagittal view, the triangulation is actually front to back. And if we appreciate the triangulation of front to back, coining the vertical zone triangulation, people have appreciate this concept to do suturing. And so really speaking, if we appreciate triangulation in the vertical zone, it is almost the same as triangulation in the conventional laparoscopy. What about traction and counter traction? So if we do fibroid surgery for single incision, I find it easier because we need to pull the fibroid out and we need to push the uterus down. This counter traction and traction in the vertical axis is much stronger than if you were to do it from the side ports. And so it gives the myomectomy a much easier surgery than the normal conventional laparoscopy. And because the instruments are from the belly button, there is an additional trick that we can employ, and it is the rotation. So to a certain extent, when the myomectomy is done, you can actually twist the whole fibroid slowly, and the fibers will give, and you remove the fibroid like as though you remove a polyp at the cervix. And so this cuts down surgical time, cuts down bleeding, cuts down damage into the endometrium. And if you look at it, you can see this is a fibroid indenting the endometrial cavity, and we did not enter the endometrial cavity. So those are tips that we can use to overcome the disadvantage or the difficulties of single incision laparoscopy. And in this video of a single incision laparoscopy, we will encapsulate all those points. So after vasopressing has been infiltrated, I use the Thunderbit to do myomectomy. Now this is a gauze that I put into the peritoneal cavity, and I can actually use the gauze to push the fibers, the pseudocapsule of the fibroid, as well as wipe out the blood. And when most of the fibers are done, the twisting action releases the myoma. And really speaking, there's minimal bleeding, and suturing is done appreciating the vertical zone triangulation. We put 1, 2, 3, throw a loop as though it is a vertical zone triangulation, and then tie the knot. So it's very much like conventional laparoscopy, except that we do it in the vertical zone. And over time, I've realized that you can even do tying of knots by one instrument. You hold steady the other suture, loop the PDS around, drop it in the loop, and then come back out slowly. And there you go. You have completed a tie with a single instrument. So single incision laparoscopy, single instrument knot tie. One more time, you go around, put the end through the loop, leave it there, slowly come out, and tie the knot. So at the end of surgery, it looks the same as conventional laparoscopy. We put on the interseat, and nowadays I morcellate the fibroid in a bag. The neat trick is to put water in the bag to keep it open, slide it into the bag, and we don't need mechanical power morcellator for this. This can be brought to the belly button, and using the C-cut technique, the whole fibroid can be removed in big chunks and very fast as well. And so there's no spread of the tissue. You can see what you're doing, and it's clean and clear. So that's single incision myomectomy in a nutshell. This case was done over the weekend, just last week. And if you see this, you'll recognize that it is a torsion. It is a cyst in the right ovary with the torsion in the tube, with the torsion of the pedicles down there. So it's also done by single incision laparoscopy. And she had 5 days of abdominal pain before she came. Fortunately, the ovary is still healthy. The tube itself looks a bit bruised, but after untwisting about 3.5 rounds, you could see at the end of surgery, the tube's vasculature coming back. And so this is final twist that you can see at the IP ligament and ovarian ligament. Very, very gingerly, the tissues are very friable, and you do not want to cause any excessive bleeding. And slow and steady does it. And once it has been untorted, we can see the femoral end of the tube. There's a big edematous. And proceed on to do the cystectomy. And again, I normally put a gauze inside this time. This gauze is now at the pouch of Douglas holding up the ovary. And the sucker is quite effectively used to do the cystectomy as well as suck out the edematous fluid. So it was about 6 centimeters dermoid cyst with a large component of clear cyst. So fortunately, that made the surgery easier. And at the end of the surgery, we managed to save the ovary. Of course, the cyst is routinely removed in a lap sac to prevent spillage. And the ovary itself, no bleeding, no need to buzz and burn, no further damage. And the gauze is there to help suction, keep the bowel away. And you can see this anatomy, this uterus. it looks small because this patient is a 10-year-old girl, 28 kilograms. So imagine the joy that the parents had at the end of surgery, seeing the 10-year-old girl having just a 2.5 to 3 centimeter cut at the belly button. So that's just one cut. So we remove 9 cm fibroids before. What about if the patient also had a gallstone? And so this was this patient with 2 pathology, where we remove the fibroid, we turn the camera around, and my surgeon friend remove the gallbladder. And so really speaking, it is a rare 2-in-1 surgery for the patient who really reap the benefits of single incision surgery, because it could have been 2 open surgeries, or it could have been 4 to 5 cuts because of the different angle of the surgery. But she had it all with just 1 cut. And so really speaking, if we can accept change and understand technology can help us improve, change our mindset to convert and reinvent ourselves, then single incision surgery is possible. So it's all about surgery refined, but more so, it's about surgery redefined. And if we accept change, we can improve ourselves, because to improve is to change, and to be perfect is to change often. And so single incision laparoscopy, is it more than mere aesthetics? I say it is more than mere aesthetics. So it is surgery refined to perfection. Thank you very much.
Wonderful presentation, Dr. Anthony.
Thank
This
you.
is Dr. Niranjan Chavan from Mumbai, your host.
Yes.
You are a pioneer in
Yes.
laparoscopic single incision surgery, and the quality of the videos were awesome. And I want to tell you that more than 2,000 members are registered now to see your wonderful presentation.
Thank you very much.
Yeah, thank you, Dr. Anthony, and very nicely presented. Just one question I want to ask: what is the learning curve in this, especially in this technique, and the other technologies you are using the camera, which I think it is only with the Olympus, no?
Yes.
It's not with the other companies.
Yes. So the camera issue I'll answer first. That's the easiest. With the Olympus flexible endo eye, it makes things easy. You can also use a 5mm 30 degrees endoscope with a long bariatric type, and you can also move the camera head to the side a little bit. With cow stalks, they have got the endochameleon, where the tip of the head rotates about 60 degrees. So instead of a fixed 30 degrees rigid scope, imagine the 30 degrees can rotate somewhere from 0 to 30 to 60 to 90. So these are the various scopes that we have for single incision laparoscopy. Really speaking, sometimes if we move the camera a bit further back, then you can move the camera head to the side, and that can help reduce the crowding. Coming to the learning curve, I would advise doing removal surgery first. So I started doing hysterectomy because it's the relatively easier one. If you get the normal size uterus, all you need to do is the uterine, the bladder, and then the Coles cup will demarcate the vault, and then you can remove the whole uterus. If suturing is a problem, you can always do it vaginally. With V-lock now, it's very easy. You don't even need to throw knots. So when ergonomics difficulty is overcome, then move on to myomectomy because of the morcellation issue, because of the traction and counter traction, and because of the amount of suturing. I would leave actually cystectomy in between or towards the end, because it is not easy to hold the ovary up and do cystectomy with the other hand alone. And you need a lot of lateral and horizontal forward backwards motion to release the cyst. So it's always good to open up the ovary, as you saw, horizontally, so that gravity will allow the bottom part to drop. If you open the cyst vertically, you're going to have a lot of problems taking out the cyst. But the reverse is true for myomectomy. Always do a vertical cut because suturing is easier. If you do a horizontal cut, it's going to be very tough suturing.
Yeah.
So all these issues was what I think through every day to get single incision laparoscopy to the level that I practice now. So I do about 95 to 98% of my surgery all single incision. I only do maybe 2 or 3 open surgeries for big ones, and I hardly do conventional laparoscopy anymore, except if it is severe endometriosis. So actually we have a video on excision of endometriosis by single incision, but I thought maybe that would be for another day.
Okay, that's good. So we hope we will see that video also. And congratulations.
Thank you very much.
Congratulations for this excellent surgery and this single port. Really, it's not only aesthetic, not only cosmetic, it's beyond that you have explained. Thank you very much for joining us.
Thank you very much for the invitation.
Thank you.
All right. Okay.
Thank you.
Thank you very much, doctors. So if we may move on to the next lecture, may I request Dr. Amrita Singh, who is a fertility IVF consultant and gynec endoscopic surgeon at Dr. Sudha Tandon's Fertility IVF Endoscopy and Maternity Center. She is an MOGS Youth Council member since the last 4 years, member of Foxy Sexual Medicine Committee for year 17-20, member of Foxy Youth Talent Promotion Committee 2020. She has had her Advanced Minimal Invasive Surgery Fellowship from Delhi, Masters in Reproductive Medicine and IVF Homerton University, London, UK. May I request Dr. Amrita to please take ahead proceedings.
Yeah, thank you, Mr. Seshan. So moving on from the wonderful endoscopic lectures that we've been listening to all day, the next lecture is going to be presented by the very vivacious and brilliant Dr. Anu Chawla. She is a specialist in reproductive medicine at the Barts NHS Trust, London, member of the RCOG London and a visiting consultant, New Delhi. She is going to be speaking on ovulation induction in infertility and ART. Over to you, Dr. Anu Chawla, madam.
Thank you everyone on board. Congratulations for a lovely show today, and thank you Amrita for a lovely introduction. I'm trying to share the screen. Let me know when you can see that.
Yes, it's visible now.
Yeah, okay,
Yeah.
All right. So hello everyone. To begin with, so I'm focusing more on the ovulation induction. So induction is basically when we aim on stimulating single follicle, and stimulation is when we go beyond and our aim is to have more than one follicles. To understand ovulation induction and stimulation, keeping in focus what not to do will be the agenda. So there is a very interesting thought that what keeps the ovarian reserve a reserve. So Sherman Silber, who is probably the oldest living practitioner in the subject of subfertility, so his thought is that it is probably the physical pressure and the actual physical forces that control the primordial follicle activation, and it is purely a pressure-based mechanics. It's physics more than biology or chemistry. It's a biophysical process, and the evidence is coming very overwhelmingly, including that from the Hayashi's lab, which is actually the lab which is working on the making of the gametes from the somatic cells. increase in this pressure in the incubator and the in vitro environment generate oocytes stop. So they stop developing when we increase the pressure in the incubator. AMH declines during late pregnancy and again increase to the pre-pregnancy level. So all these are the evidences. So why am I not able to turn the screen for? Okay, so 1 second. Okay, I'm not able to go to the next slide for some reason.
Dr. Chawla, may I request you to stop the screen share and start it again?
Yeah, I'll do that. Okay, there's something wrong. So I'll have to keep it like that. So I probably can't go on the screen. The full screen. That's fine. I'll keep it. I'll do it from here. So the other, sorry for the interruption. More number of pregnancies. Does that mean that a woman who have had a larger number of pregnancies in her life means longevity of the ovarian reserve? Probably because of the pressure that happened, and that physical pressure keeps the ovaries not active, and then it is a reserve for a longer time. So pregnancy probably preserves ovarian reserve and ovarian longevity. Similarly, if you just physically increase abdominal pressure for some reason, there has been some studies by Teramoto and Silber in 2016. And also the new things are coming up, like generating germ cells in the humans from skin cells. And so it is not de-differentiation of those cells. And it is a functional pluripotent stem cell which is injected into the, so if we actually do that, it will only give rise to a tumor. So we do not de-differentiate, we only go and further change the line of the differentiation. So this was just a thought in the beginning. So now I'm coming main into the technical part of the ovarian stimulation and ovulation. So if we see, we actually do not have a document which says, okay, which is the right way and what is the recommendation. Literally, there is actually not much structured work done which tells us clearly that what is recommended in what scenario. So this is a very fantastic document which Cindy Fucker has prepared with a group for the WHO guidance. So if at all there's any discrepancy, they have addressed to 10 main clinical questions, and they have actually taken the whole literature into account. Whatever, legible, there are a huge number of RCTs actually included in the whole mission of answering these 10 main clinical questions to be able to guide WHO if at all there are medical legal issues or otherwise to give a structure to the thing. The next is we have ASRM. So when we talk about unexplained cases, there is a recent February 2020 in ASRM guidance for the unexplained. So it's very important to focus on what is being said here. UCC, the treatment of unexplained infertility, is by necessity empiric. For most couples, the best initial therapy is a course of IUI. So they have really focused, if I cut short and give the main message out of this, it is that do IUI, use CC, and letrozole is yet not FDA approved. So whenever you choose letrozole, please tell this to the patient that it is not licensed to be used as an ovulogen, and please document that you have told the patient, and then they are happy, and then you use letrozole as an alternative to CC. Use IUI in a scenario of 3 cycles of IUI, and after that it doesn't make much sense to keep repeating IUI. because we do have a very large study, I'll come to that, which is an old one, but more than 4,000 is done, which says that it's time wasting after 4th IUI if you just remain there. So recommendations are use CC with IUI and letrozole with IUI treatments to be considered as an alternative. Please come back to CC or at least consider doing that. It is recommended that a single IUI, not single insemination, not dual insemination. Yes, definitely in the male factor, you can do dual insemination. Another interesting thing is they have said 0 to 36 hours. I have seen many presentations, some very significant names have been saying 42 hours. So if that is not being, sorry, you are controlling, excuse me, you're controlling my screen from somewhere, but I don't want you to do that.
No, madam, there is no control of the screen right
Yeah,
now.
I got a request that someone wants to control, the host wants to control. I approve that.
Yes, ma'am. Continue, ma'am. Now continue.
No, you've brought me back to the first slide. Please don't do that. You have asked me for the permission, I've approved, but then you brought me back to the first slide. Let me control the screen.
Okay, ma'am.
Please go back to where you were. I can't do that now. Sorry for this.
Now control on you. Yes.
So single insemination has to be done, not double, and 0 to 36 hours. So if at all you want to document ovulation, although it is not a necessity, but you can, but it doesn't make much sense to delay after 36. Many people do it at 24 hours. I have worked in a unit in which we used to inseminate at around 30 hours and we had good results. What is not recommended? Do not combine CC or letrozole with gonadotrophins. Do not use any, either low dose or the conventional dose of gonadotrophins with IUI. This is very opposite to what we have recently been listening, watching, doing. But this is the ASRM recommendations that they have suggested us not to use gonadotrophins in IUI. Although ESHRE recommendations are that you can use gonadotrophins even as a first line if you do have the access and the commitment from the patient to come for an ultrasound monitoring. So it's your choice. The live birth rate, the clinical pregnancy rate doubles when you use gonadotrophins as compared to the oral, but ASRM has not supported the use of gonadotrophins in the IUI. This is another, so this paper focuses on the stress of coming back to IUI. It's a wrong message going to somewhere from the nice guidelines which said that IUI is useless. It's definitely it has a value when it's used in the properly selected patients. This is the paper in which they have proved that after the 3rd or the 4th IUI, it doesn't make much sense to stick to IUI, and that is the time to move to IVF. If we talk about the multiple pregnancies, most or a large part of those pregnancies which are multiple are from IUI and not from IVF. And this is the US data in 2004 in front of you. When is the time to go to IVF? After 3 failed cycles. Set your aim and then choose the protocol, select the dose, and what we must aim for is a coordinated cohort. 15 was the number given by Shesh Kamal Shankara when she said that if we have 15 good M2s, we are in a better position. But there are recent reports now which focus on the number 27. I don't know what they've done to come to this number, but this is the new number. So 220. So many people ask, what is the dose that you start? So 225 is a very popular dose. I'm not recommending this, but I'm just sharing that this number is a very popular dose in the normo responders. How you predict, we all know AMH and AFC. Pre-treatment with hormone therapy, this is very important. So for the agonist cycle, there is insufficient evidence to make a recommendation for or against. But for the antagonist cycle, please focus that it is not recommended to use OC pills as the pre-IVF treatment when you are planning to do an antagonist cycle, because they reduce the pregnancy rate, they increase the FSH dose, they also increase the duration of the treatment that the patient needs. Progesterone treatment may be used, actually it is marginally proving to increase even the pregnancy rates, and there are insufficient evidence of benefit to develop a recommendation for estrogen only pre-treatment. However, if you ask me, I would rather choose an estrogen for a pre-treatment starting from the late luteal phase, and there is a paper which says you can even continue till the time of the trigger. This is that paper, effect of estrogen priming through the luteal phase and stimulation phase in poor responders in vitro fertilization. We deal here with a lot of patients who are older patients. Probably estrogen priming works well in those patients, but the evidence is not sufficient. So again, if we talk about that, no evidence of effect was found on the number of the live births when using any type. OC pills in agonist cycles compared with no pre-treatment are not associated with the difference in the clinical pregnancy rates, but definitely, as I said, that in antagonist cycles, they were associated with the fewer ongoing pregnancy rates. Compared with the placebo or non-treatment, progesterone probably, so this is actually coming from that Scindia Fucker paper, which I shared in the beginning. So this is based on a huge data, large number of patients and studies. The next is in antagonist cycle, estrogen pre-treatment was associated with a significant, so the length of the gonadotropin used also increased. There are some recommendations by the SI, because we didn't have enough any structured proper manuscript. So SIG of Eshrey, which is on the reproductive endocrinology, came forward and made a document. And so on day 1 or 2, if you see estrogen is less than 80, that will be the best thing that you can do to bring a coordinated synchronous cohort in the future, which should be one of the prime aims. So estrogen probably not accepted. These are the recommendation of Eshrey group. Progesterone again probably not acceptable. Antagonist is also used as a pre-treatment. How? We give it for example, you want to time it accordingly and you don't want to start this is what some people do. They give antagonist dose on day 2, 3, 4, but it is probably not recommended according to this guideline. OC pills not recommended, especially in antagonist protocol. Lower ongoing pregnancy rates. Coming to this, when we talk about antagonist and versus long, I have actually seen now in many units that they do like long protocol a lot. They think they get 1 extra egg and they can give a higher pregnancy rate, which is documented in the evidence. Megaset trial is a huge trial, which this is a 2019, the latest outcomes based on. So it focuses on the use of the highly purified HMG, even in the cases of PCO. If you want to have a nomogram, you can use this nomogram to select the dose based on the weight of the patient and the total number of the antral follicle counts that you have. When we choose to go ahead with the fresh or frozen embryo transfer cycle, the progesterone, if it is elevated on the day of the HCG trigger, which can happen in these. So when you have a higher number of oocytes, that time the progesterone elevation is in up to 16% of those patients. And this is also one of the reasons that fresh transfers will not be an ideal thing to do in such patients. For poor responders, so in this Cindy Fucker's document, which has actually taken into account a huge data and many studies, they have supported two things for poor responders. The first is the adjuvant androgens, DHEA or testosterone. There is a trial called T trial, which is coming. We are still waiting the results for those. The other thing, second thing that they have supported out of all the add-ons that we have is the adjuvant growth hormone. Please note that in selecting the patients for testosterone or DHEA, if you do testosterone and if the level is in the lower 1/3 of the normal range, that group of the patient benefits, others don't. Also, when we talk about growth hormone, the units that I have seen many people are using are much higher dose than what is recommended. If we see many studies, they have used 1 or 2 units. If you see the large studies, they are based on that dose. But we see some people are using 8 units, 16 units very often, and there is a complication when you use growth hormone. If the familial history of cancer is there and if the patient develops cancer or things like, so there are side effects when you use growth hormone. So please be judicious in your dose, which you can explain in the court of law. This is the T transport prospective RCT. Now, this is very interesting. They think that giving androgens to the poor responder might improve the outcome. So 60 days of 1% testosterone gel, then they do the agonist long down regulation protocol with the HPHMG 300, and the results are awaited. We have two things. One is follicle output ratio, which is basically the pre-ovulatory follicles with respect to the antral follicle count, the percentage of that. And the other thing is the follicle oocyte index, which is the number of oocytes that we get with respect to the antral follicle counts that we saw earlier and the percentage, so multiply by 100. So also we have an ART calculator, which says that with increasing age, obviously this is no brainer, which with increasing age, we need higher number of oocytes to be able to get one euploid embryo. This is the same thing explained. There are 3 theories. So I'm coming to, so probably the future might be dual stimulation. And for that, I'm just going back in the physiology. In the Fertility Sterility last month's journal, the first article is on that. This is the article actually. There are 3 theories of antral follicular development. The first is, so if we go back and forget everything what we were told in the classroom for gynecology, how menstrual cycle happens. So the whole theory is probably changing now. So the first theory is there is a continuous recruitment theory. It's only because of one follicle, when that sets the pattern, because that suppresses the other. Otherwise, there's a continuous recruitment theory. The second is the single recruitment episode theory. I'm not going into detail for this. And the third is the follicular wave theories, that there are the waves of follicles which come. It's not continuous, but there are waves. So it could be 2 or 3 waves. And if we see, this is a very landmark paper by Dr. Filippo Baldi, and he has talked about the dual stimulation. And the conclusion is the stimulation with an identical protocol in the follicular phase and the luteal phase of the same menstrual cycle resulted in a similar number of blastocysts in patients with reduced ovarian response. The luteal phase stimulation statistically significantly contributed to the final transferable blastocyst yield, thus increasing the number of patients undergoing transfer per menstrual cycle. I want to focus, this is not to make sure that we get many embryos in one cycle for all patients so that the patient doesn't run away. That is not the concept. The concept is why we do not choose another cycle. We choose the same cycle for the luteal phase and not the second cycle, because the prolonged estrogen priming that happens for that set of follicles gives us a better harvest of the oocytes in the second phase, which is the luteal phase. This is why luteal phase harvest is preferred to not have missed rather than going for the second cycle. Works very well for cancer patients. I work currently in a hospital which is attached to a Apex Cancer Institute, and we get a lot of cancer fertility preservation patients. When we talk about PCO hyperresponder, so we are dealing with this biochemical factory, which is differently working than a normal responder. There is an ESHRE guidance which says COC pre-treatment is not recommended. It decreases the live birth rate. The antagonist cycle is recommended for the safety, not necessarily for the better outcome. Recommended both REC-FSH and HMG, both are equivalent. Not recommended to adjust the doses between. So stick to the same dose. Don't increase the dose. If it doesn't recruit, it usually takes a longer time. So that's fine. You'd stay with the same dose. Routine use of metformin, not recommended. There is a place for metformin. I'll come to that. E2 monitoring is not mandatory, although actually we do. So recommended to promote the use of the agonist trigger and consider freeze-on. We know the segmentation thing in which we follow the 3 points, which is antagonist cycle, agonist trigger, and freeze-on. Place for metformin is this: when the patient is glucose intolerant, insulin resistance is documented, obese, more than 35 BMI, CC resistant, previous history of hyperstimulation or miscarriage. Also, whenever a patient is on metformin, please make sure either they have non-veg diet or they correct B12 levels. Coming to this very important point, how much time do I have now?
Ma'am, just a few minutes now, maximum of 2 minutes.
Okay. So I have, let me know if I can overshoot for another few minutes. Letrozole and CC, I will skip the things. I will just summarize this whole thing to say that CC has a very major role, and please consider letrozole as the secondary alternative. Otherwise, ESHRE does recommend first line in PCO patients. Cochrane review has changed their update in which they're saying that the miscarriage rate and the OHSS rate is not a reason to go to letrozole, because they've removed the low value studies out of the whole Cochrane database. How thick is too thin? Please do not cancel an IUI cycle when you see the endometrium is very thin, because in IUI it has more time till the embryo comes and implants. I'm just coming to the main slides because I want to focus and use the time for them. Oocyte donors. In oocyte donors, there is a double whammy because of which we do not get good eggs sometimes. Most of them are put on the OC pills, and then we give agonist trigger because we do not want them to hyperstimulate. Agonist trigger needs a good level of LH, which doesn't happen when we have given OC pills. That's why the oocyte harvest is not good. So if you're using agonist trigger, please do not give OC pills pre-treatment to donors. This is one point I wanted to say. Then there is this one slide I would want to show for the mild stimulation, in which the biological efficiency is known to be higher in the mild stimulation as compared to the stimulated follicles. There is something called as needle-free IVF, which will happen when we get oral antagonist. And in that case, you can give CC and follow it up with the oral antagonist tablet Elagolix, and you can save your patients to go ahead for any needles. There is a unit in New York, New Hope unit. They are actually already doing that. The other thing is same thing, actually, the same antral wave theory. I've just put this paper here to focus on this point, that this theory has been around since 2011. Although ASRM has taken this as a very prime topic in the latest journal. Coming to trigger, I would just follow, I'm skipping slides and focusing on the main slides. Dual trigger is a very important thing for the poor responders. And these are two papers. This is the first and this is the second paper. And the dual trigger for poor responder with the dose of HCG 6,500 combined with the agonist 0.2 mg triptorelin is thought to give more mature eggs. So what is future? Karyotype mapping is the state-of-art genetic analysis strategy used, which is the latest to do the genetic analysis of embryos before we transfer them. Printing a 3D ovary, which is a bioprosthetic ovary. This work is being done in the Northwestern University. 75% young adults who are childless at the time of diagnosis have a desire to have a child. Survival of cancer patients are increasing. 7 in 8 children with cancer will survive, and they will come to you as a patient and they will ask they want to have a child. Ovarian tissue auto transplant is another thing in which basically the work is, it's a 3D printed scaffolding in which they seed the harvested follicle and they give a structure to the ovary so that the ovulation can happen. Another thing on the male side is that we have Sherman Silber working on the sperm cells from the skin cells. So the fibroblasts, which are the stem cells, are further differentiated. They are not de-differentiated into the progenitor cells and the primordial germ cells, incubating stem cells with 4 commercially available genes helps them change the lineage. And then so much pressure that the nucleus. So coming back to the beginning, when I said that there is a physical pressure, actually, that pressure has to be so high that the nucleus starts rotating, if we see in the electron microscope, and that keeps the cells in an inactive form, and that increases the longevity of any gamete. This is the work being
Dr.
done.
Chavla, may I request you to
this is the last slide.
Kindly close your
this is the last slide. So this is one very interesting thing for the poor responders being done. Spindle nuclear transfer on the poor embryo transfer. So in UK, HFEA has licensed one group, and we are waiting for the live births. But Nuno Costa Borges has already made a registry in Greece, in Athens, and they are working on this, and it's the way to go. So the next, I think, dual stimulation will be very highly used, and along with probably this application. Thank you, everyone, and please share any feedbacks, and thank you. Have a lovely day.
Thank you, Dr. Anu. That was a very comprehensive lecture, starting from mild stimulation using CC for IUI right to more advanced form of treatment in ART. So I think you have practically covered all the topics related to IVF and ART treatment and ovulation induction in a short span of time. So, and just one question, in cases of poor responders, what pre-treatment do you prefer? Is it with DHEA or the testosterone gel? And do you routinely give growth hormone in these patients? And between HP, HMG and REC FSH, which is, what is your preferred gonadotropin in poor responders?
So the pre-treatment, have you asked me specifically for DHEA, or are you just generally asking me?
Generally asking you. For pre-treatment for poor responders, what is the treatment that you prefer in?
So I always avoid the pre-treatment OC pills.
Yeah.
I hate OC pills personally. I have always been not happy using OC pills as pre-treatment, and I've never done that. And in the unit's protocol, because of COVID, we have put norethistron as a pre-treatment for the pure reason of the convenience of the nursing team, because they do it.
Okay.
If I would if I would make a decision, I would use either no pre-treatment, or I would use estrogen as a pre-treatment, especially in a case of an older patient with poor response documented in the previous cycle. I would go for testing of the androgens, and if they lie in the lower 1/3 of the normal range, then I will give DHEA for 2 or 3 months.
All right. And
at the same time, if the AMH is too low, I would not waste that time. I would at least do one IVF during that course also and continue DHEA if the AMH is drastically low.
Okay. And between HP, HMG, and REC FSH?
So honestly, we do use REC FSH. We use REC FSH very often, but my needle is moving towards HP, HMG more than earlier.
Thank you, ma'am. Thank you for a wonderful talk, and thank you, Dr. Niranjan sir, for this opportunity.
Thank you, Dr. Anu. It was a wonderful presentation, and spending the valuable time with us from UK. We have got Dr. Rishikesh Pai here, and all the dignitaries who have come from abroad. And it's a pleasure that we are all meeting, but virtually we are just meeting. I remember the last time we had all met in SR Hyderabad conference, and we had a great time. It's been more than 6 months, but thank you for being there with us. And it was wonderful to have you. We have got more than 2,000 audiences listening to you. Thank you so much. Thank you, Amrita.
Thank you. Good luck. Okay.
Now I would like to call upon my friend from Indonesia. He is on the board of APEJ, and it is none other than Nandi Rachman. And we had last met, I think, in Surabaya, Indonesia, probably 2 years back. And obviously we had met before also when you had come for AAGL. This world is small, and I requested Nandi to be there with us. He has one more program which is going on in Hong Kong right now, and he has taken exclusively his time out to present his presentation. Thank you, Dr. Nandi, to be with us, and I request Dr. Rohan Palchetkar to start the proceedings of the moderation. I would like to introduce Dr. Rohan. Rohan is an associate professor at Padma Shri Dr. D.Y. Patil School of Medicine. He is an IVF consultant at Bloom. He is the joint treasurer of Maharashtra chapter of IAG and the managing committee member of MSR. He has edited many books. One of them is The Smart Obstetrics and Gynecology, co-editor of MOGS Manual of Labor. He has been convener of various programs, and now is a member of the managing committee of Mumbai Obstetric Gynaec Society. He is also the first runner-up of Foxy Korean Award 2018. I hand over the mic to Dr. Rohan Palchetkar to start with this proceeding.
Thank you so much, Dr. Niranjan sir, for including me in this program. Without taking too much time, I'm going to immediately introduce Dr. Iknandi. Dr. Iknandi Arif Rahman is the course director of the Indonesian Gynaec Endoscopy Society, KAMIG. He's the Indonesian Society of OBGY Task Force for Endoscopy as a treasurer and secretary from 2009 to 2015. He's also been the board member of the International Society of Gynaec Endoscopists from 2014 to 2018. He's also been the vice chairperson of the Young Up-Age Group Committee from 2014 to 2018. He was the president of the Indonesian Executive Board of the German-Indonesian Society for Minimal Access Surgery 2018. He was the vice general secretary of Up-Age in 2019. So Dr. Iknandi will be talking on scarless surgery for Gynaec endoscopists. Sir, over to you for your talk.
Thank you so much, Dr. Rohan, for the nice introduction. Thank you so much, Dr. Niranjan, for having me here. Thank you, everybody. Nice to see you all. So, in this FEMAS webinar, Dr. Niranjan has asked me to bring the topic about scarless surgery for gynae endoscopy. So, we were going to talk the scarless surgery for gynae endoscopy. So the objective is we need to understand that the original scarless surgery in gynecology is the vaginal surgery, but mostly the urogyne working on a decent uterus. Uh, and then we need to recognize and then to understand the combination of the vaginal procedure and combine it with the single port laparoscopy setup so we will have no scar at all. And then the setup should be designed to optimize the efficiency using the TIM concept. So talk about the history itself. It was the vaginal route has been used for endoscopic procedure back since 1901 by Dr. Ott, and then it was followed by Emmanuel Claston that doing the colpolaparoscopy in 1937. But it was Decker in 1940 who performed the coldoscopy, and then followed by Diamond who published a personal series of 4,000 outpatient procedure of diagnostic coldoscopy in infertility. And then back in 1998, it was introduced by Dr. Stephen Gortz, the transvaginal hydrolaparoscopy or the transvaginal endoscopy, and also followed by fertiloscopy by Dr. Anton Waterloo. As for now, the transvaginal endoscopy and the fertiloscopy is the only vaginal nodes in office setting. And then for the fact it is still used by the Indonesian Army Central Hospital, the Indonesia is more like India. Most of the people are barely hanging on the government support, and then not everybody are able to pay for the laparoscopy. But for us who work at the infertility, we need to have something for them who cannot afford laparoscopy. And then since the last 5 years, we've been doing combining the transvaginal endoscopy and hysteroscopy for those with an unknown fertility but not able to pay for another effort. And then the history of nodes itself, it was most developed by the surgeons. It was first in 2000 by Anthony Callow. He performed the transgastric approach for liver biopsy. And then Gatman is also performed the transvaginal nephrectomy in 2002. And then it was Rao and Reddy from India who performed the first human transgastric appendectomy and tubal ligation in 2004. And the surgeon also formed the No Scar Association, the Natural Orifice Surgery Consortium for assessment and research in 2005. What about in gynecology? So Zoran has performed the transvaginal cholecystectomy in 2007, and Bronco doing the nephrectomy in 2008, and then Kondo who performed the first tubal ligation in 2009. And then why do they love nodes? Because the transvaginal nodes, we have no abdominal incision, we have no scar, we have no hernia, and then no wound infection. And then with our patient are female, the cosmetic effect is really, really important for them not to have any scar at all. So in gynecology itself, it was the Changgang group by Professor Chilong Lee with his student Xu Shen, who performed the transvaginal nodes in the adnexal procedure. They performed tubal sterilization, self-injectomy, ovarian tumor enucleation. They also performed the hysterectomy, and then they also performed the transvaginal nodes myomectomy. And then they also performed the transvaginal node surgical staging and went published in 2014. And then they also issued some writing about it in the journal, and they have combined it with laparoscopy. We have the same complication rate with laparoscopy, but with less operation time. And also regarding pain, there are also many journals already stated that the pain from the transvaginal nodes is lesser than the one in laparoscopy. So I know that my good friend Anthony Shaw has been showing you about the single port. Now what I want to show you is the difference between the vision of the single port with the vaginal nodes. You see, in Singapore, what you see is a very wide abdomen, and then you need experience, and then the chance of the instrument colliding are larger compared to the one if you're doing vaginal nodes. And then sometimes you also need a curved instrument, which is unfortunately for my country, curved instrument is a very niche thing. I only use it in my private setting, but in my government setting, I cannot have it. It was too expensive. And then for vaginal nodes, you can use the normal, the normal state instrument without having obligation have to change it to another curved instrument. So the OR setup should be like this. It's better to have two monitors, but if you only have one monitor, like most of my fellow does in a more remote places, they just doing one monitor is on this side. Okay, there is some animation from the A page regarding the node hysterectomy. So we are from the nodes group already encourage people if you want to perform less surgery, no scar surgery, the first important step that you must perform is a vaginal node hysterectomy. If you master the technique of it, then you will be able to move forward into myomectomy or tubal recanalization or cystectomy. So the point is we put the wound retractor inside the vagina, open the top of the vagina, and then do the hysterectomy reversely. And then afterward, it's done. So if you want to perform no scar surgery, you should perform vaginal nodes for the first procedure. So it starts like a traditional vaginal hysterectomy with a posterior colpotomy, and then you can perform continuously with anterior colpotomy under the scope or without the scope. So since I'm not based on urogyne, so I cannot perform anterior colpotomy without the scope. So I usually put my scope in. So after I put the wound retractor in, then I perform the anterior colpotomy under the scope. Yes. And then afterward, after you put in the wound retractor, you can put a gauze, and then you can put the port. If you don't have any port, you can just use the glove over the wound retractor and just perform the operation. So the first thing to do, the most important thing to do, if you're doing vaginal hysterectomy, nodes vaginal hysterectomy, you should take the skeletonizing of the cervix right at the junction. Why right at the junction? Because after the junction, there's a vesico-uterine space, which is a vascular. And then, if you want the technique not to be bleeding, you should avoid the bladder pillar. See, as you can see in here, I spare the bladder pillar, which is consists of much vascular, and then I take out the lateral side. You also perform the same way with the posterior side. What you need to do is you need to make sure that you start the vaginal incision right at the junction. So it will keep the length of the vagina the same. And then rookie mistake is to perform the vaginal the skeletonizing from here, which will be more bleeding, and then it will shorten the vaginal length itself. And then afterwards, what you need to do is you need to put the retractor in. So you usually start from below. You put the posterior side right over the sacrum, and then you just push the upper side with your longest finger. In my case, my longest finger is my middle finger. Sometimes if my index finger cannot push it over the symphysis, I push it with my longest finger. But what happens if you cannot put in the wound retractor over the symphysis? no worries. After you perform the vaginal notes, after you over the learning curve, you will be able to avoid all the vaginal procedure by just simply doing a total notes, which I will explain later on the later slide. And then after you put the inner ring, you will push the second ring towards the vagina to fixate it, the wound retractor, so it will be stable and firm. And then the port that I'm using here is the port that available in Indonesia. It's very cheap, and then it's quite usable for like 5 or 10 operations. And then one of the things that the most people are afraid, how to avoid the bowel injury. To avoid the bowel injury, you need to put in the gauze. As you can see, I always told my fellow to put a thread around the gauze so it will be easier to retrieve it after the procedure is finished. Then, afterward, you will apply the port. So, this is the basic principle for doing a vaginal node surgery. The same principle will be applied to any kind of vaginal node surgery, even though it's myomectomy, even though it's a hysterectomy, or even though it's an ovarian torsion. So, as you can see here, if we perform the vaginal node hysterectomy with the gauze in, the gauze will be able to hold on the involuntary movement of the bowel, so it will be safer. And then to perform the anterior colpotomy, under the scope, you just see the sign of the wave sign, which is come out, the result as an air coming out from below and then goes on top. So if you perform this, you are so sure that there is no adhesion at all behind that. And it's really helpful if you're already making it to another bigger case, like a bigger uterus or with on the patient with a previous history of laparotomy and C-section. See, after you penetrate the peritoneum, you just widening it, and then it will be fine for you to be in the peritoneal cavity. So this is some landmark that you need to see. This is the vagina. This is the anterior ligament, uterus. The wound retractor is here. Cervix is here. So it's quite easy. And then afterward, you just perform the hysterectomy. As you can see, already cut out the cardinal side over the right side of the patient. And then I'm going to take out the uterine artery. And most of the process is bleedless. And then it will be better if you can use the smart bipolar. In Indonesia, unfortunately, most of my fellow, they don't have the luxury to use the smart bipolar. So we just using it, the normal bipolar, and it will be fine. The difference is only the time of operation. Should be about 40% faster if you're using the smart bipolar. As you can see, this is very safe. The gauze is protracting the bowel. Then you can see everything so clearly, and then taking out the uterus. And then after you finish with the right side, you just go to the opposite side and then perform skeletonizing the uterus in the same way. As you can see, the operation is pretty much bleedless. This is one of the very simple case that I use for teaching, and then you can see this very nicely. And then you can use the body of the uterus itself to protect all the bowel from the involuntary movement. So if you can utilize the body of uterus, you just need to move the gauze and then goes in like also. Okay. And then afterward, if you finish with the other side, you move back to the other side and you just take the round ligament, and then the uterus will be off. See, just move the gauze and then everything will be fine. So I just speed up the things a bit. So what you need is just a wound retractor. So in Indonesia, we use this. In Indonesia, mostly we reuse everything as long because I'm working in the government hospital, the Indonesian Army Hospital. Mostly in the government, we reuse everything. But contradictory, when we started the operation at the private sector, we use everything brand new. So one of the learning curve is to teach your fellow how to move things in the vagina. As you can see, this is I already asked one of my fellow to taking out the tube. As you can see, the movement is different, but it will be more exercise. It will be better for you. So what about suturing? Once you master the vaginal node hysterectomy, this is one of the cases when my fellow doing it and she got a bowel injury, so I need to step up and then perform the suturing. If you use ipsilateral setting in laparoscopy, it will be the same setting. And then the difference is you sit nicely tight and then you just use your ipsilateral movement like this. It will be very fine. So there is no hassle at all to suture in the feed nodes. Also, it's much better job to suture in feed nodes compared to the single port. So this is uh, I bought a video from my good friend Juan Liu from Guangzhou. This is She is a urogynecology, so she performed all the anterior colpotomy from the vaginal procedure. And then after you perform the anterior colpotomy, you just put the wound retractor inside and then take out the myome like so. And then afterward, using the barb suture, you just suture. I've shown you the suture with a normal thread, and this is the suture for myomectomy. It will be easier. Also, in infertility, you can also perform a node cystectomy. As you can see here, this is from Shushan. We're doing this from the posterior colpotomy. So after you put the ring inside, so unlike the vaginal hysterectomy, which you try to put the wound retractor inside after you put the colpotomy anterior and posterior, or you can do the other round under the scope. In cystectomy or myomectomy, you only perform one colpotomy. It depends. Usually, if it myomes on the upper side, you can use the anterior colpotomy. If you have a myome or cyst, you usually using the posterior colpotomy. Yeah, and then since the movement is very different from single port, you can see the colliding of the instrument is not as much as the one when we doing the single port laparoscopy. And then for a patient, especially in fertility patient, if you perform cystectomy like this, and then with a transvaginal nodes without any scar at all, it will be very happy for them. And then this is also another case with the ovarian torsion. So this is another video also from Shushan. This is another example of the ovarian torsion, but it's just the same basic principle with the cystectomy. You just skeletonizing it, and then you taking it out, clear it up, and then you try to reposition the torsion, and then put everything back together. See? It's very easy, very safe, and the patient can live Usually, after vaginal nodes procedure, the patient go home the next morning. So, what does it need to be successful in scarlet surgery? First, you need to find a good foundation in vaginal surgery. You have to know the anatomical landmark, and then you also have to obtain the hand-eye coordination when you have it during the conventional laparoscopy. And then, for my experience, I've been teaching the vaginal node for the last 3 years. It will be better if we teach the person to perform the single port first, then move on to the vaginal surgery. On the Indonesian experience, if you directly teach them how to perform vaginal surgery, the result is not very good. Maybe it depends on our curriculum. In our curriculum as a gynecologist, during our register, we don't have any much chances to perform vaginal hysterectomy at all because you have to compete with the trainee of urogyne to do it. So most of us don't have any experience doing it as a general gynecologist. So we have the group, what we call the vaginal nodes group. It is on a Facebook. You are more than welcome to see us here. There are many operations for us. And then I know that the Indian notes is already developed by my friend Suyash. Okay. And then if I can use doing it and I teach all my fellow in the my colleague in the army hospital and then all my fellow from all over the island, as you can see, we just use whatever we have because this is Indonesian, not like in Europe when I used to study, everything is there. In Indonesian, you need to be creative if you want to perform. I see Dr. Niranjan nodding. Yeah, this is the difficulty that we are having in the developed country. So prepare a good hemostatic device. A smart bipolar is not needed. Mostly, if you have a normal bipolar, it's okay. Start on a simple case. Try to avoid the adhesion, narrow vagina, or obese patient. Try to be bleedless doing the skeletonizing the cervix. Always look for the wave sign. Put the gauze. It will make your life easier. So, for a take-home message, that vaginal nodes is a marriage between vaginal procedure and single port laparoscopy. Basically, the patient has the benefit of scarless procedure, less blood loss, and possible shorter hospital stay. So by incorporating it, it will overcome its limitation. Whatever you do in vaginal surgery, you can do it in the vaginal nodes. And to achieve that, you need to take a learning curve. Okay, thank you so much for the chances. Back to the moderator, Dr. Rohan. Thank you so much, Dr. Niranjan.
Thank you so much, Dr. Iknandi. It was a wonderful talk. I loved how you started off with the history going into it. And the best part about your talk was talking about the tips to have a successful V-node surgery and the learning curve that's involved in it. So thank you so much for giving us such an in-depth outlook of V-node surgery. Thank you so much, Dr. Ratna.
Thank you.
Dr. Niranjan?
Yeah, I'm really awestruck by the presentation, and you have shown ovarian cystectomy, ovarian detorsion, then myomectomy, vaginal, hysterectomy, and the way you have said and the procedure. We look forward to call you back again for our course of high grad as per your convenience, and surely the audience are enjoying. Vaginal hysterectomy is being pioneered by Indians. I would like to take the names of our great gynecologist, Dr. Purandare, N.A. Purandare, who was the FIGO president, and we had also Dr. Shirorkar, and of course now the lineage has been passed on to the younger generations, and really this is something we have been aware of, but only when the borders are now dissolved and now we can meet quite often rather than once or twice in 2 years or once in 2 years. This is going to be a really nice joining of hands. I like that symbol of Garuda And Indonesia and India, the names are quite familiar.
Yeah.
And Rama, Sita, Lakshmana, and all those cultures have gone together. So really, I appreciate your efforts, and I don't want to take much of your time because you have been waiting to go for an operation. But surely,
Yes.
there are many people who have applauded and seen your procedure and the presentation. We look forward to you. There are many speakers which are there, and there are many faculty members who are really appreciated your efforts to teach V notes, and we will do that course in the future. Thank you so much.
I think Niranjan,
Thank you
one
so
thing
much.
I would like to say here that you have to, as you are one of the pioneers here in teaching in Sion Hospital, I think that you need to call him down to India to demonstrate it in our teaching institute, and it will be a landmark first workshop for our country as well. So you as well as Rohan is at DY Patil, and both of you should do it and be, I think, the pioneer this technique and promote it in India.
Amazing. Thank you for your blessing, sir, and for giving your permission. And Rohan, we will work on that.
I think there's one more person already in India who is doing it. Is he around also here? Someone you mentioned who is doing it in India already, because I see him on the Facebook. I forget his name.
I think Dr. Suyash Naval, I think.
Suyash is doing it. Yeah.
So, I always
Suyash is
wondered
doing it
what
now.
is he doing? What is this vaginal loads? But like now I got some idea today as to what exactly it is. Good. I'm really happy that you young people are doing such landmark work. Congratulations.
Thank you.
Sir. Thank you.
Thank you, sir. Thank you, Nandi, for giving your
Thank
valuable
you.
time.
Thank you so much, Dr. Niranjan.
Thank you, Rohan.
Thank you, Dr. Rohan.
I also wanted to say that Dr. Anu's talk was also very good and well researched, and I think that we have learned a lot from her today also. I feel we keep on learning. Every time I listen to a lecture of a person, I keep on getting more and more knowledge, and I feel that I'm more and more ignorant about everything. So, Niranjan, this is not good for my self-confidence. Every time you have a program, I feel more and more illiterate.
No, sir. No, sir. I don't agree. That is your humbleness, and that is your, quite to be simple. But we know, sir. We have heard your lectures, especially I have heard your lectures. Sorry, Anu. Please.
The ground on which we all stand.
I completely agree. He's one of the people who we can always go to whenever we're stuck with anything.
Thank you, all of you, for this compliments, and I wish all of you all the best.
Thank you.
Thank you, Dr. Limbachia. We welcome Dr. Limbachia. Thank you so much. And I call upon Dr. Hanuman to be there moderating this session. Dr. Ramakrishna Hanuman is MBBS MD. He has presented various papers in various conferences of India, 30 publication, recipient of the Wonder Foxian Award of 2019, received 20 prizes for best paper. He's a visiting faculty to 6 medical colleges, and he is teaching endoscopy as an associate professor. He has established the Sankar Laparoscopy and Infertility Center at Chirala. Chirala is a very small place, but he has performed in this small place with many fellows, more than, I can say, 200 fellows, and I found him there to perform more than 7,000 endoscopic surgeries since last 2 decades. He has also a Foxy recognized course in endoscopy and has trained more than 100 gynecologists, 500 plus presentation. Dr. Ramakrishna, without much ado, I request you to please call upon Dr. Deepak sir, and we will proceed with the next proceedings.
Thank you very much for those kind words, Dr. Niranjan. It's my pleasure to be associated with you all on this webinar. And I also see Dr. Rishikesh Pai. I don't know whether he remembers me. We met way back in 2001 at Hyderabad on optimizing IUI and ART.
Yeah, I remember. Yeah. Hanuman, yes.
Yeah, conducted by Dr. Kiran Shekhar, sir.
Right.
And I thank you all for giving me this opportunity. Okay. I introduced Dr. Deepak Limbachia. We all know him. He had been to our APCOG state conference and he has performed surgeries when he had come down to Khammam. And he's a great surgeon. and he needs no introduction. I think if you see his endoscopic career, he's one of the best, and I have seen him operating. And he has done a lot of laparoscopic procedures, laparoscopic myomectomies, and he's a pioneer in doing endometriosis. And also, you should see him doing a lateral pelvic wall dissection. So I had the opportunity to watch him so many times at so many conferences, and without much of wasting time, I introduced Dr. Deepak Limbachia for the audience. Dr. Deepak, you can carry on with your work.
Hi, thank you very much, Dr. Hanuman, for kind introduction, and hello, Dr. Niranjan, and my best wishes are always there with you. And I've given the very good topic, that is laparoscopic management of the endometriosis. Can I start my screen sharing?
Yeah, it's fine. You can start, sir.
Okay. Sure. Okay. So the topic is laparoscopic conservative endometriosis surgery with the resection anastomosis for the deep infiltrating endometriosis over the rectum. And the bowel and colonic involvement, GI involvement in endometriosis, the incidence lies from 3.8 to 37%. It starts from the serosa and many times invades through muscularis. Rarely it affects the mucosa. The incidence is a rectosigmoid involvement, that is a 90%, rectum and ileum 12, appendix 8%, while the cecum 6%. Surgical versus medical management. I prefer surgery is the best option. And modalities of the management, there is a saving excision, disc excision, and a segmental resection and anastomosis. So when there is when we need to do shaving excision, then in the most conservative manner, progressive layer by layer removal of the deceased bowel and restoration of the normal anatomic architecture without entering the bowel lumen, recommended for the lesion below the sigmoid colon. Disc excision is required for the less than 3 centimeter tumor and involving less than 1/3 circumferential of the bowel and the mucosal involvement. We need to remove full thickness of the diseased part of the bowel. RA required for the more than 1/3 circumferential, more than 3 centimeter lesion, or multifocal lesion or the obstructive lesion. Now I'm going to present the video with the case scenario. She was a 34-year-old lady. She presented with a severe dysmenorrhea with the menorrhagia over since 6 months. And she had a severe backache with the bilateral radiating lower limb pain since 5-6 months. And on radiological findings, she had endometriosis with the endometrioma with the colorectal nodule. So we planned the laparoscopy. So this is the first endo you can appreciate. This is a severely adenomyotic uterus and a bilateral ovarian endometrium, and the fallopian tube travels from here to here. And the pouch of Douglas was totally obliterated with the sigmoid colon and the rectum here. So I prefer to start first deflating the ovary so we can get the adequate space to work there. And first deflate the ovary and start from normal to the abnormal area, that is from the pelvic brim, that is a usually not affected area, and I entered retroperitoneally, and here we can see that ureter is here. So once we see the ureter, we need to work on the medial surface of the ureter, lateralize the ureter by working on the medial surface of the ureter till it's under surface of the uterine artery. Then if you go medial to it over the sacral promontory, you can make it out the inferior hypogastric nerve. This autonomic nerve should be preserved. So we work over this nerve. Pulling the nerve on one side will give a retraction on the opposite side. This is a retrorectal space. Here I am working, as she had a severe backache with the radiating lower limb pain. And here I am approaching toward the hypogastric fascia. And see, again, I am lateralizing the ureter by working on its medial surface and going deeper down for the pararectal space here. And this is a pelvic splanchnic nerve. that makes a plexus with the inferior hypogastric nerve.
Dr. Deepak, sorry
Yes.
to interfere. Your
Yeah.
videos are not clear. Can you make them a little bit clear?
No, we are giving. I am giving a pause to demonstrate it. It's a stop right now. Is it okay?
Yeah, it's okay here.
Okay. So this is a piriformis muscle over here, and you can appreciate the sacral nerve roots. From the sacral nerve roots, the lateral splanchnic nerve, pelvic splanchnic nerve, that gets origin. So we need to release this nerve when patient is having this kind of the pain. This is S2 and S3, but fortunately she had no involvement of the nerve in this segment. When you want to perform any kind of the radical surgery for the endometriosis or the oncology, you need to preserve the inferior hypogastric nerve along with the lateral splanchnic nerve. So first of all, I have isolated all these nerves and safeguarded all this nerve, and the ureter is also safeguarded on both sides. Retrorectal space is created. And now, am I audible there, Dr. Hanuman?
Audible.
Okay. So this space is created here, and this is on the right side. Piriformis muscle and hypogastric fascia overlies to it, and the sacral 1 nerve root, and this is S2 and S3. And if I go further below, I can make it out the S4. Now approaching distally to lateralize the ureter from the this all nodule, and ureter is safeguarded, and here you can appreciate all this lateral splanchnic nerve with the inferior hypogastric nerve and the sacral plexus is all safeguarded here. So all this work is done retrorectally. And see, this is the view. All work is done after lifting the rectum. And here I haven't jumped on the central part of rectum dissection. Now I started working on the central part of the rectum ventrally. And now this is mobilized toward the rectum. And here I can appreciate that more than 1/3 circumferential of the rectum is involved here. This is the posterior vaginal wall, and now once all our vital structure are freed, then I started doing peritonectomy, which is a diseased, and adenomyomectomy and excision of the all endometriotic nodule. So this is a right-sided peritonectomy, and this is a nodule which was overlying the rectum. This was being separated from the rectum and the colon. And here you can appreciate on the posterior wall of the uterus, there is this is adenomyoma. This is adenomyomectomy will be carried out. So the principle is to start from normal to the abnormal area, guard all the vital structures, that is the nerves, ureter, and rectum. Once it is done, you can remove all the diseased tissue. Now this is affected part of the rectum. Distal part is denuded of the mesorectum for the proper application of the linear stapler. And proximally, I take a stay stitch over here, so we can remove up. We can decide up to which part we need to remove. The distal linear stapler is applied. I check the mobility of the sigmoid colon up to distal part. For that, I dissected this inferior mesenteric artery area. In some cases, we need to take the inferior mesenteric artery for the tension-free anastomosis. I perform colpotomy to enter the anvil through the colpotomy and did removal of this diseased portion, and this is the opening of the sigmoid colon, and will enter stitches taken here for proper preparation of the donut, and all the fats are removed. Circular stapler introduced from below transrectally, and it's aligned with the circular stapler. Axis is checked for the proper alignment. So this is a anastomosis done. Bubble test would be done. This is a final endo view. Here you can appreciate this is a residual disease 0, the term what we use for the ovarian malignancy, and this is a 4 centimeter lesion in the muscularis of the rectum and approaching toward the mucosa. Here this is diseased area and this is mucosa. After that, this is most boring work, that is a cystectomy we do. Colpotomy closure is being done. And here you can see there is no residual disease of the endometriosis. That gives the best output to the patient. Thank you. Stop. Okay.
Oh, that was a wonderful presentation. And really, it is so good to see the entire anatomy like the Cunningham's manual. I don't think the cadaver anatomy would be so beautiful. I congratulate you on this.
Thank you.
Nice presentation. And I have a few questions. How do you prepare the bowel? And what would be your post-operative
I admitted the patient a day before, and for that we give a peglet to the patient day before. Pegleg or the liquid exolite.
I think.
Do you use any?
Yeah, Dr. Hanuman, he has answered your question.
Hello, can I ask a question to him?
Yes, sir. Yes, sir.
Yes, sir.
Congratulations, Dr. Deepak. You are a great surgeon. Now,
Thank you,
what
thank
I
you, sir.
want you,
Thank you,
all of you, I want to ask you one thing, that is, what is the follow-ups we are doing? Because many of the top surgeons in our country, we get, patients from all over the country. So how are you following them up? What are the post-operative recovery? Suppose we do cancer surgery, what are the recurrences? Is there any registry you are keeping? How are we doing how do we analyze our results? On table results, I can understand.
Yeah,
like
that is it. See, fortunately, none of my benign cases had no leak. In malignancy, in ovarian malignancy, there is a chance of the leak because the immunosuppression and many things are there. And in such a cases, we do the temporary diversion, like ileostomy or the transverse colon diversion. But in endometriosis, fortunately, there is no leakage, and the patients are giving lots of blessings after the surgery because they get relieved of the dysphagia and pain during defecation during menstruation. So that is a really good thing.
Great.
Yes, sir.
Good. Fantastic.
Thank you, sir. Thank you, sir.
I think I'll have to come now
Dr.
and
Deepak.
start learning from you again.
Hi, Anu.
Hi, Dr. Deepak.
Hi.
So you remember me?
Yeah. Same college.
We were together in college.
Yeah. BJ Medical.
Okay, good. Absolutely proud to see you doing such great work. Super impressed. Congratulations and good luck.
Thank you, Dr.
I think the webinar also helps to meet the old friends, I think, who studied together.
Thank you.
Yes, Dr. Hanuman, please go ahead. You had few questions.
Do you use any intra-abdominal drain tubes following the surgery because you have done such an extensive...
I keep drainage for till the patient pass the stool. And when patient pass the stool, on second day I remove that drain. That is a Romo EDK 28. And the patient pass the flatus within 24 to 48 hours and they pass the stool. within 48 to 60 hours.
What about this regular rectal dilatation, which has been
not required? Actually,
taught
when
in the
you pass
previous
that
days
circular stapler,
for all colonic surgeries?
no. When you pass the circular
Any
stapler,
flatus tube?
not required. Not required. Hello, there is some problem in network. When we introduce the circular,
What are the
when I introduce the circular stapler, at that time usually the lot dilatation happens, and I do not put any rectal tube in a endometriosis. Not till nowadays not required.
Okay.
Thank you, Dr. Hanuman. Thank you, Dr. Deepak Limbachia. Wonderful presentation by both of you. Excellent, surgeries which you have shown. And I take this opportunity to thank the moderator, Dr. Hanuman, Dr. Deepak Limbachia, to be here with us. And I would like to say we have crossed more than 2,142 users have logged in. They have spent Sunday whole morning from 10 o'clock till 4:30. We had 3 international speakers, Dr. Anu Chawla, Dr. Nandi, Dr. Anthony from UK, Indonesia and Singapore, and of course our own Indian faculty who were there. I would like to thank Dr. C.N. Purandare, the chief guest of this program, and the guest of honors were Dr. Adi Dastoor sir, who also sang a Elvis Presley song in the beginning, and he inspired us. I want to tell everyone that Adi Dastoor has worked as a secretary along with Dr. Nargesh Motashaw madam in IAG before he became the president. And you really have to work and understand the organization, and it was great to have him. Along with that, we had also our Iron Lady from India, Dr. Shanta Kumari madam, as a guest of honor. And of course, then we had lined up the most wonderful presentations from all over India. Dr. Rishikesh Pai began with his presentation, and this was followed by many others and moderated by luminaries and gems from all over India. It was a wonderful day today, all of us being together and spending time. I think Corona has changed everything in our lives, but still we are going to fight it. And above all, what a day it was. Dr. Rishikesh Pai has stayed from, I recollect, from 9:45 till 4:33 or 4:40 till the time we are here. And that is in spite of his busy schedule and being there on Sunday. And I can see Dr. Malvika Sabarwal.
Malvika is also there. Baba, Malvika is
I know Rishikesh is ignoring that,
Actually, no. It's very surprising. Dr. Niranjan is from Sion, and one of the first places where I had actually met Malvika was in a Sion hospital.
Absolutely.
Workshop.
Rishikesh, I even remember what I was wearing when I met you. Those were the
lovely friends I see. Oh my God! I in the meantime I don't want to hide, but I had gone to Patna and I was there for 1.5 hours hearing Dr. Hema Divakar's lecture, and Dr. Supriya Jaiswal had come from Patna to Mumbai. So it was just amazing. And probably
I welcomed you there also. I received you there, welcomed you there, and came back to moderate your session.
Nice to see you here, Supriya. Nice to see you like this.
Thank you. Thank you.
So it was great.
Sir, nice to see you.
Yeah. Hi, Supriya. Good. Nice talking to you and meeting you.
Yeah, thank you.
Rishikesh, I loved your talk as well. It was so
Thank
good.
you. Thank you.
Very nice.
So we have one video of the sponsorer, and I request the support to show it, and then we say tata, bye bye.
Deepak, are you there? You're muted. Deepak is muted. Anyway.
Deepak must be busy in operating some case.
Oh, he's very good. He's excellent.
Anemia cases. WHO estimates globally around 1/3 of all women of reproductive age are anemic. Also, 40% of pregnant women and children less than 5 years of age are anemic. According to National Family Health Survey in India, Around 53% women and 23% men aged 15 to 49 years and 59% of children below 5 years of age are anemic. Prevalence of anemia was higher among lactating women, followed by non-pregnant, non-lactating women and pregnant women. Distribution of anemia is skewed in India, majorly seen in younger lactating and older pregnant women. For conventional oral iron supplements, different formulations are available in the market. The conventional oral iron uses specialized transporter, divalent metal transporter 1 or DMT1 to enter the enterocytes, and ultimately reach the bloodstream. The bioavailability and absorption rate of only 10 to 15% has been reported. Iron intolerance is also commonly associated with these conventional oral iron supplements. A strong metallic taste from these iron formulations leads to non-compliance of iron therapy. Introducing, for iron deficiency, anemia, pregnancy and lactation, weakness and fatigue, to improve physical and cognitive performance in children and in childhood worm infestation. First time in India, Jictoco's liposuspension. Liposomal is designed by unique LDD technology and mechanism of absorption. The micronized ferric pyrophosphate are reduced to particle size 7 micron and encapsulated in phospholipid bilayer composed of sunflower lecithin. The micronized iron increases the surface area and bioavailability. Microencapsulation masks the metallic taste of iron and increases efficacy. Liposomal iron results in more acceptable and palatable taste of the iron supplement. With minimal adverse effects and enhanced patient compliance, it ensures targeted drug delivery. Liposomal iron when ingested reaches stomach with ability to withstand gastric acidity in the stomach. Liposomal iron reaches intestinal tract unchanged, hence prevents any GI side effects. Liposomal iron moves further into the smaller intestine where it is completely absorbed by epithelial cells via endocytosis. This leads liposomal iron to directly enter the liver through the lymphatic system, ensuring high bioavailability. In the liver, the presence of lysosomal enzymes breaks liposome layer to release active iron. Active iron moves from liver to the bloodstream where it is utilized as per requirement. Bioavailability of liposomal iron is 3.5 times greater than iron pyrophosphate and 2.7 times greater than ferrous sulfate. Clinical study shows liposomal iron significantly increases hemoglobin and hematocrit levels. Adverse effects were found much lesser in patients consuming liposomal iron.
Dr. Niranjan, you're muted, sir.
I would like to thank our sponsors, Oaknet, to give free registration to all of you. And that's how we could all join together. And thank you all of you to be present today. IAGE, that is Indian Association of Gynec Endoscopy. It's a premier institute and organization since formed in 1984 by Dr. M.N. Parikh and all the seniors, Dr. Motasha, Dr. Adi Dastur sir, and then later on we had past presidents with Dr. Rishikesh Pai, Dr. P.K. Shah, Dr. Prashant Mangeshkar, and Dr. Prakash Trivedi. We have these voting lines which are open till 15th of October, but I want to tell you only 55% of members have voted. So please vote, exercise your right and do the right choice and elect your and select your candidates who are standing and who you feel can run this organization. Thank you so much.
Thank you. Bye. Good night. Have a good day. Have fun on Sunday.
Thank you.
Thank you so much. Had a great time. Thank you, Niranjan.
Thank
you,
madam.
Bye. Take care. Bye, Rishikesh.
Bye.
Thank you very much.
Bye, everyone. Bye, Niranjan. Bye.
Bye.
Hanuman.
Thank you, doctor.
Bye.
Thanks. Have a good day. Thank you.